प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं भर्गो देवस्य धीमहि धियो यो नः प्रचोदयात्। ॐ भूर्भुवः स्वः तत्सवितुर्वरेण्यं
I extend my warm welcome to all the respected faculty, the delegates, and the staff that's there on this podium. To begin with, I congratulate all the speakers who have made it to be a part of EPEC and all the faculty members who have agreed to chair these sessions and give their valuable inputs. Today is the last day of EPEC. And in this journey, we have tried to cover many important aspects which are important for any postgraduate appearing in the exam. And in line with this, we have today's sessions, which will be focusing primarily on the endocrine system and some very miscellaneous topics, which can behave very mischievous when asked in the exam. And without wasting any more time, I would like to introduce the chairperson for our first session, Dr. Madhu Gupta. Ma'am is professor in the Department of Anesthesiology at ESI, Postgraduate Institute of Medical Sciences and Research. And ma'am's area of keen interest are obstetric anesthesia, pediatric anesthesia, difficult airway, and BLS and ACLS. We welcome you, ma'am. I request ma'am to kindly go ahead with the proceedings of this session.
Thank you, Nitin. Good morning, everyone. First of all, I would like to congratulate Team Ram Manohar Lohia Hospital for arranging such a good postgraduate program, which has a lot of academic activities related to them, then very well organized, always starting in time and all those things. And thank you for making me part of it, Nitin.
Thank you,
So
ma'am.
without wasting any time, we will start with the first session. First session will be taken up by Dr. Uma Hariharan. She is Associate Professor at Dr. Ram Manohar Lohia Hospital and Atal Bihari Vajpayee Institute of Medical Sciences, New Delhi. And her areas of interest are onco-anesthesia, palliative care, ultrasound-guided regional anesthesia, and advanced trauma life support. And she has also done FCCS in obstetrics. And she will be speaking today on total intravenous anesthesia. So Dr. Uma, over to you. You can start. And we will take the question answers after both the speakers are done with their lectures. Is that okay, Nitin?
Yes, ma'am. Yes, ma'am.
Okay. Uma, over to you.
A very good morning to all of you. I am Dr. Uma Hariharan from RML Hospital, and I am extremely grateful to my head of department and the entire team of EPIC for this excellent opportunity. And I am here to talk on a very important topic, and that is total intravenous anesthesia. This is an important topic for the postgraduates, as any of the agents may come up as a short note, or the procedure of TIVA itself can come as a long question. TIVA by definition is defined as a technique of general anesthesia for both induction and maintenance of anesthesia, wherein a combination of agents are given exclusively by the intravenous route, without the use of inhalational agents like nitrous oxide and the inhalational anesthetics. The exceptions to this rule include the use of oxygen, compressed air, and helium. TIVA has become extremely popular and practical in the last 2 decades because of tremendous improvements in pharmacokinetics, pharmacology, and pharmacodynamics of newer intravenous anesthetic agents. But the history dates back to 1656, when IV opium was given along with alcohol into a dog to analyze its effects. And later on in 1665 by the development of IV opiate for insensibility. In 1872, IV chloral hydrate was introduced in animals, and in 1905, Hedonal was introduced. In 1921, Daniel and Gabriel did excellent advancements in intravenous anesthesia, and finally IV pentothal was developed in 1936, which changed the practice of IV anesthesia, followed by development of several agents like ketamine and propofol, which changed the game forever. In 1996, remifentanil came into clinical use, followed by, in 1999, dexmedetomidine. TIVA is extremely popular and upcoming in these days. This popularity is mainly because of the avoidance of side effects of volatile anesthetics and reduced OT and environmental pollution, especially in areas where scavenging is not possible. TIVA is made possible because of the availability of short-acting titratable drugs with advanced monitoring devices to measure the depth of anesthesia. Newer pharmacokinetic models and development of various logarithms for target-controlled infusions have further propelled the development of TIVA. This is definitely a boon for the anesthetist working outside the OR environment, especially in limited resource settings. Of course, the cost factor is also a major concern. Advantages and disadvantages of TIVA are tabulated in this particular slide to make you understand why TIVA is becoming very popular these days. It results in comfortable induction with rapid titration of anesthetic effect and better maintenance of hemodynamic profile, rapid recovery, and hence a reduced post-operative anesthesia care unit stay, and hence therefore reduced hospital stay and hospital cost is a major advantage with TIVA. It can also be very advantageous in awake intubation and extubation because it results in stress-free anesthesia. Reduced emergence phenomena as well as post-operative delirium, especially in the elderly population, is a major advantage. Intraoperative wake-up is possible with the retention of amnesia, especially done in spinal cord procedures. Reduced intracranial pressure with these TIVA agents is advantageous in neurosurgical procedures as well as procedures where patients are having a raised intracranial tension. It also results in less oozy surgical field, which is a welcome change both for the anesthetist as well as the surgeon. It preserves the hypoxic pulmonary vasoconstriction and hence a better VQ matching with better oxygenation and ventilation. Some agents like propofol have anti-cancer properties and hence preferable in oncosurgeries. The disadvantages of TIVA are mainly because of the technical aspects related to the administration of TIVA, especially because of difficulties in venous access. This could be a possibility in frail patients or those pediatric patients wherein obtaining an IV access before giving anesthesia is a difficulty. Pain on injection, especially with agents like etomidate and propofol, especially in children, is another problem. We must understand that TIVA is irreversible after the intravenous drug goes in. Drug metabolism concerns and bacterial contamination of IV infusion is also a problematic problem here. Difficult to titrate the effect either because of under or overdosing of the drug is also a problem, especially if you do not have advanced monitors and training. Hence, all anesthetists giving TIVA must be trained as well as experienced in the administration and be well versed with all the pharmacokinetic models and pharmacokinetic principles of the various intravenous drugs. The cost factor of syringes, infusion pumps, infusion lines and disposables is also a problem, especially when we are concerned about the environmental effects of plastic waste. The problems of inhalational anesthetics are the major reasons for the popularity of TIVA, especially because these inhalational agents like nitrous oxide are known to cause distension of air-filled spaces in the body, and they are also known to cause environmental damage with depletion of ozone layer and increased incidence of post-operative nausea, vomiting. And the most important indication for TIVA, which is a problem with inhalational agents, is malignant hyperthermia susceptibility, in which these inhalationals are contraindicated. Of course, there are several emergence problems with inhalationals which are counteracted with TIVA. TIVA also has beneficial effects on all organ systems as outlined previously, especially in the central nervous system, where it results in reduction of intracranial pressure, cerebral metabolic rate and maintenance of cerebral autoregulation, and hence this is extremely beneficial in patients undergoing neurological procedures like neurosurgery, spinal cord procedures as well as interventional neuroradiology. In the renal system, it results in reduced ischemia reperfusion injury with reduction in AKI after cardiac valve surgery. In gastrointestinal system, it results in reduction of post-operative nausea, vomiting and hence reduced PSU stay. In oncological surgeries, several agents like propofol have anti-cancer effects and TIVA is linked with recurrence-free survival rate. In the geriatric population, it may be easier to titrate to the clinical effect by the intravenous anesthetic agents and helps reduce the risk of post-operative cognitive dysfunction and delirium. Post-operative pain is also reduced in patients who are given TIVA, especially when dexmedetomidine is used. But this we must remember that when we are giving remifentanil, post-operative pain needs to be taken care of. Cardiovascular system is also benefited in the sense there is reduction in inflammation after cardiopulmonary bypass with the use of TIVA. In immune system, propofol has several potential beneficial effects like acting as a free radical scavenger, antioxidant, anti-apoptosis agent, and anti-inflammatory agent. The indications of TIVA can be divided into patient-related indications, procedural or surgical indications, and others. Patient-related indications include malignant hypothermia susceptibility or MH risk, high PONV risk patient as calculated by the APFL score, patients having myasthenia gravis and neuromuscular disorders, and intolerance to muscle relaxant, and of course, patient choice needs to be given highest priority. Procedural and surgical indications include patients having anticipated difficult airway with both difficult intubation and extubation, and patients undergoing airway procedures. Tubeless ENT and thoracic surgery like laser procedures can be easily undertaken with TIVA. Neurosurgical patients, especially in those with raised intracranial pressure and volume. Intraoperative neurophysiological monitoring, especially in patients undergoing spinal cord surgeries or spinal column surgeries, TIVA is indicated. Now, procedural indication, which is very important, is the transfer of anesthetized patient between facilities both in the hospital and outside the hospital, because in these patients we cannot be carrying the inhalational anesthetic vaporizers, and TIVA acts as a great boon. The other indications include remote site anesthesia, especially in cases outside the operating room environment, reduction in OT and air pollution concerns, and daycare and ambulatory surgery like oocyte retrieval procedures and procedural sedation also call for administration of TIVA. Now, TIVA is an excellent opportunity for us to train the residents and the trainees regarding the pharmacokinetic and the pharmacodynamic principles of intravenous anesthetic agents, and hence this is a major important armamentarium in our teaching and training protocol. Of course, TIVA is a choice of drug for monitored anesthesia care. There are several TIVA agents which are used in modern day practice, starting from propofol, ketamine, the various opioids, including the latest one, the remifentanil, magnesium sulfate, and lidocaine, and other analgesics in dexamethasone, acting as adjuncts to TIVA, and of course dexmedetomidine. I will not be going into the detail of these agents, but suffice it to say that you must know all these agents, which will be dealt with separately in the drug section. Types of TIVA can be divided into those wherein we are securing a definitive airway with the introduction of the endotracheal tube, or maybe a tracheostomy tube which is already in situ. Without the endotracheal tube, TIVA can be given by putting in a supraglottic device, or without a supraglottic device with the use of nasal or oral airways. Sometimes TIVA can also be given without the use of any airway device, and this is especially followed in monitored anesthesia care or non-operating room anesthesia, or wherein anesthetic procedures are undertaken outside the OR environment. In these situations, we need to be extremely careful regarding the airway management and prevent loss of airway. TIVA is especially important because it gives a balanced anesthesia and completes the anesthesia circle with hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, and analgesia. There are several ideal TIVA agents which can be developed in the future, and one which I'll be just talking about shortly is remimabzolam. So ideally meets these features. The various features include rapid onset of action, rapid and predictable recovery profile, potent and lipid soluble agent with water solubility and stability in solution, and chemical compatibility with other agents and miscibility with other anesthetic drugs. There should be no risk of extravasation problems and non-absorbable by plastic infusion devices. It should not promote bacterial growth and should be devoid of adverse events and of course low in cost. Remimazolam is a new ideal TIVA drug which is a combination of benzodiazepine and opioid, sedative anesthetic, ester based, and it has the properties of both midazolam and remifentanil. It potentiates GABA receptors, but we must remember that it contains dextrin 40 which can cause severe hypersensitivity reaction. It is called a soft drug because it has self-metabolizing and organ-independent properties. The ideal dose is 0.075 milligram per kilogram and a context-sensitive half-time of 7 minutes, which is very favorable. There are several principles of TIVA which must be remembered before embarking on the administration of intravenous anesthetic infusions. First of all, adequate hypnosis must be ensured by complete understanding of the pharmacokinetic and the pharmacodynamic principles to ensure correct dosage for smooth induction and recovery, and use of adequate monitoring devices like bispectral index and entropy. We can also use a processed EEG monitor in these cases. Ensure adequate analgesia and suppression of reflex response, especially during intubation, surgical stimulus, and other high stimulating environments. Titration of remifentanil and alfentanil infusion to surgical stimulus and higher doses may need to be administered, which cannot be given by longer acting opioids, and hence these newer agents have been developed. And ensure continued post-operative analgesia when we know that the duration of action is short in case of remifentanil. Ensure hemodynamic stability with good monitoring as well as clinical evaluation, and sometimes you can consider hypotensive agents if BP is elevated, or the vasoconstrictive agents or inotropes if the BP is persistently low despite resuscitation. You must keep all resuscitation equipment and drugs ready in these situations, especially when we are working in environments outside the OR. Ensure adequate muscle relaxation and monitoring whenever required, and frequent neuromuscular blocking doses may be required when we are using propofol alone without opioids. You must understand that whenever these audits are done, like the NAP5 audit, the most important contributory factor for failure of TIVA or awareness in TIVA is due to inadequate education and training. And hence adequate simulation exercises and CMEs must be organized. Monitoring during TIVA is very important. We must note the clinical calibration of the patient before knife to skin by noting increments in effect site concentrations showing loss of response to shaking, loss of hemodynamic response of limb movement with vigorous jaw thrusting, and absence of tachycardia or bradycardia with laryngoscopy and intubation, and avoiding the neuromuscular block until lack of response to jaw thrusting is achieved. Excessive hypnosis is more problematic than inadequate depth, and a TIVA trainer pharmacokinetic software is available and can be used, which graphically plots 50 to 95% probabilities of lack of response to noxious stimuli. Titration of effect site concentration to patient response is most effective. There are several general considerations apart from using proper monitoring and equipment to administer TIVA. In this, we must enter the weight, height, age and gender of the patient and choose the correct pharmacokinetic model with depth of anesthesia monitoring, and adjust the dosage as per the response of the patient, and reduce the dose and target concentration in higher ASA grades, elderly and obese patients. Routine ASA monitoring is recommended, plus complete OT preparation is required in all these cases. The pharmacokinetics of drug infusions can be understood by remembering that plasma drug concentration is not only determined by the dose of the drugs which we are injecting, but also by the drug distribution, redistribution, excretion, metabolism, absorption and elimination of the drug. The onset and offset of infusion can be understood by a very important concept which is known as the context sensitive half-time. In addition to distribution and elimination half-life, context-sensitive half-time is the time in which the plasma concentration of the drug reduces by 50% by discontinuing an infusion. The context here is the specified duration of drug infusion. Decrement time is used for offset of drug action, wherein the plasma concentration must decrease by a percentage other than 50% at the end of infusion, known as decrement times. Effect site equilibrium, there is a lag or delay between achieving a specific plasma concentration and particular clinical response, and the time taken to equilibration is known as the rate constant. Clearance is also important as well as elimination. Now, this is a graph depicting the context-sensitive half-time of various agents. If we see this graph on the right-hand side, we can see that remifentanil has almost a straight graph, and this is very, very useful for us in administering TIVA. The pharmacokinetic models are several, and the most important one is the compartmental model, which is most commonly used, and the others include physiologic and hybrid models, which are used for research purposes. The compartmental models can be one compartment, two compartment, or multi-compartment, or more than 3 compartments. In one compartment model, this is too simplistic because the rate of absorption is neglected in calculation. At equilibrium, input is equal to output. This assumes that plasma concentration remains unchanged as long as infusion is held constant, and hence this is too simplistic for us to follow. In double compartment model, the drug is assumed to be distributed in 2 compartments, the first into highly perfused tissues, which is the central compartment, and then into less perfused tissues, which is the peripheral compartment, and there is a bi-exponential curve of distribution and plasma elimination phases. Then we come to the multi-compartment model, and the most common one which is used is the 3-compartment model, described by Gibaldi and Feldman. There are 3 compartments, C1, C2 and C3. C1 is the central compartment representing plasma or blood. C2 is the side compartment which is rapidly equilibrated, wherein there are highly perfused organs and tissues, and C3 is the slow equilibrating compartment which are poorly perfused organs and tissues like bone and fat. And there are several kinetics which are used to explain these multi-compartmental models. Target controlled variable infusion rate is a method of targeting plasma concentration by varying the infusion rate to match the changes in contributions from distribution and excretion as the duration of the infusion increases. TCI pumps are nothing but target controlled infusion pumps, which are microprocessor programmed pharmacokinetic models for different drugs which are given by TIVA. This is a major advancement because it maintains operator determined plasma concentration as per the effect site concentration and the target which is required. We have to enter the patient weight and the target concentration. An initial small bolus is given, followed by an infusion that is at first rapid and then slowed down as per the saturation of the peripheral compartment with the drug. Now, when we want a greater target site concentration, the pump again delivers a small bolus and then the target concentration is reduced as per the requirement. The physiologic and hybrid models, as I told, are mainly used for research purposes, and they describe the drug uptake in different tissues and require the open possibility to adjust to pathological state of the patient as well. Computer programming has greatly helped in the development of these models. There are several methods to give TIVA. It can be either a single drug or double drug or multiple drug combination depending upon the requirement and availability of syringe infusion pumps and other advanced monitoring devices. Single syringe technique with mixture of drugs can also be given. Continuous IV infusion can be given either through drips or by syringe infusion pumps, and the latest one, that is target controlled infusion machines and automated drug delivery systems or closed loop anesthesia delivery systems. The single syringe TIVA has only one syringe and a simple pump is used and is very useful for low resource settings or settings outside the OR environment. The manually controlled infusion pumps are very commonly used, and this can be given with single agent or multiple agents, with syringe pumps or with drip sets. And now the target controlled infusion, wherein an infusion controlled to achieve a preset drug concentration in plasma or effect site is administered. There is one popular regime known as the BET regime, developed by Kruger and Thymer, known as the bolus elimination and transfer regime, where the bolus dose is calculated to fill the central blood compartment and a constant rate infusion is set equivalent to the elimination rate of the drug from the body, and the infusion compensates for transfer to peripheral tissues, and there is an exponentially decreasing rate of drug concentration. To sum up, I would just like to tell you that we must be having several measures to avoid pitfalls and drug delivery problems. Even though this slide is specific for pediatric TIVA, this is a common problem which we encounter, especially while maintaining the IV lines while administering TIVA, because blockage of these lines can result in alteration of the target site concentration and sometimes even awareness, or basically hemodynamic disturbance and inadequate surgical requirements. And hence we must keep the IV lines visible with anti-reflux valves and avoiding dead space and air bubbles in these IV lines. The infusion pumps must be corrected and checked properly before administration of TIVA, and proper patient profile and programs must be set up along with correct drug concentrations and pressure alarms. The effect site monitoring with processed EEG and clinical monitoring is extremely important in all these cases. TIVA can come as a full question or as a short note, as told to you previously. I am not going into the details of the various drugs or TIVA in various environments like obese patients or elderly or children, because that is a complete topic in itself because of limited time. But yes, this overview is sufficient for you to answer your question in the examination. I'm extremely grateful to Dr. M.D. Kaur ma'am, Dr. Neerja ma'am, and all the faculty at RML and other students in attending this program. Thank you so much, and Jai Hind. Thank you.
Thank you, Dr. Uma, for excellent presentation on TIVA. We will have the question after the Dr. Neerja finishes her lecture. TIVA is actually for all the PG students. It has definitely come as a boon to the anesthesiologist for certain conditions where we want stress-free awake, extubation or intubation and anesthesia outside the OR settings, like in MRI, for IVF, endoscopies, history of PONV, neurophysiological monitoring, etc. And Uma, you have covered nearly all the aspects of TIVA in the stipulated time. Thank you, and wait for the question answer session. Now I will invite next speaker, Dr. Neerja Banerjee. She is professor in anesthesia at Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi. Her areas of interest are critical care and neurosurgery, and ATLS and CCLS instructor she is. So Neerja, now she will speak on sodium and potassium disorders and their management, which is very important. Over to you, Neerja.
Thank you, ma'am. Good morning, ma'am.
Good morning.
Good morning, everyone. Welcome to the last day of EPIC 22, the morning session. Welcome you all here for this session on potassium and sodium imbalance. I'll be talking about hypokalemia, hyperkalemia, hyponatremia and hypernatremia, the pathophysiology, clinical presentation and management of these 4 conditions. So let's learn about potassium. Let's quickly recap as to what is the distribution of these ions in the intracellular and extracellular space. In the extracellular space, sodium is the predominant ion. It is a positive ion, whereas in the intracellular space, it is the potassium which is the main ion. So potassium is primarily intracellular. 98% of this is intracellular, which is 150 milliequivalents or 150 millimoles per liter. And extracellular is only 2%, which is 3.5 to 5.3 millimoles or milliequivalents per liter. Now here I would like to emphasize that in univalent ions, or monovalent ions, the millimoles per liter and milliequivalents per liter, they are same. They are expressed in same value. Either of them you can use. You don't have to change the value. Whereas for bivalent ions like magnesium and calcium, the millimoles per liter is different from that of milliequivalents. That is, it is half of that. It is expressed as half of that. And this is depending upon your molar equation and all, right? So this is something you should know whenever you are expressing, and please specify the unit in which you are expressing the values of any ion. So for sodium and potassium, I'll be using the term milliequivalents per liter, right? And this distribution of ions, this is responsible for maintaining transmembrane electric potential, which is vital for cell excitability and muscle contraction, so nerve excitability, cardiac muscle excitability and all. And when you take them orally, how is it excreted? So potassium is excreted by kidneys. 90% of it is excreted by kidneys and 10% is excreted by colon. And what is the daily requirement of potassium? Why is it important? So it is extremely important to replace the daily requirements of potassium, because when these ICU patients, if you do not replace them, these symptoms of hypokalemia, it forms a cascade and you are never able to properly manage them. So 1 milliequivalents per kg per day is the requirement that has to be given over and above the losses that are occurring in whichever setup a patient is in. So potassium, this is a picture which is telling you the cells here is inside, where potassium is 140 milliequivalents per liter and outside it is 4. So here you can see there is sodium potassium ATPase pump. Through this sodium potassium ATPase pump, sodium is pushed out and potassium is pushed in. And these insulin, beta-2 adrenergic agonists and thyroid hormones, these are the ones which are acting at this, and then they are basically pushing potassium from extracellular to intracellular. This is also termed as transcellular migration of potassium. Okay, we will learn further about it. This is one of the major components resulting in hypokalemia. So let's learn about hypokalemia. Hypokalemia is any levels less than 3.5 milliequivalents per liter, and this level of less than 2.5 milliequivalents per liter is severe hypokalemia, and that is where you really have to act aggressively, and so that it doesn't result in life-threatening complications for the patient. Right? So what are the causes of hypokalemia? Either it could be poor intake, which can be in a patient who is accepting orally because of that, or when we are giving NG feeds or any parenteral nutrition, we have to ensure that adequate amount of potassium is given. So that poor intake is a very important component in critical care patients. Then losses. Losses can be from two places. Either it can be renal loss or it can be an extra-renal loss. So renal loss can be because of certain medications, basically diuretics. Please remember that hypomagnesemia also causes to increase potassium loss. So whenever there is hypokalemia, there is a very, very high likelihood that hypomagnesemia is also present. Then other than that, osmotic diuresis and mineralocorticoids, they also cause increased renal loss. Extra-renal loss primarily means losses from gut. So those patients on NG aspirates, those patients with ileal fistulas, excessive sweating, your dialysis, they are the places where a lot of potassium loss occurs. Transcellular shift, that sodium potassium ATPase pump that I talked about, that is where all these are acting. Insulin is pushing the potassium inside. Adrenergic excess, beta-2 agonists, they are pushing it inside. Hypothermia causes it, further pushing it inside. And this is a specific term called as hypokalemic periodic paralysis. This I'll be talking about later. And yes, of course, alkalosis also. Let's talk quickly about hypokalemic periodic paralysis. This is a very interesting kind of a situation, because if you have seen it once, you will never forget it. I have managed it in ICU. Here, young patients, generally around 20s, they give you a very innocuous kind of history that I had a good meal. Then after that, in cold night, I went out for gym or maybe some strenuous exercise. And then suddenly I started having this neuromuscular deficit. And in fact, they land up in respiratory compromise also, and require ventilation. So this patient about whom I'm talking about, this patient was put on ventilator. Within 24 hours or so, gradually started improving. We replaced potassium, and then gradually patient could be weaned off. So whenever a patient with this kind of sudden history, keep this in mind. Always check for hypokalemia. Whenever there is any kind of respiratory muscle weakness or sudden onset of weakness, hypokalemia is the first thing you should come to your mind. Similarly, thyrotoxicosis, by virtue of thyroid hormones pushing potassium inside, they can also result in sudden onset of paralysis, and the symptoms are similar. Just see these drugs, which are very commonly given in our ICU setup. High dose of glucocorticoids, thiazide or loop diuretics, antibiotics, amphotericin B, hyperglycemia. Now imagine a scenario where you were working during COVID days. In your ICU, they were receiving they were on steroid therapy. A lot of them were in later stages given amphotericin B. Then because of steroids, sugar management was also a problem. Hyperglycemia was also a concern. They were also on diuretics. So this was a perfect recipe for hypoglycemia. So if we are not sensitized about it, we would not replace it adequately, and the complications associated with it with hypokalemia would be seen, right? And then the increased renal loss I have already talked about. Excessive GI losses, this is extremely important in surgical cases. Because of any kind of obstruction, any kind of perforation, there are a lot of losses. They are the ones you should anticipate, be prepared, replace them adequately. Okay, other than sweating, burns, high-grade fever, all of them can also cause it. So we have learned about what are the various conditions which can result in hypokalemia. Let's see how it presents. So primarily, remember that it is a neuromuscular condition, which is most important for us. So schedule can be formed in the form of weakness, and respiratory muscle weakness requiring ventilatory compromise is one of the most dreaded complications of this. Smooth muscle involvement. In ICU, any patient where you are expecting that gut motility should be there and yet it is not there, please remember this. Post-operative patients, check for potassium when you have to start feeds. Constipation and urinary retention can also be a symptom of hypokalemia. Let's talk about cardiovascular. Severe hypokalemia can cause orthostatic hypotension, and these are the ECG changes. We always, right, during your undergrad days, you have been taught about the presence of prominent U waves. So what does it tell you? When you see these U waves, basically it's trying to tell you that there is potassium deficit. And if you don't take care of me, this is just sort of a warning sign for you. I can sort of throw arrhythmias. The heart is telling you I can throw arrhythmias. So if you see slightly prolonged P waves, peaked P waves, slightly prolonged PR interval, peaked P waves, ST segment depression, shallow T waves, and prominent U waves, think that there could be hypokalemia, and which can then further worsen to arrhythmias. Okay, hypokalemia also causes potentiation of digitalis toxicity. Please remember this. You have had a case discussion of mitral stenosis. Whenever we talk about treatment of a patient of mitral stenosis receiving digoxin, we always tell that this patient is receiving potassium chloride. Why is it being given? This is given because if there is hypokalemia, digitalis toxicity gets potentiated, and anyhow digitalis gives a very, very small margin of safety. So after learning all the signs and symptoms, knowing what are the conditions which can cause it, let's learn what further needs to be done. So please don't forget to examine your patient well, take the history well, because that will point towards the underlying condition which has resulted in this. Then after finding that out, if suppose it's poor intake, accordingly, you have to basically manage the underlying condition. And remember, urinary excretion, whether it is because of urinary or extrarenal potassium excretion, the best way to find that out is if you do the urine sodium. If urine sodium is more than 15 millimoles per day, then it is renal. So spot urine, you do it. And if it is less, then it is extrarenal. So how do you manage them? So remember, you will definitely would like to take care of replacing potassium, but whatever life-threatening conditions have occurred because of hypokalemia, take care of that, take care of airway, breathing, circulation, and then go on to replacement of potassium. So what all do? We correct potassium deficit, minimize further ongoing losses, Yes, correction of underlying cause is if the tap from above is open, however hard you fill, you're never going to fill the compartment. So the underlying cause needs to be taken care of. And yes, further, let's learn what can we do to prevent hypokalemia, right? Severity is a very important factor because severe hypokalemia is one where please do not try to replace with oral potassium. These are the ones who will require IV potassium. Whereas mild and moderate and daily replacements, they can be managed. In fact, mild can be managed with oral, otherwise you will need to give IV. Since this concept we are aware of that extracellular potassium is very low. So the low levels of potassium, extra ECF values that we get from serum potassium, that does not reflect the total potassium depletion. So this is one of the ways by which you can estimate 1 milliequivalent of depletion will tell you about 200 to 400 milliequivalents of total body potassium depletion, or whereas 0.3 milliequivalents per liter deficit represents about 100 milliequivalents per liter. So for example, if suppose it has fallen from say 3.5 to 2.5, so this will be approximately about 350 milliequivalents. So that you will have to replace, and let's learn how do we replace this potassium. So as I told you, for mild, the preferred route is oral, and for daily replacement also preferred route is oral. So potassium chloride syrup is available, where 15 ml of potassium chloride gives you 20 milliequivalents of potassium. Remember that it is highly gastric irritant, so I take adequate precautions for that. Let's learn about intravenous potassium. Intravenous potassium is available in the form of potassium chloride. It is dispensed as 10 ml of ampule. It has got 15% of KCl, right? Each ml contains 2 milliequivalents or 2 millimoles of potassium. So 10 ml will have 2 milliequivalents or 20 milliequivalents of 20 millimoles of potassium, right? So this is what you should know what your ampule contains, and it has got high osmolality. It has got very high osmolality. So what does it mean to you, high osmolality? Basically, it is extremely irritant when you give through peripheral veins. So please choose a large vein if whenever you are giving through peripheral vein, and dilute it. Do not give it through the infusion pump with minimal dilution, right? So but larger dilutions are required so that it does not cause irritation. So how much of rate? Where to give? Peripheral vein can be given, central vein can also be given. Remember, somewhere you would have read central vein, we cannot give it. We can give through central vein, but it is, you have to ensure that rate is very well controlled. You do not give bolus through central vein, otherwise you would cause dreaded complication because of significant hyperkalemia. So how much to give through these? 10 milliequivalents per hour is the maximum through peripheral vein. 20 milliequivalents per hour is maximum through central vein. In some life-threatening situation, in life-threatening arrhythmias, which is mostly seen in cardiac surgery situation, we can even go up to 40 milliequivalents per hour. Please remember to continue ECG monitoring and serial potassium monitoring. These are some precautions you will always remember. Never give bolus KCl. Never hold it 10 ml of filled syringe and giving it bolus. Do not give more than 40 milliequivalents per hour. Do not give more than 240 milliequivalents per hour per 24 hours, which basically means 20 milliequivalents per hour per 20 milliequivalents per hour for up to 12 hours it will be say 240. So gradually you have to taper it. Try to keep it up to 240 only, and do not dilute in Isolite M, because Isolite M contains 35 milliequivalents of potassium. So whenever you are using any diluent, please know what are the constituents of your fluid. Syringal lactate contains potassium, Isolite M contains potassium, Isolite G contains potassium, Isolite P contains potassium. So read how much potassium is present in that IV fluid, right? Hypomagnesemia most of the times coexists with hypokalemia. This is more so in hypocalcemia, malnutrition, alcoholism, diarrhea with use of diuretics, diabetes, aminoglycoside use. So in ICU setup, whenever hypokalemia is being replaced, magnesium replacement always takes place with it, and which will be further discussed in detail by my next speaker. So what are these high-risk patients where you do not want hypokalemia to occur and otherwise dreaded complications can occur? This is the patients with digitalis, hepatic failure, MI, IHD and diabetes. So these are the patients where potassium supplements are given to them. Those patients on large doses of IV steroid should also receive potassium supplements. So what are the anesthetic implications of hypokalemia? Before surgery, should you operate? Should you not operate? Remember, if there are any symptoms, if there are cardiac manifestations, ECG changes, you will have to replace. These are high-risk patients, congestive cardiac failure, digoxin. Please replace potassium. Otherwise, you'll really have a problem managing cardiac manifestations. So treat them. And once it comes from severe to say moderate, continue treatment, giving a KCL infusion, and then you can manage your patient accordingly. Please remember all those drugs which shift potassium from extracellular to intracellular compartment, avoid them, and avoid hyperventilation because alkalosis will further also cause transcellular shift. You should anticipate prolonged action of muscle relaxant. So give your drugs accordingly and use neuromuscular monitoring. Next comes hyperkalemia. Hyperkalemia is anything more than 5.5 milliequivalents per liter, and severe is when it is more than 6.5 milliequivalents per liter. Remember that hyperkalemic severe hyperkalemia is a medical emergency. Your patients do not give you time. If you have ever witnessed a hyperkalemic arrest, you would realize however hard you try, it really becomes very, very difficult to salvage them. So keep this in mind whenever you're managing. So how do you help these patients? The most important is keep your index of suspicion high in those patients who have high likelihood of having hyperkalemia. So there is a term called as, so let us learn about causes of hyperkalemia. So there is something called as pseudohyperkalemia. So pseudohyperkalemia occurs because of what? Whenever cell death occurs, there is lysis of the cells, and potassium being intracellular gets released in the extracellular compartment. So that is why there is increased potassium because of this cell death. So hemolysis, thrombocytosis, severe leukocytosis, fist clenching, these are some of the conditions where you can get pseudohyperkalemia. Other than that, abnormal potassium distribution basically means anything where intracellular potassium is being pushed outside into the ECF compartment. So which is opposite of hypokalemia, insulin deficiency, beta blockers, metabolic or respiratory acidosis, and here also there is a term familial hyperkalemic periodic paralysis. This rhabdomyolysis term I would like to explain in detail. Rhabdomyolysis is basically a lot of muscle destruction is occurring. So this is the time when a lot of potassium is getting released. These are the patients who are a case of polytrauma, massive crush injury, and they come to you in your emergency, and if you have to intubate them and you give them succinylcholine, severe hyperkalemia, sudden arrest, you won't know what will happen to your patient. Right? So please keep this in mind. Do not give them succinylcholine. Patients of electric burns, similar situation, rhabdomyolysis, massive potassium release. Patients of neurological insult resulting paralysis, they have extrajunctional receptors. There also succinylcholine causes massive release. Those patients of like Seguin-Barré syndrome, when you try to intubate them, please do not intubate them with succinylcholine. They result in massive release of potassium, and you can have again a risk that I'm talking about. Right? Another important thing that you should know of is renal disease, acute or chronic renal failure. We learn it. We are all aware about it. You should be highly sensitized that potassium levels can be high in them. Another very important thing that you should know of is stored blood causes a lot of release of potassium because of the fact that stored blood, when in hypothermia, your sodium potassium ATPase pump is not as effective. So there is a lot of leak of potassium from intracellular to extracellular compartment. Whenever the patients are on ACE inhibitors or ARBs, please remember that they can be having hyperkalemia. So whenever you do your PACs, please check for that. NSAIDs can also cause hyperkalemia. So these are some of the drugs you'll have to keep in mind. Potassium sparing diuretics, they can cause hyperkalemia. So be sensitized about the drugs. You should be aware about them whenever you are doing the PAC, managing the patients in ICU or in emergency. When you keep your index of suspicion high, that is the time when the complications decrease. As far as clinical presentation is concerned, it is not very specific. Respiratory compromise can occur even in this, but it's a cardiac compromise that is what we are worried about. Syncope, palpitations, arrhythmias, and finally arrest. So let us look at the ECG changes. ECG changes, peaked T waves, peaked tall T waves. Thankfully, all of you are sensitized about it like U waves. This also is really an alarming sign for you. Immediately try to rule out, could there be hyperkalemia? And in case if you miss it, then it further progresses to loss of P wave, prolongation of QRS complex, ST segment elevation, ectopic beats, then followed by arrhythmias, ventricular fibrillation, and finally arrest. So what do we do besides doing ECG lab investigations? Other than that, for ruling out cause, then you will have to rule out ARF, you will have to rule out CRF, then even blood glucose levels need to be done. So these are some of the things that you will investigate the patient for. Now, we have learned about what are the causes. We have learned about signs and symptoms. Let's see how we can help them. So what do we do when we find that your patient is having hyperkalemia? Immediately, remember, if you are asked this question, you have to answer the question as 3 steps. One is antagonizing the membrane effect of hyperkalemia, which is why is this effect worrisome? Because this is the effect which is occurring at the heart. This is what you do not want, which is the most dreaded complication that we are anticipating. So antagonism of membrane effect, it does not lower potassium, it is only antagonizing the effect of potassium on heart. Then is decreasing the level of potassium, which can be either by transcellular migration or by elimination of potassium. So under these 3 heads, you'll have to answer your question, whether in theory or in practical. So how do you antagonize the membrane effect? The antagonism of membrane effect occurs by administration of calcium gluconate. It is dispensed as 10 ml of ampule. 10% of 10 ml is given over 1 to 3 minutes. Depending upon what an emergency is, you can give, if it is much lower, then it is called rule of 10 ml of 10% over 10 minutes. Otherwise, give it over 1 to 3 minutes. The effect is very fast, within 1 to 3 minutes, and last up to 30 minutes. If the effect is not reversed, then you can even repeat it. Calcium chloride may also be given, which has got much higher calcium than that, 3 times higher that of calcium gluconate. So how do we promote transcellular migration? Transcellular migration is promoted by making use of glucose-insulin drip. In glucose, 25 to 50 grams of glucose, you can put 10 to 20 units of plain insulin, start infusion with that, and then the onset of action is within 30 minutes and duration is 4 to 6 hours. If your patient is having acidosis, pH is low, please give soda bicarb only in these situations. Otherwise, do not give soda bicarb unnecessarily, because that is not going to help. So soda bicarb needs to be given when there is acidosis. You give 10 ml of soda bicarb, that immediately pushes the potassium inside. Nebulization with salbutamol, beta-2 agonist, causes, as we knew, it causes hypokalemia. Basically, it is pushing the potassium inside. 10 to 20 milligram of nebulization can be done, where onset of action takes place 15 to 20 minutes and duration of action is 2 hours. So how do we promote elimination of potassium? Through kidneys, by giving diuretics, and hemodialysis is one of the best methods of causing potassium removal from the body. In gut, we use cation exchange resins, which can be calcium exchange resins. They basically exchange from potassium gets exchanged with calcium, this which can be given through orally or through parectal route. This is a table which further summarizes the whole thing that I have talked about. So you have this hyperkalemic patient whom you have to give anesthesia. Remember, no elective surgery can be done if potassium is not normal. So if it is more than 5.5 milliequivalents per liter, please bring it down, whatever measure needs to be undertaken, and then only you take up. But however, if there is an emergency situation, do all the emergency measures to decrease it, and then only stabilize them also, then only you can take them up. Most important is you have to identify the high-risk patients of hyperkalemia, the patient of burn, the patient of polytrauma, the patient with neurological deficit, patient who has received multiple transfusions. They are the ones who can have hyperkalemia. So that is something that you have to take care of. Avoid succinylcholine and NSAIDs in them. Give goal-directed fluid therapy. keep a threshold for blood transfusions high in them. And if you have give as fresh as blood or as much as possible, so that chances of potassium release in stored blood is decreased. So this was about hyperkalemia and hyperkalemia. Let's now learn about your sodium and water imbalance. Remember that sodium imbalance is always associated with water imbalance. So in fact, sodium disorders are also called as disorders of water balance. They're also called disorders of osmotic. Basically, it is associated with changes in osmolality and changes in water balance in body. That is because of the fact that serum osmolality, the main component is sodium in our body. So because of that, any change in sodium results in change in serum osmolality. So this is a major cation of extracellular compartment. The normal levels of 135 to 145 milliequivalents per liter. Hyponatremia is defined as when it is less than 135 milliequivalents per liter, and it can be acute or chronic depending upon whether it is less than 48 hours or it is more than 48 hours. The normal serum level is maintained by virtue of your antidiuretic hormone, and that's how with either increase or decrease in urine of water takes place by antidiuretic hormone. And the causes and treatment of sodium disorders, it depends on the osmolality and volume status, and our management also depends on that. Please remember that. And remember, the one organ which gets maximum affected by hypo or hypernatremia is brain, because that is most osmotically sensitive organ. So in hyponatremia, there is edema. In hypernatremia, there is cells shrinkage resulting in bleeding, intracellular hemorrhage occurs, subarachnoid hemorrhage occurs. So these are some of the things which occur. So if you have worked with neurosurgeons, they have the highest sensitivity for this. It is the neurosurgeons, neurologists, and your urologist and nephrologist. They are the ones who are most worried about hyponatremia and hypernatremia. So here, if you look at it, CNS symptoms, they can be very innocuous, like, lethargy, listlessness, difficulty in walking. And this is classically seen in elderly patients who are on thiazide diuretics, hypertensives, with poor salt intake, and they have these vague kind of symptoms which we say, oh, they are old patients, they are slowing, but actually they could be having mild hyponatremia. So keep that high index of suspicion in them. And yes, seizures, decorticate posturing, they are the ones which we do not want to happen to your patient, and then you have to be aggressive about managing them. So let's learn what we can do and how we can help them. So as I told you, volume balance, osmolality, which is serum and urine osmolality, is important. So these are the things that you need to do. Measure serum osmolality, urine osmolality, estimate volume status, estimate urine sodium, and other lab investigations. Now let's look at this algorithm. I'll break it each step at a time so that you can understand. So first thing that you need to do is look for the osmolality. So when you look for the osmolality, three things can happen. Either it can be low, or it can be normal, or it can be high, right? So normal can be 280 to 290. What can be the cause of normal? When you have normal osmolality with hyponatremia, that is sodium less than 135. This is called as pseudo-hyponatremia. I'll discuss this further. Elevated can be because of presence of hypertonic hyponatremia in the presence of hyperglycemia or hypertonic infusions. I'll talk again further. Then if it is low, this is called as true hyponatremia. Low osmolality, that is the time when you have to further talk about assessment of volume status. So let's first learn. Pseudohyponatremia is because of the presence of increased plasma potassium. If plasma protein. If plasma protein and plasma lipids are high, then it can cause pseudohyponatremia. This hypertonic hyponatremia occurs, I'll tell you why, when you are infusing say mannitol or glycine, what is happening is these are the fluids which are sitting outside in ECF compartment. They cannot go inside intracellular compartment. So what happens is, because of that, this increase the osmolarity outside. So a lot of water gets shifted from inside to outside. So this is what translocational hyponatremia occurs. And this is extremely important for glycine. It results in QRP syndrome. It has been discussed in great detail in your lecture, in your case discussion of TURP. So TURP basically results in glycine administration, results in hyponatremia. In hyperglycemia, 100 grams of glucose, if it is above the 100 grams of glucose levels, if they rise, 1.6 millimoles per liter occurs for each 100 grams of glucose rise, and up to 400. But if it is more than 400, it increases by 2.4 millimeters per liter, right? So this was about hypotonic. This was about when there is hypertonic and when there is U1, when the osmolarity is normal. Let's then come to the second situation when there was hypovolemia. So what do I do about hypovolemia? What do I do when there is low serum osmolality? So when there is low serum osmolality, let us assess the volume status of the patient. So volume status can again be low, normal, or high. So what can be their situation in normal? Normal, the commonest cause is SIADH, or when a patient is a psychogenic polydipsia. Basically, these patients drink a lot of water without realizing it. So there is dilution because of that. It can also be because of hypothyroidism. Please remember. Okay, in mixed edema, you can have hyponatremia. Hypervolemic, lot of water. So anything with lot of water because of pathological condition like congestive heart failure, decompensated cirrhosis, and nephrotic syndrome. Remember, there can be hyponatremia. Let's now come to hypovolemic hyponatremia. In this, what you do is you check for sodium losses. If there is more sodium loss, then it is because of recent diuretics, adrenal insufficiency. If it is less than 15 milliequivalents per liter, then it can be because of vomiting, diarrhea, fistulas, right? So these are the conditions which will cause it. So if you get causes, if you have to enumerate the causes of hyponatremia, you combine all these causes of various types of hyponatremia and then enumerate them accordingly. And the tests would be according to the cause which could be there, and this also increase the CT in case if the patient has symptoms related to neurological condition. So what do we do? We have learned that we have estimated the osmolality, we have estimated the volume status, we have realized that which category your patient fits in. So depending upon different categories, we accordingly treat them. So remember, it is very important to know whether your patient is having acute or severe, acute or chronic hyponatremia, mild or severe hyponatremia. So severe hyponatremia with symptoms is very significant. They are the ones who will require IV administration of 3% of normal saline. Acute situation less than 48 hours of hyponatremia, they are the ones where the rate of administration is much more than that of chronic hyponatremia. So let's learn further. What do we do in them? Let's first talk about symptomatic severe hyponatremia. Our fluid of choice is 3% normal saline. 3% normal saline contains 513 milliequivalents per liter. The normal saline that we are administering, 0.9% of normal saline, it gives 154 milliequivalents per liter. You should know this whenever you are administering these fluids. So this is the classically described formula, Andromeda's formula. In this formula, we are basically estimating the change in sodium, serum sodium, by giving 1 liter of infusate. So depending on what infusate you are using, this is the infusate sodium you will be filling up. So in case if you are using 3% normal saline, you will be filling up the value that you will replace as 513. And in case if you don't want to aggressively replace it with 3% normal saline, you are giving only normal 0.9%, then you will replace it with 154. Total body water is calculated on the basis of multiplying body weight with 0.5 for women and 0.6 for men, right? So, and in case of potassium is also being administered, you have to add sodium and potassium. This is where this further needs to be added. Let me give you an example. Suppose there is a 60 kg female with a total body water of So this patient would have total body water of 30. So a serum sodium would be this patient has a serum sodium of 110 milliequivalents per liter with a hypovolemic hyponatremia. So how do I give 3% of normal saline to her? So look at this. Total body water is 30. So increase in serum sodium. If I give 1 liter of 3% saline, if I replace the values in this formula, I get it is 13 milliequivalent. So if I administer 1 liter of 3% normal saline, I'll be able to raise 13 milliequivalents for this patient. Okay. And so what is the rate at which I'll set up? So in case if I set a rate of 100 ml per hour, I'll be increasing the serum potassium by 1 milliequivalents per hour. And remember, in an acute condition, the rate of increase of sodium is 1 to 2 milliequivalents per hour for 3 to 4 hours. Then we decrease it. When do we decrease it? Either my potassium level increases to more than 125, more than 120 actually, or your signs and symptoms, they start decreasing. If nothing else, then also after 4 hours, please decrease the rate to 0.5 milliequivalents per hour. And maximum amount that you would replace is 10 to 12 milliequivalents. You will have to remember this so that you do not result in dreaded complication of central pontine myelinosis. Okay. These are another two formula. This was basically mentioned in your lecture of TURP syndrome. 1 ml per kg of 3% normal saline, if you give, it is expected to raise a serum sodium of 1 milliequivalent. So this formula can also be used. This is the newer studies have depicted that this formula also you can use, right? This is another formula is also there where sodium deficit can be calculated. Whichever you can remember, use it. But please keep monitoring your sodium levels regularly. Otherwise, you will cause hypernatremia. Okay. So this was regarding the calculation. How do you calculate? This I have already talked about. So let's go to individual situations. What do we do? In hypovolemic hyponatremia, we will have to replace fluid over and above this. So that the blood pressure starts settling, because rapid infusion of 3% saline cannot be given. So give 0.9% saline. In case there is potassium depletion, give potassium depletion also with it, because a lot of potassium may also be lost. Replace that along with it, then calculate these losses and then start giving 3% of your normal saline according to the infusion rate that we will calculate. As far as euvolemic is concerned, syndrome of inappropriate ADH secretion is very common. Hypothyroidism and glucocorticoid deficiency may also be there. So CNS conditions are the commonest cause of your SIADH. Okay. So what do you do in them? In these patients, you will have to restrict fluid to 500 ml, less than that of daily urine. 1, restrict fluid. 2 is 3% saline in case if there is severe manifestation or serum potassium is less than 125 milliequivalents per liter. Other than that, diuretics can be given, and there are these drugs which are called as Vaptans, which are basically vasopressor receptor antagonists. You should know the names. If someone asks you, Tolvaptan is the commonest, Conivaptan, Relcovaptan, Nelivaptan. These drugs can be given. Remember, these are not standalone therapy. They are only adjunctive therapies. For hypervolemic hyponatremia, as the name suggests, you'll have to take out water. So you will basically give diuretic therapy, do diuretic therapy, sodium and fluid restriction, and then treat the underlying condition. So why were we worried about giving these drugs, these fluids at a certain rate? Because we are worried about the dreaded complication of central pontine myelinosis, which is now known as osmotic myelination syndrome. This is more so in patients with chronic hyponatremia, because they are the ones where the adaptation occurs. And if you rapidly increase it, rebound edema, cerebral edema occurs, which results in this demyelination syndrome eventually. right? So what happens in them? These are the patients who will be in a locked-in syndrome. This is a classic term used for that. We really cannot help them. This is an iatrogenic condition we have resulted. We should own the responsibility of not causing it. So some of these are high-risk patients, patients of hypokalemia, liver disease, malnutrition, alcoholism. So please take care specifically in these subset of patients, okay? So keep doing your serial level monitoring of your sodium levels. To summarize hyponatremia, it can be asymptomatic to life-threatening. 3 states: hypovolemic, hypervolemic, euvolemic. Common causes we have already learned. Do not correct more than 10 to 12 milliequivalents in 24 hours. In acute condition, in chronic 6 to 8 milliequivalents per hour. Regarding management of anesthesia, correct significant and symptomatic hyponatremia. If emergency surgery needs to be undertaken, continue the replacement of say 3% of normal saline. Continue it with your infusion pump. Replace ongoing losses with blood and ringer lactate accordingly. And then remember that if patient is having hypovolemia along with it, there could be hypotension. So give your vasopressors and inotropes along with it. Do invasive monitoring. Okay, so I have summarized from how to recognize, what to give, when to give, how much to give, and in under anesthesia, what precautions need to be taken. Quickly, I'll talk about hypernatremia. It is not as common as hyponatremia. In hypernatremia, basically, why it is not common? Because thirst mechanism is a very good mechanism which takes care of drinking a lot of water, preventing hypernatremia. However, in pediatric age group, in elderly patients, debilitated patients, your mental illness patients, those patients with mental illness, unconscious, they are the ones where this mechanism is gone. So you may have significant hypernatremia. In hypernatremia, it is the dreaded complication of neurological compromise, which is what we are worried about. So seizures and death eventually, which can result, the extremely level high of morbidity and mortality occurs with hyponatremia and hyponatremia. So this is an algorithm. I'll break it again for you. Remember, here also we have to check for volume status. They can again be hypovolemic, euvolemic, and hypervolemic. Remember, euvolemia, there in hyponatremia was SIADH. In this, it is diabetes insipidus, which can be nephrogenic or it can be central in origin. As far as hypervolemia, in hyponatremia was because of cirrhosis and your nephrotic syndrome. In this hypervolemia, you will find peripheral edema, ascites, hypervolemia with your hypernatremia. Then this is a separate subset. It is a hypovolemia with hypernatremia that we have to take care of. So basically, these would be the patients who would have signs of decreased skin turgor, flat neck veins, dry mucosa, orthostatic hypotension, tachycardia, oliguria. So check for that. So any patient with these symptoms with hypernatremia, then we further divide into 2 limbs. To find out whether it is the losses occurring in the kidneys or outside the kidneys. So you do spot urine estimation, more than 20, less than 20, more than 20, it is renal, less than 20, it is outside renal. So a lot of sodium gets lost in your fistulas. So these high output fistulas, ileal fistulas, colon, where we make these colostomies, a lot of losses can occur because of that. So keep a very high index of suspicion for them. And in renal, it is the diuretics which are the major culprits. So whenever you are further trying to manage them, look for volume status of the patient. And then do the history and physical examination, look for polyuria. If it is more than 3 liters per minute, that is something very alarming. Try to find out whether this is central in origin or it is nephrogenic diabetes insipidus. Okay. So what do we do? How do I manage? Remember, a treatment of hypernatremia, we have to replace the fluid. Either this is called as free fluid replacement. The best way to replace is by giving it orally. Water can be given if your patient takes it. Through NG fluid, or also we can give clear water. Or IV fluids in the form of 5% dextrose or 0.45% of normal saline can be given. So these are the replacement fluids for management of hypernatremia. Okay, so let's learn how do we do. This, if you remember this one formula, this Andromedia's formula, this can also be used for calculating hypernatremia. Here it will give you the change in sodium. So basically, what is the change in sodium? You'll get basically infusate sodium, you'll get a negative value here in this. And change in sodium is for 1 liter of fluid that you are infusing. So infusate sodium in this, if you are giving 5% dextrose, would be 0. And if you are giving 0.45% of normal saline, so that would be 77 milliequivalents. If you put these values here, you will be getting the amount of amount of sodium change that is expected. And depending on fluid, then you calculate how much of fluid needs to be given. So similarly, 60, as in previous case, 60 kg woman, so with a total body water of 30 liters, has a serum sodium of 160 milliequivalents. When we replace this, we find out that if we replace this with 0.45% of normal saline, we find out if we give 1 liter of 0.45% of normal saline to this patient, we increase the change in sodium occurs by 2.7 milliequivalents. So then you calculate how much of fluid you need to give accordingly. It comes out to be approximately 300 milliliter per hour, because this is what is going to decrease it as 1 milliequivalent per hour rate. Remember, the rate of decrease for sodium and rate of increase for sodium stays the same. So everything, rate of correction is same in both groups of patients. And very important for hypernatremia is, besides this free water, you will have to replace the daily losses. So that can be in the form of 0.45%, or if excessive daily losses are there, sometimes in hypovolemic patients, even normal saline is given. But so you can give 0.45%, you can give normal saline depending upon what your condition of the patient is. Other than that, calculation of water deficit can also be done by this formula. Water deficit is equal to previous total body water into actual sodium upon desired sodium. Please remember it. You can memorize. Otherwise, one formula for both the condition can also help you in calculation. This is another formula which will help you in telling about the water deficit. I have given the calculation also. So this is about fluid administration. I have highlighted the fact water deficit and ongoing fluid losses needed to be replaced. So let's go back to our previous slide. This is what is going to tell us what type of hypernatremia I have, whether it is hypovolemic or hypervolemic. And this is specifically more so if it is central diabetes insipidus or nephrogenic diabetes insipidus. So what do I know? What can I do about them? Let's learn quickly about diabetes insipidus. Central diabetes insipidus is failure to synthesize or release ADH through hypothalamus. Anybody who has got the patient of craniopharyngiomas operated, you would know that surgeon will continuously keep on asking you, what is the urine output? What is the serum sodium? Please get urine osmolality done. Please get serum osmolality done. All this is because of the fact that you do not want these patients to be landing up in diabetes insipidus. So neurotrauma, post-surgical metastatic tumor, CNS infections can have this manifestation. And hallmark of this is diabetes insipidus is dilute urine. And what do? You give desmopressin spray in them. Desmopressin spray is the drug of choice for diabetes insipidus. You give nasal spray of 5 to 10 microgram nasally. When there is improvement in your hypernatremia condition, the output improves, the osmolality decreases, then you know that this patient is suffering from central BI. Okay, so that is what you will do. Other than that, whatever water deficit is there, you will, as I have told you, you will replace it with free water depending upon 0.45 or 5% of dextrose, and then ongoing losses also need to be given. Other than that, quickly summarize. Hypovolemic and euvolemic hypernatremia. Hypovolemic, you might need to give normal saline for hemodynamic stability, and other than that, free water deficit needs to be replaced. For euvolemic, 0.45% of saline is good enough. Along with it, please can also correct the daily losses. Hypervolemic hypernatremia, it is basically iatrogenic, lot of soda bicarb, sodium tablets. They are the ones which result in this condition. Just by stopping the offending agent, giving free water and loop diuretics, sometimes even hemodialysis needs to be done in these situations. So this was regarding management. What do I do about a patient who comes to me for anesthesia? So delay surgery as much as possible. If it is severe, please decrease it as much as possible to normal levels. Try to bring to 135 or 140 is the ideal level. Continue correction and do perioperative monitoring, regular perioperative monitoring of sodium. In case your patient is hypovolemic, would require invasive monitoring, would require vasopressors accordingly. Monitor urine output, monitor serum sodium, monitor osmolality, all that needs to be done. Remember, volume of distribution of hydrophilic drugs gets altered in hypovolemia and hypervolemia. You should be aware about it. So this was completely about hyponatremia and hypernatremia. I have already discussed in detail hypokalemia and hyperkalemia. I hope you have understood. On your table viva, you can be asked an ampule of KCl. You can be shown a normal saline VAC or a 3% saline, hypertonic saline. So you should know how to read it. You should know how to tell. You can get short notes on this. And sometimes an examiner may give you a clinical scenario and ask you to calculate the deficit in hypo and hypernatremia. I hope you have understood whatever I have taught. All the best for your exams. Thank you.
Hello.
Hello, ma'am.
Hello. Hello. Hello.
I'm audible. You're audible, ma'am.
Okay, thank you so much, Neerja, for excellent presentation. You have made such a complex topic so easy for the students. The resident doctors are day in and day out coming across such patients in ICU and emergency OTs, but still have many doubts, and most of them must have been cleared by now. So after both the topics, may I have some questions, Nitin? Are there any questions?
Ma'am, there's a question where they've asked role of Lasix in hyponatremia in TURP syndrome. This is not the primary treatment. This was addressed by in the lecture of TURP also when the case discussion took place. Please remember that a patient of TURP would have so many other manifestations besides hyponatremia. So first, take care of the patient. Remember, always remember your ABCs. So this patient could suddenly become drowsy, could have breathing problem, the BP might drop. So first take care of that, calculate your sodium level according to the sodium serum levels, calculate the deficit, start normal saline replacement. Lasix is really not the first treatment that you need to give, and then manage accordingly, okay? So serial management needs to be done. Specific management needs to be done in the form of replacement with 3% of normal saline, depending upon what are the levels. If it is very severe, you will have to replace it. And please remember the rate of replacement also, okay? So Lasix actually is not the mainstay of treatment. Lasix is very important in your hypovolemic hyponatremia. This is translocation. So there you would need to replace sodium.
Okay, I can't see any other question from the audience. Dr. Uma, I just want to ask you, Remimazole, I think it has been approved by FDA in 2020.
Ma'am, it has been recently approved, but yes, it is not being used.
It is not available in India?
Ma'am, it is there in India, but the problem is it is not available everywhere. And there has not been very many studies to understand its safety, because the main problem is the cost, ma'am. Once you use a drug which has a very, especially ester hydrolysis drug, you need a large quantity of drug, both for bolus as well as for infusion. The same problem is with remifentanil. So both these drugs, in fact, remimazolam is a combination of midas with remifentanil, and the advantage that it can be reversed with flumazenil. So that is a very, very important advantage. And definitely the cost is lesser than remifentanil, but the problem is the amount is more. And we need more studies, especially when we are using it outside the OT. That environment where in US, the studies have been done in endoscopy suits. To understand the use of remimazolam there. But in India, we need more randomized control trials and greater availability and greater knowledge about this drug before we
Safety of
bring it into our practice. Yes, ma'am.
Oh.
Yes, ma'am. Because
Thank
there
you.
are several other drugs which have also come in anesthesia with short duration and a very good potential for improvement, like rapacuronium, which again went back into disrepute.
Okay, thank you, Uma, and thank you, Dr. Neerja, for the nice
Thank you,
session.
ma'am.
And once again, thanks to RML team to give me this opportunity to chair this session. Thank you all.
Thank you, ma'am. Thank you so much. Thank you.
Okay.
So, good morning, everyone. Without delay, we want to start the new session.
Thank you so much.
Uh,
So moving ahead with our next session, I would like to invite the chairperson of this session, Dr. R.P. Singh, Sir's professor at Banaras Hindu University at Varanasi, and Sir's area of special interest are pediatric anesthesia.
so, quickly we will start the session. So, good morning, everyone. Our next lecture is on calcium, magnesium, and phosphate. And to talk on this lecture, I invite Dr. Akhil Agarwal. So, he is additional director at GI Surgery Anesthesia, Fortis Escort Hospital, Jaipur. His area of interest is hepatopancreaticobiliary and GI anesthesia, airway management, BLS, ACLS courses, and simulation in anesthesia. Please, Dr. Akhil Agarwal.
Recording in progress.
Good morning, everyone. And to begin with, I would like to convey my regards to the organizing team for giving me the opportunity to speak on this platform. Today, I would be speaking on calcium, magnesium, and phosphate. And without wasting time, let us start our presentation. Scroll down. Calcium is present in 3 different forms in our body, out of which 50% is ionized. Rest, which is biologically inactive, out of that 80% is bound to albumin and 20% is complex to plasma ions. So if you see, total calcium in our body is 9 to 10 milligram per deciliter, out of which ionized is 4.5 to 5 milligram per deciliter. Decrease in albumin decreases amount of calcium protein bound fraction, and ionized calcium remains unchanged. There are a few very important things to remember. Acidosis decreases binding of calcium to albumin, therefore it increases the ionized calcium. There is a loss of carbon dioxide from blood sample which lowers the ionized calcium. EDTA heparin is they bind calcium, and therefore heparinized syringe should not have more than 15 units per ml of blood. Especially this is the last point is very important, especially for ICU patients. You have to add 0.8 milligram per deciliter for every 1 milligram decrease in the serum albumin, that is below 4 milligrams. What are the causes of hypocalcemia? So if you look at the causes are alkalosis, blood transfusion, cardiopulmonary bypass, drugs like amenable epocyte, cimetidine, heparin, theophylline, fat embolism, vitamin D deficiency, hypoparathyroidism, pseudo-hypoparathyroidism. Magnesium depletion is very important. We will come to this magnesium depletion in our later slides. Renal sufficiency and sepsis. Sepsis is one of the very important cause of hypocalcemia, especially in ICU settings. How does our body react to hypocalcemia? So body reacts by increasing the parathyroid hormone secretion. This parathyroid hormone works on 3 different target organs. So primarily it works on intestine, where it increases the intestinal calcium absorption, and it also increases the phosphate absorption from the intestine. It also increases in the bone, where it increases the bone turnover and increases the calcium from bone to the blood and also the phosphates. When it acts on kidneys, it increases the calcium absorption, but also decreases the phosphates from the body. So net effect is there is a rise in serum calcium, but the phosphate remains unchanged. Hypocalcemia patients usually presents with perioral numbness and carpopedal spasms. We are all probably aware with Chvostek's signs, Trousers signs, and Erb's signs. On the cardiovascular front, there is a decreased cardiac output which leads to hypotension. There are ectopics which can proceed to and progress to arrhythmias and can lead to heart block. How do you elucidate these different signs? To elicit the Chvostek signs, you have to tap the facial nerve 1 to 2 cm anterior to earlobe with fingertip, and you will watch the twitching of the muscles. Grade 1 is when there is a twitching at the corner of mouth only. Grade 2 is when this includes along with twitching of ala nasal, and grade 3 is when twitching of both the other above two muscles includes contraction of orbicularis oculi. For eliciting Trousers sign, you have to inflate the blood pressure cuff above the systolic blood pressure for up to 3 minutes, and the result will be a carpal spasm, whereas wrist and metacarpophalangeal joints will go into flexion and interphalangeal joints will go into extension. To elicit Erb's sign, you tap the peroneal nerve just behind the fibula head and you will find flexion and eversion of the foot. How do you manage? So it's very simple. Whatever is less in body, you have to give that. There are two IV modalities of calcium management. So we have two preparations. One is 10% calcium gluconate, in which 10 ml vial contains 94 mg of elemental calcium. Another is calcium chloride, where 10 ml of vial contains 273 mg of elemental calcium. For any symptomatic hypocalcemia, you have to give 200 mg of elemental calcium at least. And remember, that means 8 mg of calcium chloride or 22 mg of calcium gluconate in 100 ml saline over 10 minutes. Remember, each 100 mg bolus of calcium will raise serum calcium by 0.5 mg per deciliter. This is to be followed with a continuous infusion of calcium of 1 to 2 mg elemental calcium per kg per hour for next 6 to 12 hours. Also, along with replacing calcium, you have to treat underlying causes, especially magnesium depletion if there is any. Now coming to hypercalcemia, the causes are malignancy, hyperparathyroidism, excess of vitamin D, familial hypocalciuric hypercalcemia, more turnover from the bones because of local tumor or immobilization or enhanced intestinal absorptions. The clinical manifestations of hypercalcemia depends not only on the magnitude of hypercalcemia but also the rate of rise in serum calcium. So if there is a slow rise, the symptoms probably will be less. In GI symptoms, there would be nausea, vomiting, constipation, and abdominal pain. Neurologically, patient might present with lethargy, fatigue, difficulty in concentrating, and coma. Cardiovascularly, patient will present hypertension and shortening of QT interval. We will look into the cardiovascular manifestations of hypercalcemia in next slide in detail. Renal symptoms would be nephrogenic diabetes insipidus resulting into polyuria, can present with nephrocalcinosis, and acute cases, severe cases can be acute renal failure. Cardiovascular symptoms peculiarly depend on the level of serum calcium. So up to 15 mg per deciliter of serum calcium, myocardial contractility increases, results in hypertension. QT intervals typically shortens when the serum calcium is more than 13 mg per deciliter. PR and QRS intervals are also prolonged. AV block, which can progress to complete heart block and even cardiac arrest, is seen when total serum calcium is more than 15 to 20 mg per deciliter. Hypercalcemia can worsen digitalis toxicity and may cause hypertension. How do you manage calcium? You manage serum calcium levels when the calcium is more than 14 mg per deciliter. You treat the underlying causes and you start with IV resuscitation with normal saline. It reduces the proximal tubular reabsorption of salt and water. You also have to give loop diuretic 40 to 80 milligrams IV and can be repeated every 2 hourly until you achieve an urine output of 100 to 200 ml per hour. You have to maintain an accurate intake output assessment, and IV biphosphonates like pamidronate and zoledronate can be given. They act by blocking the osteoclast mediated bone resorption, but the action is slow and the clinical response is seen in 2 to 4 days. Subcutaneous calcitonin 4 unit per kg every 12 hourly can be used, but the problem would be of tachyphylaxis. Corticosteroid, particularly hydrocortisone 200 mg daily in 2 to 3 divided dose has been used. Hemodialysis is the treatment of choice for end-stage hypercalcemia patients. And recently, plecamycin, which is an anti-neoplastic agent, has been used to inhibit bone resorptions. Coming to magnesium. Magnesium is the second most abundant intracellular cation, and it is cofactor for more than 300 enzyme reactions. So this micro and nutrient magnesium is very important for our body functioning. But out of the total magnesium present in body, less than 1% is seen in plasma. Therefore, there is a very limited value of plasma magnesium concentration to gauge the total value of total body magnesium stores. Out of the total magnesium present in body, 67% is ionized, and rest 19% is bound to plasma protein and 10% related with divalent anions. Spectrometry measures all the three forms of fractions, and magnesium is used in all the kind of enzyme reactions like ATP metabolism, muscle contraction, relaxations, release of neurotransmitters, regulation of vascular tone, heart rhythm, platelet-activated thrombosis, so on and so forth. Whenever you are assessing magnesium, serum magnesium is favored over plasma magnesium assay because the anticoagulant which is used for plasma samples can be contaminated with citrate or other anions, and they can bind magnesium. There can be false hypomagnesemia reported. Magnesium is also very important for anesthesia. When it comes to peripheral nervous system, it interferes with the release of neurotransmitter at all synaptic junctions, and therefore it potentiates the actions of local anesthetics. At the neuromuscular junctions, it significantly blocks the presynaptic neuromusculars. Blockage is seen, and it enhances the action of non-depolarizing muscle relaxant. It also precipitates weakness in patients with myasthenia gravis and Aton-Lambert syndrome. It also prolongs action of depolarizing neuromuscular blockers, and it prevents potassium release by succinylcholine. It is also used in severe acute asthma as treatment as an effective bronchodilator, and everyone probably knows the uses of magnesium in OBS anesthesia. It is a powerful tocolytic agent to manage premature labor, and there is a very long topic and a complete full question on prophylaxis and treatment of eclampsia by magnesium, which probably will be dealt in your OBS anesthesia lecture. The normal range for magnesium in our body is 1.7 to 2.4 milligram per deciliter. Coming to hypomagnesemia, it is the most underdiagnosed electrolyte abnormality. It is hypomagnesemia when serum magnesium is less than 1.6 milligram per deciliter, and the predisposing conditions are usually drug therapy like furosemide, aminoglycosides, amphotericin, pentamidine, digitalis, cisplatin, cyclosporin. Diarrhea is also responsible. A very peculiar cause of hypomagnesemia is chronic alcohol abuse. Diabetes mellitus is also there. Magnesium deficiency is always also associated with other electrolyte abnormalities like hypokalemia, hypophosphatemia, hyponatremia, and hypocalcemia. It can present as ischemia, arrhythmias, and digitalis toxicities, and we will see it in our later slides. There are many clinical manifestations of hypomagnesemia. On the neuromuscular front, it presents as weakness, tremors, muscle fasciculations, and positive Chvostek's and Clauser's signs, and also dysphagia. Arrhythmias are very common in hypomagnesemia, and most common arrhythmia is Torsades de Pointes. It is so common that in my PG classes, in my PG exams, whenever there was Torsades de Pointes, the treatment was by IV magnesium. No questions asked. Coming to central nervous system, depression, agitation, psychosis, nystagmus can be seen in hypomagnesemia. In severe cases, can lead to seizures. It is, as we have seen in earlier slide, is associated with hypokalemia and hypocalcemia. Evaluation of hypomagnesemia is very important. You have to evaluate serum potassium, phosphate, and calcium levels, and you have to also evaluate urea, creatinine, glucose levels. ECGs to be done. A very important decision-making factor would be whether there is a GI loss or renal loss. For this, you have to measure a 24-hour urinary magnesium excretion. This is known as fractional excretion of urine. Here you multiply urine magnesium with plasma creatinine and divide it by multiplication of plasma creatinine and urine plasma magnesium and urine creatinine with 0.7. If this fraction excretion of magnesium is more than 2%, that means a lot of magnesium is being excreted in urine with normal RFT, then the likely cause is magnesium is getting wasted because of drugs like diuretics or aminoglycosides. How do you manage magnesium? You give magnesium. So multiple preparations are available. There are multiple oral preparations available, and parentally you commonly use magnesium sulfate 1 gram injection, which contains 8 milliequivalent of elemental magnesium. As far as doses is concerned, life-threatening conditions like cardiac arrhythmias, torsion pointis, or seizures, you have to load the patient with 2 grams of magnesium sulfate over 5 minutes, followed by 5 gram over next 6 hours and 5 gram every 12 hourly for next 5 days. If the patient has deranged renal function test, then you reduce the doses by 50%. For moderate level of hypomagnesemia, you give 6 grams of magnesium over 3 hours, followed by 5 grams over next 6 hours, and then 5 grams every 12 hours for next 5 days. Mild asymptomatic patients, usually total deficit is 1 to 2 milligram per kg, but 50% is lost in urine, and therefore requirement is twice the calculated deficit. You gave a 1 milligram equivalent per kg for 24 hours, followed by 0.5 milliequivalent per kg for next 3 to 5 hours. Remember, Ringer solution should not be used as diluent for magnesium sulfate because calcium in Ringer will counteract the actions of magnesium. While managing hypomagnesemia and giving magnesium, you have to keep on checking deep tendon reflex every 15 minutes, and periodic monitoring of serum magnesium is required. It is contraindicated in patients with heart block or extreme myocardial damage. Doses, as we have already seen, should be reduced in patients with renal failure. To maintain a urine output of around 30 ml per hour. And if patient shows signs of magnesium toxicity, immediately stop giving more magnesium and give 10% calcium gluconate along with fluid loading and diuretics. When do you stop giving magnesium? So for that, there is a magnesium retention test which identifies the end point of magnesium replacement therapy. Here you measure the urine magnesium excretion and it compare it with the infused magnesium load. So if you give 6 milligrams of magnesium and then you measure 24-hour urine excretion, and if it is more than 80% of the infused magnesium load, that means the magnesium replacement therapy is complete and you will stop giving more magnesium to the patient. Coming to hypermagnesemia, the causes could be decreased renal excretion, which can be seen in acute or chronic kidney diseases, use of proton pump inhibitors, malnourishment, alcoholism, hypothyroidism or hyperparathyroidism or lithium-based drugs. It could also be because of increased intake, like decreased gut motility, use of anticholinergics, opioids, or maybe inflammatory bowel diseases, use of laxative, Bell-Calculi syndromes, and maybe because of management of eclampsia or tetanus patients. And it could thirdly be because of compartmental shift like hemolysis, tumor lysis, or abdomyolysis. Manifestations depend on the level of serum magnesium. If it is more than 4 milliequivalent per liter, there is hyporeflexia, weakness, nausea, dizziness, and confusion. At more than 5 milliequivalent per liter, you can see first degree AV block, bradycardia, and reduction in blood pressure. More than 10 milliequivalent per liter can lead to a complete heart block and can eventually end up in cardiac arrest when the levels are more than 13 milliequivalent per liter. Therefore, it is very prudent that you have to monitor urine output, deep tendon reflex, and respiration whenever you are administering magnesium, and also monitor levels frequently. How do you manage? If the patient has got normal renal functions and the patient is mild asymptomatic, no treatment required, just remove the source of magnesium. In severe cases, monitor blood pressure, ECG, neuromuscular functions, give IV calcium gluconate 10 ml over a period of 10 minutes, and IV normal saline 100 to 150 ml per hour should be started. In severe cases, you also have to give IV loop diuretics and maybe hemodialysis is required. Serial measurement of magnesium is very important, which has to be continued till the magnesium level comes back to normal. Coming to the last part of our presentation today, which is phosphates. So average adult has 500 to 800 grams of phosphate, out of which 85% is in bone skeleton and is in organic molecules. Rest 15% is in soft tissue, which is free inorganic phosphorus, which remains mainly intracellular. Phosphates are used for glycolysis, high energy phosphate production, and the normal value of phosphate is 2.5 to 5 milligram per deciliter. Hypophosphatemia is labeled when serum phosphates are less than 2.5 mg per deciliter, and it can be because of increased renal excretion like diabetic ketoacidosis or osmotic diuresis. The most common cause is intracellular shift, and it is seen because of glucose loading, that is refeeding or oral or enteral feeding. Severe hypophosphatemia is usually seen after 7 days of total parenteral nutrition because of this glucose loading syndrome. It can also be seen because of respiratory alkalosis, use of beta receptor agonists, and sepsis. Also because of decrease in phosphorus absorption from gastrointestinal tract because of use of phosphate binding agents like aluminum binding compound like sucralfate, you can see hypophosphatemia. Usually it is clinically silent but can cause impaired cardiac output and impaired myocardial contractility, and can also present as hemolytic anemias. The oxyhemoglobin dissociation curve shifts to the left, and there is an impediment of cellular energy production. Clinically, very importantly, it is causing muscle weakness, and it is very important for those patients who are on mechanical ventilation in ICU settings. There are two IV solutions available for replacement. One is sodium phosphate and this potassium phosphate. Both contains 93 mg per ml of phosphorus, but the choice of agent depends on whether there is a concurrent potassium deficiency or not. If there is a concurrent potassium deficiency, then probably you should use potassium phosphate. And the doses required are for severe hypophosphatemia, 0.6 mg per kg body weight per hour, and for severe hypophosphatemia with adverse effects, it is 0.9 mg per kg body weight per hour. It is usually reserved for those patients who have severe hypophosphatemia with cardiac dysfunctions, respiratory fatigue, and muscle weakness. You have to monitor phosphorus levels every 6 hours till the level comes to 2 mg per deciliter, and then probably once daily phosphorus levels are to be measured. Coming to hyperphosphatemia, it is caused by impaired phosphate excretion as seen in renal insufficiency and widespread cell necrosis like rhabdomyolysis, tumor lysis, hemolysis, and acute leukemias. It can manifest as formation of insoluble calcium phosphate complexes, and also because of acute hypocalcemia, which is seen with hyperphosphatemia, patient will present with tachycardia, restlessness, anorexia, nausea, vomiting, tetany, tingling in numbness of finger lips, and muscle spasm. Two-pronged management approach is suggested for treatment of hyperphosphatemia. First is to promote phosphate binding in GI tract by using calcium acetate tablets. Another is hemodialysis in patients with renal failure. Also, it is important to avoid phosphate enemas in settings of impairment in kidney functions. This brings us to the end of our lecture for the day, and I would like to wish all the best to all of you for your exams. Thank you.
Thank you, Dr. Akhil Agrawal.
Thank you, Dr. Singh. It was a pleasure participating on this platform.
Yes, good. So to continue, our next speaker is lecture is on extubation guidelines. So for this lecture, I invite Dr. Michael Gulavani, who is speaking on extubation guideline, and extubation is our primary important for ICU care patients. So Dr. Michael Gulavani is assistant professor in anesthesia. Affiliation is in UCMS and GTBM New Delhi. His area of interest is difficult airway, neuroanesthesia, obstetric anesthesia, as trauma anesthesia. So I invite Dr. Gulavani, please.
Good morning, everyone. I'm Dr. Michelle Gulavani, Assistant Professor Anesthesia at UCMS, and I would like to talk on extubation guidelines. Now, to make our topic relevant and interesting, let's begin with a case. This is a 35-year-old male who was a known tobacco chewer with post-COVID-19 rhinoorbital cerebral mucormycosis and was scheduled for bilateral sinonasal debridement and bilateral orbital exenteration. On examination of the nose and oral cavity, the patient had excoriating discharge from both his nostrils with a hard palate perforation. Swelling was present on both the cheeks with a huge abscess on the left side. Pre-operative airway evaluation of the patient revealed a mouth opening of only 1 finger, an MPG of 4, thyromental distance of 4.5 centimeters, and a receding mandible with normal neck flexion and extension. The patient was RT-PCR negative for COVID-19 and microbiologically confirmed case of mucormycosis when he was scheduled for the surgery. On this image, we can clearly see that the mouth opening is extremely reduced and there is swelling on bilateral cheeks, making it not only a difficult intubation, but also a challenging mask ventilation, and the abscess is seen on the left side. Here we see that the thyromental distance is also reduced and he has a receding mandible and the abscess is more clearly seen. So definitely it is a case of anticipated difficult airway and challenging intubation. Therefore, we went ahead with an awake technique using an ambuscope, which is a flexible video scope. The tracheal tube was placed successfully and capnographically confirmed with the intraoperative course, which went on uneventfully. Now, the question is whether to extubate this patient, how and when, whether in the OR or at a later date. So to understand these, let's begin with our study on extubation guidelines. So when we talk on extubation guidelines, the most commonly used ones are the Difficult Airway Society guidelines, which have divided extubation into 4 steps. Step 1 is planning extubation. Step 2, preparation. Step 3 is performing. And step 4 is post-extubation care, including recovery and follow-up. So step 1, planning. So how do we plan? Based on general and airway risk factors. So we categorize the patients into low risk and at risk for extubation. A low risk extubation is one which is uncomplicated or having a normal airway at induction, which also remains unchanged at the end of surgery, and no other general risk factors are present. So what are the general risk factors we are talking about? It could be a cardiac or respiratory comorbidity the patient already has, any neurological impairment, any coagulation factor abnormality, temperature, hypothermia, any acid-base disorder. So all these general factors, if they are within the normal limits and the airway is not difficult prior to intubation, then we know that we are dealing with a low-risk extubation. However, an at-risk extubation is one in which already there is a pre-existing difficult airway, like in our case, or a perioperative airway deterioration due to trauma, bleeding, debris, which have made the airway, which was not so difficult pre-operatively, but during the course of the surgery has now become difficult. Or if there is a restricted airway access, suppose there's a common or a shared field between the surgeon and the anesthetist restricting the airway access. So the at-risk extubation has also been defined by the practice guidelines for the management of difficult airway as a loss of airway patency and adequate ventilation after removal of a tracheal tube or supraglottic airway from a patient with known or suspected difficult airway. Step 2 is preparation for extubation. So for that, you have certain patient factors, like in the airway, you check whether the bag mask ventilation is possible. If there are edema, blood clots, foreign body or trauma, that should be assessed by direct laryngoscopy. A cuff leak test checking the subglottic caliber and the presence of an audible leak is a reassuring sign. Of course, gastric decompression will be necessary if high pressure face mask ventilation has been used at induction. And of course, then you have to optimize the general factors which we've discussed about. The neuromuscular blockage should be fully reversed with a train of 4 of 0.9 or more. The patient should be hemodynamically stable, acid base, electrolyte, temperature, coagulation should all be within normal limits, and adequate analgesia is very important prior to planning extubation. Then optimization of logistic factors. Extubation is always an elective process and should be carried out in a controlled manner with the same standards of monitoring, equipment, and assistance as needed for induction. Communication between the surgeon, anesthetist, and the entire team is vital for a successful extubation. Step 3 would be performance of extubation. Now, according to the low risk and at-risk extubation, the general principles remain the same. That is pre-oxygenation before extubation, keeping the FiO2 of 1 and an end-tidal oxygen of more than 80. Patient position, although no evidence on a universal patient position is there, but there is an increasing trend towards keeping a head-up position. Suction should always be done under direct vision of a laryngoscope, especially if soiling, blood, or secretions are present. Alveolar recruitment maneuvers, like applying PEEP, is commonly practiced using our modern ventilators. Another technique is simultaneously deflation of the tracheal tube cuff and removal at the peak of sustained inflation that generates a passive exhalation, expelling and reducing all the secretions and thus reducing the incidence of laryngospasm and breath holding. So a bite block, which is commonly employed, it prevents occlusion of the tracheal tube during emergence from anesthesia, and it hence prevents forced inspiration against an obstructed airway, leading to negative pressure pulmonary edema. So the two broad methods of extubation would be a fully awake one, which is safer as the airway is secure and the patient can maintain his or her airway. And of course, then there's the deeply anesthetized one, which reduces the pressure response like bucking, hypertension, tachycardia, but it requires intense monitoring, vigilance, and expertise, not only in the OR, but also in the PACU area. So the DAS extubation guidelines have a basic algorithm on these 4 steps of planning, preparation, performing, and post-extubation care, and they risk stratify the patient to the low risk and at risk following the same principles. And then there is a separate low risk and an at risk algorithm. So the low risk algorithm, we can either fully awaken the patient and extubate following the same general principles in which you pre-oxygenate with 100% oxygen, suction, and establish an adequate breathing by antagonizing the neuromuscular blockade, ensure adequate spontaneous ventilation, and wait till the eye opening is there and response to commands is there, apply positive pressure ventilation, deflate the cuff and remove the tube, check the airway patency and continue oxygenation till then. And also you can do a deep extubation if it is a low risk patient, or you can use advanced techniques, which we'll just be talking about. And vigilance and expertise is very essential if you're using a deep extubation technique. Now, if we have a look at this at-risk algorithm, so the patients we've categorized into low risk and at-risk. So our at-risk patients for extubation, the key question here is whether you can safely remove the tube, yes or no. If you do not plan to remove the tube, you can either postpone the extubation or you can go ahead with an early tracheostomy. So if you postpone the extubation, you shift the patient on mechanical ventilation to the ICU or the critical care unit, or you can do an early tracheostomy. Suppose there are certain malignancy surgeries in which you also do flap reconstruction and you expect that the extubation will not happen very soon. Then you can plan for a tracheostomy to reduce the airway edema and the laryngeal edema, and you can even go ahead with an early tracheostomy to make the weaning helpful for your patient. But if you do plan to extubate the patient, then you can use your awake technique, which is safer because your patient is already an at-risk patient for extubation, or you can use one of these advanced techniques, which are the laryngeal mask exchange, the remifentanil technique, or the airway exchange catheter assisted extubation. So let's look at each one of them in detail. So first would be your LMA exchange or your Bailey maneuver, in which you exchange a tracheal tube with the LMA to maintain a patent and unstimulated airway. Now, before the LMA insertion, you must do a direct laryngoscopy and suction. Insert the deflated LMA behind the tube and inflate the cuff of the LMA. Now, deflate the tracheal tube cuff and remove it while maintaining positive pressure ventilation. It is useful in cases when you want a stress-free extubation, especially when you don't want to disrupt the surgical repair, and also is useful in smokers, asthmatics having irritable airways, and in certain ischemic heart disease patients in which the pressure response like hypertension, tachycardia, which happen at extubation could be detrimental in them. But the caution here is it should not be used when re-intubation would be difficult or there is a risk of regurgitation. So patient selection should be appropriate before planning extubation via a Bailey's maneuver. Then we have the remifentanil infusion technique. Now we all know that remifentanil is an ultra short acting opioid that reduces the harmful effects of pressure response at extubation. It provides the beneficial combination of a tube tolerant patient who obeys commands. Before the end of the procedure, set the infusion rate to the desired level of remifentanil, antagonize your neuromuscular blockade, at the appropriate phase of the surgery. Discontinue your anesthetic agent, be it the inhalational one or propofol. Continue ventilation. Laryngoscopy and suction should always be performed under direct vision if appropriate. Do not rush or overstimulate. Wait till the patient obeys to your verbal commands. Stop positive pressure ventilation. If spontaneous respiration is adequate, remove the tracheal tube and stop the remifentanil infusion. After extubation, monitor the patient closely. Success of this technique lies in the removal of the hypnotic component of anesthesia well before extubation and careful titration of your remifentanil. Then the third technique is the airway exchange catheter assisted extubation. Now, airway exchange catheters are routinely employed in all your ORs, and they are long, thin, hollow tubes made up of semi-rigid thermostable polyurethane. They are blunt-ended with distal terminal and side holes, radiopaque, and have length markings on the exterior surface. As you can see, here are the various length markings, and normally you don't go beyond the 25 centimeter mark. They also have 15 mm Luer lock connectors in which you can use it for the breathing circuit connection. They can also be used as a guide over which the tracheal tube can be passed if there is a need for reintubation and need to oxygenate the lungs. They have also been used for high pressure jet ventilation in emergency scenarios. And it is important to decide how far to insert your AEC. As we have said, it should normally not be inserted beyond the 25 centimeter mark in an adult patient. And when the patient is ready for extubation, advance the AEC at the predetermined length. Never insert it with resistance. Pharyngeal suction should be done before removal of the tracheal tube, and remove the tracheal tube over the AEC while maintaining its position. Record the position of the AEC. It can be normally left to even up to 72 hours. Now, step 4 would be post-extubation care, recovery, and follow-up. Oxygen must be administered when the patient is being transferred to the recovery with appropriate monitoring. Trained staff and an anesthetist must be available till the patient is fully awake. Capnography aids timely detection of airway obstruction. Good communication between the surgeon and anesthetist is vital in the recovery and PACU area. Verbal and written instructions should be given during handover. Close observation of the patient's vital signs with level of consciousness, temperature, and pain score should be made. Now, a word about the All India Difficult Airway Association guidelines for safe airway management in a COVID-19 patient in the OR. So, airway management procedures, especially tracheal extubation, is a high aerosol generating procedure. So these guidelines have recommended that ideally it should not be performed under the light plane of anesthesia to prevent coughing and agitation. Tracheal suction should be performed only if required, and that too using a closed suction system. Prophylactic antiemetics should be given at the end of the procedure to reduce the risk of vomiting and hence the viral spread. Tracheal extubation should be performed under a transparent plastic sheet or a COVID box. Nebulization with saline or bronchodilators should be avoided. Airway manipulation or airway exchange procedures should be avoided during extubation. And tracheal extubation can be delayed if there are concerns of a failed extubation. These are my references. Now about the case. Did we extubate the patient in the OR? No, we did not. We shifted the patient on mechanical ventilation to the ICU. And then after 24 hours, when the edema subsided, we awakened the patient, and using an airway exchange catheter, we did the extubation so that we could safely extubate the trachea in this case. 3 days after the operative procedure, the patient was shifted to the ward, and subsequently his course was uneventful in the hospital. And that's how we planned an anticipated difficult airway in a awake intubation and a safe extubation using an airway exchange catheter. And that too 24 hours later, we waited for the edema to subside. So safety comes always first. Therefore, it's important to remember that extubation is elective and we should never be in a hurry. Patient selection criteria is really important while planning for extubation, and remember the guidelines and proceed accordingly. Best of luck. Thank
you. Unmute, sir.
Sir, kindly unmute yourself. Singh, sir.
Yeah. Yeah, thank you, Dr. Michael Gulavani, and thank you, Dr. Akhil Agrawal, for excellent covering the topic. And I think the students who are going to appear in exam, they are benefiting a lot by these lectures. So I think there are some questions in chat box.
No, sir, there are no questions.
Achha, okay. Thank you for inviting me for this sharing session in your this activity. Thank you.
Most welcome, sir. Thank you, sir. And thank you to the speakers for their wonderful presentation, for lucidly explaining such topics in a very interesting way. Thank you so much.
Thank you.
So before we move on to the quiz, the first quiz of the day, I would like to announce the winner of yesterday's quiz, the last quiz that occurred at 6 o'clock, the 10 MCQs quiz. So I'm happy to announce that the winner is Dr. Avinash. He is a postgraduate student from ABVIMS and Dr. RML Hospital. Many congratulations to Avinash. We'll move on to the first quiz of the day. Can we have the MCQs, please? So the first MCQ is, which of the following statements is false about the new drug Remimazolam? A, it is an ultra-short acting TIBA drug. B, it has benzodiazepine and opioid properties. C, it is a GABA receptor antagonist. Or D, it is a soft drug with organ-independent and metabolizing properties. The next are all except A, at-risk extubation, B, jet ventilation, C, elective intubation, or D, re-intubation. Okay. So we'll quickly have a tea break and we'll resume our sessions from 10:10 for our first lecture. Thank you. I welcome once again after the tea break. So we'll move on to our next session after the tea break. And to chair this session, I would like to introduce our chairperson, Professor Bimla Sharma. Ma'am is a senior consultant and is vice chairperson at Sir Gangaram Hospital, New Delhi. And ma'am's area of special interest are extraglottic airway devices, palliative care, and pain management. We welcome you, ma'am. Ma'am, can you unmute? Yeah.
Yeah. Yes. Thank you very much.
Good morning, ma'am.
Nandi, good morning. Good morning. Good morning, everybody. So, and at the outset, I would like to thank Dr. Kaur, Dr. Akhilesh, Dr. Nirja, and her team for inviting me for this session. And I'm sure the PGs will, they are going to benefit a lot. And we are covering a very important topic, that is a neuraxial block. And our first speaker is Dr. Apurva Agarwal. He is professor and head Department of Anesthesia, Critical Care and Pain Management. And he's also the honorary secretary, ISA UP State Associate, and also an associate editor for the Indian Journal of Anesthesia for the Central Zone Supplement. And he is at Rajkiya Medical College, Jalan, and his areas of interest are pediatric anesthesia and regional anesthesia. So, Dr. Agarwal.
Thank you so much.
Good morning, everyone.
Thank you, ma'am.
The topic allotted to me today is neuraxial blockade. And I am Dr. Apurva Agarwal, Professor and Head, Department of Anesthesiology, Critical Care and Pain Medicine at Government Medical College, Jalan. At the outset, I would like to thank the organizers for giving me this opportunity to present before you this topic. Before embarking to my lecture, I would like to quote a phrase from Dr. Lee, who said that quality of anesthesia can be defined by 6 domains. That is, it should be effective, equitable, timely, efficient, safe, and patient-centric. And I am very happy to say that neuraxial blocks meets all these 6 criteria. In the terms that it is done in a timely fashion, it is very efficient, it is very safe, and it focuses mainly on the patient. So that's why the term quality anesthesia suffices to neuraxial blocks. The spinal, epidural, and caudal blocks are collectively known as neuraxial blocks. Each of these blocks can be performed as a single injection or with a catheter to allow intermittent boluses or as a continuous infusion. These blocks result in sympathetic block, sensory analgesia, and motor block depending upon the dose, volume, and concentration of the local anesthetic. Spinal anesthesia is a very reliable because there is an endpoint to it, and the endpoint is the backflow of the CSF, which is a clear indication of the successful needle placement, and the local anesthetic spreads easily through the CSF medium. In the first year of residency, it is expected from the residents to successfully perform a good spinal anesthesia, and more than 90% of the success rate can be achieved just after 40 supervised spinals. Here I would also like to quote a word by Dr. Bala Venkat, who said that central neuraxial blockade, especially the spinal anesthesia, is a boon to the anesthesiologist. However, the complications are more likely the consequence of complacency, and we shall prevent them. Complacency in the term that we think that it is the perfect, but we still need to improve onto it. And the more we improve onto it, the lesser will be the chances of the complications. A word about the history of neuraxial blocks. After the first spinal anesthesia, which was performed in dogs in 1885, August Bayer in 1898 performed the first spinal in humans, and at that time it was performed with cocaine. After that, ligno came into picture. However, bupivacaine came into picture in 1966. Epidural anesthesia was first performed in 1901 by Kathleen and Segard, but it was only in 1949 when the first extradural catheter was placed. Higginson popularized the technique of continuous caudal anesthesia. In 1947, there was a famous case in which two patients, Mr. Woolley and Mr. Rowe, who suffered paraplegia on the same day following spinal anesthesia given by the same anesthesiologist, Dr. Graham, for two very simple procedures, one meniscectomy and the other repair of the hydrocele. Later, it was proved in the court that it was not the negligence of the anesthesiologist, but rather, at that time, disposable syringes were not being used, and the glass syringes which were re-sterilized were adulterated with an acid content used for descaling. This led to the paraplegia, but it has created a bad publicity of the neuraxial blocks for 2 decades. However, over the years, due to the several advantages of regional anesthesia, it again came back into widespread use. There are many advantages of regional anesthesia. It avoids pulmonary complications, and it is an alternative to general anesthesia for high-risk patients, especially difficult airway and respiratory diseases. Various respiratory complications like bronchospasm, laryngospasm, postoperative atelectasis, and the systemic side effects of general anesthesia are not seen. All the complications of intubations like cardiovascular response and failed intubations are obviated. The disturbances of the body chemistry is also very minimal. Bleeding is also very less because of the low mean arterial pressure, and there is decreased incidence of thromboembolism due to the increased vascularity of the lower limbs. It gives a better postoperative analgesia and the patient remains awake. However, there are some disadvantages too. The motor paralysis persisting in the postoperative period may be very disturbing for some of the patients, and some complications like hypotension or post-dural puncture headache may be there, and it may be time consuming also. We must know the surface anatomy before proceeding for neuraxial block. C7 corresponds to the most prominent vertebra in the neck. T7, the inferior angle of the scapula. L4 is the line connecting the iliac crest. S2 is the line connecting the posterior superior iliac spine. And sacral hiatus is the groove or depression just above or between the gluteal clefts above the coccyx. We must know about the dermatomes for providing and checking the successful block. T8 corresponds to the little finger. T1 and T2 to the inner aspect of the arm. T4 to the nipple line. T7 to the inferior border of the scapula or the tip of the xiphoid. T10 is the umbilicus. L1 and L2 is the inguinal ligament. L2 and L3 is the anterior thigh, and S1 is the heel of the foot. What are the level of the blocks required in different surgeries? So, for chest surgery, a C4 level or up to the level of the clavicle is required, but this is very dangerous. T4 and T5 is required for upper abdominal surgery. T8 for lower abdominal surgery. T10 for pelvic surgeries. L1 is required for the thigh surgery. A level of L2 or L3 may be required for foot surgeries, whereas for perineal surgeries, a level of S2 and S5 is required. We must know about the spinal cord anatomy as well. The spinal cord extends from the foramen magnum to the lower border of the L1 in adults and to L3 in the children. It is about 45 centimeters long in adult. The dura, subarachnoid, and the subdural space extends up to S2 in adults and S3 in children. That is why we must be very careful while giving caudal in children so as to not accidentally puncture the dura. The spinal cord gives 31 pairs of spinal nerves. The extension of the pia mater, called as the filum terminale, penetrates the dura and attaches the terminal end of the spinal cord, that is the conus medullaris, to the periosteum of the coccyx. The sympathetic nervous system arises from the intermediolateral cord of the thoracic and the lumbar segments. That is why sympathetic system is said to be thoracolumbar in origin. As we can see from the diagram, there is kyphosis in the thoracic segments and lordosis in the lumbar segments. Knowing this anatomy will help us guide in the proper placement of the needle in the subarachnoid space, because as we see that there is lordosis in these lumbar segments, the needle direction must be directed cranially so as to land up into a subarachnoid space and get a good CSF flow. A very frequent question asked in the examination is, what are the structures encountered while administering spinal anesthesia? So from out to inside, these are the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament, followed by the ligamentum flavum, which is the yellowish tissue, followed by the epidural space, then the dura mater, followed by the subdural space, and finally the subarachnoid matter. Other important facts are the cardiovasculator fibers are located from T1 to T4 segments, and the high blockade up to the level of T1 or T2 may result in severe bradycardia and a decreased cardiac contractility, leading to severe hypotension. Sympathetic tone and vasomotor fibers are located from T5 to L1 segments. Therefore, blockade of these segments lead to vascular dilatation, hypotension, and a contracted gut. This contracted gut will be helpful for the surgeons for a proper anastomosis during the time of laparotomy. T4 to T8 is the most dependent portion of the spine when the patient lies supine, and this is where most of the drug settles when the patient is placed supine after spinal anesthesia. Before administering spinal anesthesia, a proper preoperative preparation is very imperative. You must ask the patient what are the concurrent medications he is on. A lot of patients are on anticoagulants and antiplatelets. If the patient is on a beta blocker and after spinal, if the heart rate further dips down, then atropine may not work in these patients. Hence, adrenaline must be kept handy. Ask whether the patient is on any antihypertensive drug or not, as there may be an accentuated fall in the blood pressure after spinal anesthesia in patients who are already on antihypertensives. We must also assess whether the patient is having resting tachycardia or not. Diabetics mostly have resting tachycardia, and this may lead to severe hypotension in the post-spinal period. If the patient is on NSAIDs, we do not stop the NSAIDs before any neuraxial block. Even if the patient is on aspirin, up to the dose of 300 mg per kg per day, we do not stop aspirin. But if the patient is on clopidogrel, we stop it 5 to 7 days prior to the surgery. For patients on unfractionated heparin, we give the dose subcutaneously or IV 4 hours before the surgery, and this can be restarted 2 hours after the surgery. While for the patients on low molecular weight heparin, it can be given 12 hours before the surgery and restarted 2 hours after the surgery. For patients on warfarin, INR must be kept below 1.5 for any surgical procedure. Though looks simple, but a thorough preoperative checkup is very essential before proceeding for spinal block. Any skin lesion or infection in the lumbar region, any scar present in the spine must be looked for very meticulously. Presence of a tuft of hair in the spine may suggest a spinal fusion deformity or the presence of a meningomyelocele. In these cases, administering spinal anesthesia may prove to be difficult. If necessary, the radiology of the spine, the AP and lateral view may help us guide that in which segment this space is more or less, and this may help us in choosing the correct space for the spinal. Like in this X-ray, we can see that the space between the L4 and the L5 vertebrae is very reduced as compared to the space in the L3 and L4 or L2 and L3 vertebrae. Here the space is more, and therefore giving spinal in these spaces can be very fruitful. Sometimes the presence of the scar may be because of previous spinal fusion surgeries, and this may once again prove to be very difficult for administering a spinal. So full preparation for general anesthesia or alternative form of anesthesia must be kept handy before administering any regional blocks. Needless to say that 2 wide bore cannula, which are fully functional and placed intralumen, must always be present before administering any regional block. In a properly hydrated patient, or if the patient is preloaded or co-loaded with adequate fluids, the hypotension which ensues after spinal anesthesia will be very less. Around 20 ml per kg of crystalloid is what is recommended, keeping it judicious for those with severe cardiac ailments. Now, the next two slides of my presentation are very important. The placement of the spinal needle in the subarachnoid space breaches all the defense mechanism of the central nervous system, leading to neurological sequelae, meningitis, arachnoiditis, bleeding, and hematoma formation. Hence, proper aseptic precaution must be adhered to while performing any procedure. A strict 2-minute hand scrubbing with chlorhexidine solution is mandatory. 2 minutes may look like an hour to you, but with proper scrubbing, donning of the surgical gown, gloves, cap and mask may prevent most of the infections. Furthermore, use of powder-free gloves may prevent chemical meningitis. Most of the residents, if they add an adjuvant, they mix it with local anesthetic, but they should not be practiced, as it alters the pKa of the local anesthetic and the effect of the drug may change. There may be medication errors due to lookalike ampules, and it has been reported very frequently in literature that tranexamic acid has been administered intrathecally, and this may lead to severe complications and even death of the patient. Do not load the drug given by the sister or any staff unless and until you have yourself inspected the drug and the expiry date. Bradycardia occurring just after the institution of spinal may be due to the effect of the local anesthetic drug per se, but bradycardia occurring 20 minutes after spinal anesthesia may be due to the effect of the adjuvant, and most commonly this is due to clonidine. A subarachnoid block can be given in various positions. The most common position utilized is the sitting position. A line is drawn connecting the highest point of the iliac crest, and this is called as the Toothier's line. This crosses the body of the L4 vertebra or the L4-L5 interspace. For a successful spinal in the sitting position, it is imperative that the patient sits properly so that the posterior superior iliac spines are in one line. These posterior superior iliac spines should be in one line. Sometimes administering spinal in the sitting position may lead to severe vasovagal attacks, and that is why the anesthesiologist must be in constant communication with the patient, and when the patient goes silent, we must immediately lie him down and raise his legs. Lateral decubitus position is also preferred by many, especially in old age patients, but a proper assistance is needed for the patient to be properly flexed in the chin to chest. This is the chin to chest or the knee to chest position. Utilization of the ultrasound may also help us in guiding the proper placement of the spinal needle. Linear probes are utilized for thin patients, whereas curvilinear probes are required for obese patients. The probe can be placed in the paramedian sagittal plane, or they can be placed transversely. Identification of the posterior complex or the anterior complex is what is required. Placement of the needle between the posterior complex and the anterior complex will lead to successful subarachnoid block. Most commonly, a midline approach is utilized for spinal anesthesia. However, in patients in which midline cannot be ascertained or the ligaments are calcified, lateral approaches can also be utilized. If the midline cannot be identified, I usually follow the intergluteal cleft, which is generally in the midline. I utilize this sheath of the spinal needle, which is around 13.5 centimeters in length, and place one end of the sheath in the intergluteal cleft and the other end cranially in the vertical direction. This guides me in finding the midline appropriately. Paramedian approach is utilized when the ligaments are calcified or there is difficulty in flexing the spine. The needle is placed 1 centimeter inferior and 1 centimeter lateral to the superior spinous process. The needle is directed 10 to 25 degrees towards the midline. Alternatively, Taylor's approach may be utilized for patients whose spine is fused, or the spine is arthritic, or those who have infection at the lumbar spine. The point chosen is 1 centimeter medial and 1 centimeter inferior to the posterior superior iliac spine. The spinal needle is entered through this point and is directed around 45 to 55 degrees medially and cranially. And you land up in a good space and you get a good CSF flow. This is what is called as the Taylor's approach. The spinal needles utilized can be of two types. It can be dural cutting needles like Quincke's or Babcock's, or it can be dural splitting needles like Whittaker's or Sprotte's. If a continuous spinal technique is chosen, then either Toohey's or Husted's needle can be utilized for easy passage of the catheter. These spinal needles are color coded according to the sizes for proper visual guide. Spinal anesthesia produces a differential blockade with autonomic blockade followed by sensory, and which is followed by the motor block. So the sympathetic block is 2 to 6 segments higher than that of the sensory level, whereas motor block is 2 segments lower than that of the sensory level. It is very important for the residents to remember that the sympathetic block is 2 to 6 segments higher than that of the sensory level, and that is why the accentuated hypotension in patients who are taking antihypertensives or in those who are diabetics with autonomic neuropathy, the hypotension may be much higher. Sensitivity to the blockade is determined by the axonal diameter, the degree of the myelination, and the anatomy. So what is the order of the blockade of the nerve fibers? First, the autonomic preganglionic beta fibers are the first to be blocked, followed by the temperature sensitive C fibers. After this, the A delta fibers, which carry pinprick, are blocked, to be followed by the A delta fibers carrying light touch. Somatic motor fibers carried by the A alpha fibers, followed by the vibration, and the proprioceptor receptors are the last to be blocked. So I'll repeat it once again. The order of the blockade of the nerve fibers is first is the preganglionic beta fibers, followed by the cold C fibers, followed by the pinprick or light touch A delta fibers, followed by A beta fibers, then the somatic motor fibers carried by the A alpha, and the last to be blocked is the vibration and the proprioception receptors. Now, how to assess for the block? Sympathetic block can be measured by measuring the skin temperature or by placing a cold saline and asking whether the patient feels this temperature difference or not. Followed by the sensory block can be done by the pinprick, whereas motor block can be assessed by a modified Bromwich scale. Grade 1 block is free movements of the knees and feet. Grade 2 block is some movement of the knees but free movement of the feet, and this suggests around partial or 33% block. Grade 3 block is unable to move the knees, whereas grade 4 block is unable to move the feet or leg. Now, what is baricity? Baricity is the ratio of the densities of the local anesthetic with that of the CSF. A solution can be made hypobaric by addition of distilled water, whereas it can be made hyperbaric by addition of 7.5% or 8% dextrose. So a hypobaric solution will move caudally with Trendelenburg position. So this is a hypobaric solution. This moves caudally with Trendelenburg position, whereas it will move cranially with anti-Trendelenburg position, as opposed to a hyperbaric solution which will move cranially with Trendelenburg position, or it will move caudally with anti-Trendelenburg position. We have various drugs for neuraxial blocks: lignocaine, bupivacaine, and with the introduction of 0.75% and 0.5% lopivacaine, along with 0.5% levobupivacaine, it has added to the drug armamentarium of the anesthesiologist, and they are very safe and produce very reliable anesthesia. Various additives in the form of fentanyl, clonidine, neostigmine, epinephrine, and dexmedetomidine are also there. These adjuvants has been utilized to increase the duration of the sensory analgesia and may even increase the motor paralysis. Now, what are the factors which affect the level of the spinal anesthesia? Of them, the drug factors are the baricity of the drug and the dose of the drug. I have told you previously about the baricity. As you increase the dose of the drug, the level of the block also increases. Patient factors may be age. So as the age increases, lesser amount of the local anesthetic will travel upwards because of the reduced CSF space. If the CSF volume is high, the drug will be diluted more and it will not ascend upwards. Pregnancy also plays an important role by increasing the intrathecal pressure and increasing the lumbar lordosis, leading to higher spread of the local anesthetic cranially. Position is also very important, as placing the patient in the sitting position will produce a saddle block, whereas placing in the Trendelenburg position will lead to cranial migration of the drug. Other less important factors may be temperature, viscosity, weight, height, and the fluid currents. So what is the fate of the drug when it is injected into the CSF space? Within the first 2 minutes, there is mixing and dilution in the CSF. In the next 2 to 6 minutes, 50% of the drug is absorbed into the neural tissue and it starts to block the neural fibers. However, after next 20 minutes, 15% of the drug still floats in the CSF and is available for further blockade. Finally, after 20 to 25 minutes, the drug is absorbed vascularly and is eliminated. This is very important for very small surgical procedures like an anal dilatation or the procedure less than 15 minutes. If you have administered spinal anesthesia, please do not leave the patient unattended before 30 minutes because the drug may ascend upwards and may produce severe hypotension and other complications. Now, what are the contraindications of spinal anesthesia? The first and foremost absolute contraindication of spinal anesthesia is patient refusal, followed by infection at the local site, coagulopathy, severe hypotension, and severe stenotic lesions. Relative contraindications may be sepsis, spinal deformity, or pre-existing neurological deficits, but we must document that the patient already had some neurological deficits so that he does not blame the anesthesiologist for producing it during this anesthesia. Coming to the complication, the most common complication after spinal anesthesia is hypotension, and it can be prevented by preloading or co-loading with crystalloids up to 20 ml per kg. Use of symptomatic drugs like ephedrine, phenylephrine, or mephentamine can be used. Use of phenylephrine is done when there is tachycardia. Other common complications like respiratory depression, bradycardia, transient neurological complications, nausea and vomiting, and urinary tension. I will not go into the details of this, but I would like to touch upon a point of high spinal versus total spinal. High spinal is when the dose of the drug exceeds for that individual, whereas high spinal of central axial blockade is produced, leading to hypotension and bradycardia and respiratory depression or apnea. The patient may also become unconscious. Apnea and respiratory depression is primarily due to decreased blood supply to the cardiac centers in the brain, whereas total spinal is when the drug reaches the cranial subarachnoid space, leading to ischemia of the vital control centers and cranial nerve palsies. Management of high spinal and total spinal is done in the same way by maintaining the airway, breathing, and circulation, giving judicious amounts of fluid, and starting vasopressors. Patient needs to be ventilated for around 2 to 4 hours, and as the effect of the drug will wear off, the patient regains consciousness if other vital signs are normal, followed slowly by a movement of the arms and legs. Aphonia is another rare complication. It is a transient loss of voice following combined spinal epidural technique, and this has been attributed to the addition of the fentanyl with local anesthetic. Coming to the PDPH, which is one of the most common encountered complications after spinal anesthesia or accidental dural puncture while performing epidural anesthesia. It is due to leakage of the CSF with resulting traction on the dura and the tentorium and vasodilation of the cerebral blood vessel. It usually occurs 24 to 72 hours after dural puncture, and the headache is typically bifrontal and occipital, which gets worse in the upright or during cuffing or straining. Headache is accompanied with nausea, vomiting, photophobia, tinnitus, and diplopia. Other mechanism responsible for PDPH following CSF leak is increase in the cyclic AMP, which results in cranial blood vessels being dilated. Or there may be increase in the neuropeptides or nitric oxide synthetase, leading to increase in the nitric oxide, which results in extracranial blood vessels being dilated. There is also an increased nociceptive signal transmission following CSF leak, and the CSF density may also decrease. There may also be increased sympathetic transmission. All these mechanisms leads to post-dural puncture headache. As has been previously stated, that the dural fibers run longitudinally and are arranged parallelly. But the electron microscopy of the dura reveals that the dura is made up of fibroblasts interspersed with extracellular collagen and elastic fibers. It is made up of 3 layers in which the collagen is interwoven in the lamina and oriented in various directions. Hence, the previous theory that the dural fibers run longitudinally and parallel doesn't stand true. See the electron microscopic picture of the dural lesion produced by the Quincke's needle or that produced by the Whittaker's needle. This clearly states that the Quincke's needle produces a linear flap in the dura, whereas the Whittaker's needle produces an unorganized hole. Now, do smaller needles prevent PDPH? Frumin used 32 gauge BD needles, but still PDPH happened. So it is not the size of the needle which actually prevents the PDPH, but the technique in which the needle is introduced. So the Quincke's needle, if inserted perpendicularly to the dura, a valve can open in either direction depending upon the pressure differential. Whereas if the bevel is facing away from the dura, like in this picture, we can see that the bevel, this is the bevel and this is the dura. So bevel is facing away from the dura. So the valve is formed outwards. Due to the CSF pressure will actually keep the valve open and the CSF leak will always happen. But if the bevel is facing the dura, the valve will open inside, and after you have withdrawn the needle, due to the effect of the CSF or due to the CSF pressure, the valve will close and there will be no further CSF leak. This can also be clearly depictable by the potato peel theory, in which the peeler is facing outwards, the valve will open outwards. Whereas if the face of the peeler or the bevel of the peeler, if it is facing the potato, the valve is formed inside, hence preventing further CSF leak. Now, how to prevent PDPH is by bed rest, using saline instead of air in the LOR technique for epidural catheter placement, or delayed removal of the intrathecal catheter in cases of accidental dural puncture. And some people advocate the use of prophylactic epidural blood patch, but I have never used a prophylactic epidural blood patch. For therapy, PDPH, it is generally self-limiting. However, therapy revolves around adequate bed rest, adequate hydration, analgesics in the form of paracetamol, using a high dose of caffeine. Red Bull energy drink is one drink which contains around 32 milligrams of caffeine in 100 ml, and the gold standard therapy is epidural blood patch. But how many of you have actually seen a patient being administered epidural blood patch for PDPH? I hope very few. So what is in between these other therapies? The other therapy is use of xanthanol nicotinate, or what is commonly known as complement retard. It's an old age medicine which comes in around 500 milligram, and it is used twice daily for 3 days. Headache usually responds after 2 doses. I have used in many patients and it works beautifully. It is a vasodilator and increases the glucose metabolism in the brain ATP levels and elevates the concentration. Some people have also tried the use of neostigmine and atropine 8-hourly for 3 days. Neostigmine increases the acetylcholine in the CSF and also inhibits the uptake of the acetylcholine by the choroid plexus, causing increase in the CSF. It can also lead to some cerebral vessel constriction. Atropine blocks the effect of the acetylcholine on the choroid plexus and increases the CSF, and also blocks the sphenopalatine ganglion, causing cerebral vasoconstriction, thereby alleviating the headache. Other methods utilized to get relief from the PDPH is greater occipital nerve block. The occipital protuberance is felt and a line is joining the greater occipital protuberance and the mastoid process. A point is marked 1/3 medially and 2/3 laterally from the greater occipital protuberance. This is the point where the greater occipital nerve travels. Blocking this nerve with 1.5 to 2 ml of the local anesthetic relieves the pain. It is a very simple block to perform and it can be done at the bedside. Other block which can be done is the sphenopalatine ganglion block, and this is also very simple block and can be done by simple soakage of the cotton pledget with 5% xylocaine jelly and placed in both the nostrils. This anesthetizes the sphenopalatine ganglion, causing cerebral vasoconstriction and relief from headache. A beautiful paper written by Dr. Sunil Malik and Dr. Shiv Kumar Singh advocates the use of nerve and ganglion dual block for PDPH, which utilizes greater occipital nerve block as well as sphenopalatine ganglion block for relief from PDPH. Epidural blood patch, though a gold standard for the treatment of PDPH, is quite cumbersome and utilizes two persons at the same time. One withdraws fresh blood around 20 to 30 ml in an aseptic technique, and the other person places the epidural needle in the same place where the previous spinal anesthetic was given. It is postulated that the injected blood forms a clot around and adheres to the dura, thereby reducing the CSF leak. Other theory is that the injected blood increases the pressure in the intrathecal space, reducing the traction and thereby relieving the symptoms. We all must have failed a failed spinal. We must have faced a failed spinal. So if the anesthesia and the analgesia have not affected within 20 minutes of successful intrathecal position of the local anesthetic, then it is said to be failed spinal. There are many causes of failed spinal. Operator-related causes are inadequate drug doses or improper assessment of the block, inappropriate positioning, and failure to communicate. Whereas the technique-related failure is due to faulty technique, anatomical deformities, obesity, misplaced injectate, or a pseudopuncture. Many times we have seen that after the placement of the spinal needle, there is a free flow of the CSF. But when we attach the syringe to the needle and try to aspirate, there is a negative aspirate, and there is no free flow of CSF in the needle. In this scenario, the reason for this may be that the bevel is exactly at the dura, and the negative suction with the syringe sucks the dura in the bevel, thereby causing no CSF aspirate. And when we inject the drug, the local anesthetic does not go into the subarachnoid space, but is deposited in the subdural space. Other reasons are anatomical abnormalities such as severe kyphosis or scoliosis, and rarely the ligaments that support the spinal cord within the theca form complete septa and act as longitudinal or transverse barriers to the local anesthetic spread. Spinal stenosis may also limit the spread of the local anesthetic. Rarely, ductal ectasia, which is widening and ballooning of the lumbosacral dural sac, increases the CSF volume, and the local anesthetic which is deposited is diluted in the extra CSF, thereby causing reduced effect. It is found in around 60 to 90% of the patients with Marfan syndrome. Equipment or drug-related failures may be due to the blocked needle, non-potent drug, wrong drug, or drug resistance, as has been seen after scorpion bite, in which the local anesthetic, action of the local anesthetic becomes resistant. Management of the failed spinal is we can repeat the block if it is a non-urgent section or with complete failure, and the patient is having difficult airway or inadequate starvation. We can also revive the block by giving a Trendelenburg position if it is an urgent cesarean section or the skin is already incised and it is a definitely difficult spinal, and we can recourse to general anesthesia if the revival fails and there is no time to repeat the block or on the patient's request also. A word about unilateral spinal. It affects the sensory, motor, and sympathetic function on the one side of the body and offers the advantage of the spinal block without the typical adverse effects with the bilateral block. The patient is placed in the lateral decubitus position and a low volume of local anesthetic is used using a pencil point needle orientation facing the dependent side of the body and injecting the drug very slowly. Keeping the patient in the same position for some time allows only the dependent portion of the drug, only the dependent portion of the body to have effect. Advantages are lower incidence of hemodynamic complication, and it is more selective block on the operator side. Avoids unnecessary paralysis of the non-operated side, better mobilization during recovery, and patient satisfaction. Of late, there is a quite hype in the segmental spinal. This is done in difficult spinal patient. This subarachnoid puncture is done as close to possible as the operative field, and low volume of local anesthetic injected slowly. For example, if the puncture is at the level of the T12 or L1 for lower abdominal surgery or lower limb surgeries, laparoscopic cholecystectomy, mastectomy, and many other similar procedures can be done under segmental spinal without even paralyzing the lower limbs. Moving further, in neuraxial block is epidural anesthesia. It is an anesthesia technique obtained by blocking spinal nerves in the epidural space as the nerve emerges from the dura and then passes to the intervertebral foramina. Techniques can be loss of resistance or hanging drop technique, or even ultrasound can be utilized for successful placement. Oxford epidural space indicator is injecting 3 to 5 mL of local anesthetic containing adrenaline into the epidural space. If the drug is intravascular, the heart rate increases by 20% within 30 to 60 seconds. Whereas if it is in the subarachnoid space, it produces a dense block within 3 minutes. Most commonly, a 16 to 18 gauge, 9 cm long epidural needle is used for the block. Most commonly, it is Tuhis. Other types of needle which can be used are Husted's, Crawford's, Scott's, or Weiss needle. Epidural catheters are usually 16 to 18 gauge and made up of nylon or polyamide. Length is usually 90 centimeters and it has 2 distal holes within 2 centimeters of the end, which is closed. We usually thread the catheter around 2 to 3 centimeters within the epidural space. Epidural filters are 0.2 micron mesh size and it can act as bacterial, viral, or foreign body filters. They have a priming volume of around 0.7 ml and it is recommended to change them every 24 hours. Used for inline filtration of low volume of aqueous solution to prevent transmission of the infection into the epidural space. It is recommended that the syringe should not be more than 10 ml capacity so as to avoid undue pressures. It has Luer lock connection and is transparent for visual monitoring. A word about SUI test, that is TSUI test. This is used to confirm the catheter position. It is a test which is used to stimulate the spinal nerve roots with low voltage current which conducts through the normal saline filled epidural catheters. If the catheter is in the epidural space, the response will be unilateral motor at the current of 1 to 15 milliampere. Whereas if the catheter is near the nerve root, the motor response is mostly unilateral, but the current is usually less than 1 milliampere. If the catheter is in the subcutaneous place, there will be no response even at a current of more than 15 milliampere. If the catheter is in the subdural space, the motor response will be multisegmental at a current of less than 1 milliampere. Whereas if the catheter is in the intrathecal space or in the subarachnoid space, the response will be very strong bilateral response and at a current of less than 1 milliamperes. Now, what should be the epidural insertion sites? For labor analgesia, the level of the insertion must be between L2 to L4 and the height of block should be around T8 to T9 and the density of the motor block should be very minimum. For hip and knee surgeries, the level of insertion should be between L2 to L4 and the height of the block should be around T10 with a dense motor and sensory block. For laparotomy, the level of insertion should be between T8 to T10 and the height of the block for upper abdominal surgery should be between T7 and T8 and for lower abdominal surgery around T10 and the density of the block should be dense sensory and motor block. For thoracotomy, the level of the insertion should be between T5 to T7, the height of block should be at the relevant area and the density of the block should be dense sensory but minimal motor block. Coming on to combined spinal epidural anesthesia, it is a technique in which spinal anesthesia and epidural catheters are placed concurrently. This approach combines the rapid onset and intense sensory anesthesia provided by the spinal with the ability to supplement and extend the duration of the block afforded by the epidural catheter. It also provides post-operative analgesia after the procedure. Needle through the needle technique is the most commonly used and is performed at L3 to L4 or L4 to L5 interspaces. The technique is very simple and fast. Identify the epidural space by the LOR technique. Insert a small gauge spinal needle through the epidural space. A pop is felt as the needle enters the dura. Stabilize both the needle. Look for the CSF. Inject the subarachnoid drug. Withdraw the spinal needle and then insert the epidural catheter. What is epidural volume expansion? The addition of the local anesthetic or either normal saline in the epidural space via the catheter after giving low dose spinal compresses the dural sac and increases the block height. This is useful in many cases, especially old age and cesarean deliveries. Now, what are the advantages of combined spinal epidural? The advantages are that very low doses of spinal can be given. I generally give around 0.5 ml of bupivacaine for patients more than 100 years of age, a dose of 0.5 to 0.8 ml for patients between 90 to 100 years of age, and between 0.8 to 1.2 ml for patients between 80 to 90 years of age. And for 60 to 80 years of age, I generally use a dose of 1.2 to 1.5 ml. I keep the mean arterial pressure equal to the age of the patient. A very important tip while giving the top-up is to aspirate and give the drug very slowly. This will prevent apnea and also the chances of hypotension and chemical sympathectomy will be less. There are some frequent problems encountered while doing combined spinal epidural. Sometimes there is a bloody tap, and when we try to remove the catheter, it doesn't come out because there is shearing on the catheter due to the needle. It is better to remove both the needle and the catheter and need to resite it at a different level. Sometimes in CSE, we have given the spinal, but we are not able to place the catheter in the epidural space, and that's when we are in much hurry and threading the catheter becomes very difficult. So you must remember that, as I've told you previously, that 50% of the drug is still there in the CSF available for action. So you have around 20 more minutes to place the catheter. Don't be in such a hurry. Many a times, we are not able to get the CSF, but able to thread the epidural catheter. This may be due to the fact that the direction of the needle is such that we have punctured the ligamentum flavum, but going beneath the dura or on either side of the dura. So we need to reposition the needle in such a way so as to puncture the dura perpendicularly. Lastly, coming on to caudal epidural anesthesia. Caudal spaces is the sacral position of the epidural space. Caudal anesthesia involves needle or catheter penetration of the sacrococcygeal membrane covering the sacral hiatus that is created by the unfused S4 and S5 lamina. The sacral hiatus can be felt as a groove between the coccyx or between the two bony prominences called as cornua. Its anatomy is more clearly in children up to 6 years of age. The posterior superior iliac spines and the sacral hiatus make an equilateral triangle. What are the indications? It is mainly used in pediatric patients for procedures below umbilicus, including urogenital, rectal, inguinal, and lower extremity surgeries. It can be combined with general anesthesia for postoperative pain relief and can also be used for rectal surgeries in adults. Major contraindications include malformations of the sacrum, including meningomyelocele or open spina bifida, meningitis, and intracranial hypertension. The technique is very simple. The sacral hiatus is located by palpating the coccyx and then sliding the palpating finger in a cephalad direction until the depression is felt. The needle is inserted at an angle of approximately 45 degrees to the sacrum. While the needle is advanced, a decrease in the resistance is appreciated as the needle enters the caudal canal. The needle is advanced under the bone is contacted. The needle is withdrawn and the angle of the needle is decreased relative to the skin surface. Loss of resistance is confirmed by entering into the epidural space. The needle is advanced no more than 1 to 2 centimeters into the caudal canal. The confirmation can be done either by the Woosh test or the Shoes test. Woosh test is the use of the air, while Shoes test is the use of the saline or local anesthetic. As you can see from the diagram that the angle of the needle is first 45 degrees to the skin and later the angle is decreased and then it is advanced into the epidural space. Armitage formula is used for caudal dosing in pediatrics. 0.5 ml per kg for sacral dermatomes, 1.5 ml, 1.51 ml per kg for sacral and lumbar dermatomes, 1.25 ml per kg for mid-thoracic blocks. Approximately 20 ml can be utilized for a 20 kg child. Thanks a lot for your patience listening. I hope this lecture of mine might be of some help to you. Thank you.
Unmute ma'am, please.
Ma'am, please unmute yourself.
Yes. I'll do. Thank you, Dr. Apur, for giving a very comprehensive talk on the subject. And I'm sure the students must have benefited a lot. And, covered, right from, selection of the patient to their, preoperative preparation, monitoring, even talking about, the communicating to the patient during the procedure, which is, very, very, very important. Many of us forget, we apply the monitoring, but, forget to, keep the communication with the patient. That is very, very important. And you discuss all the important complications and their management also. Very good lecture indeed. And can we take the questions now?
Thank you, ma'am.
Dr. Nitin, can we take the questions from the chat box?
Yes.
There is one question in the chat box, ma'am.
Okay.
Sir, can you please tell us why loss of resistance syringe we use 10 ml and why can't we use 5 ml instead of 10 ml for LOR?
Yeah, 5 ml syringes can also be very well used, but actually the LOR syringes which are right now present here are actually 10 ml, right? And the commercially available syringes, they have actually a loss of resistance. If we use dispo needles, dispo syringes, they are not LOR syringes. So it is better to use those commercially available syringes because the resistance between the plunger and the syringe is very less in these LOR syringes, right? It is not the same with the dispo syringes. So the LOR cannot be very well appreciated with those syringes. So it is better to use these syringes if whatever is available, the commercial syringes. You get my point?
That's it. There is no other question as of. We can go ahead with the next session. There are no.
Yes. Now I invite the next speaker, Dr. Rashmi Salotra. She's a professor from the Department of Anesthesiology, Critical Care and Pain Medicine. And she is working at the University College of Medical Sciences and Guru Tegh Bahadur Hospital, Dilshad Garden. And her areas of interest are resuscitation, obstetric anesthesia, airway management, critical care, regional anesthesia, and enhanced recovery after surgery. And she has several achievements to her credit. Fundamentals of critical care support provider. She's also AHA certified, for BLS and ACLS instructor. And she has several publications and she has written chapters in the books. And she's also a reviewer for Index Journal. Dr. Rashmi Salotra, please.
Good morning, everyone. I am Dr. Rashmi Salotra, and today I will be talking about equipment for regional anesthesia. The regional anesthetic can be performed either in the induction room or inside the operating room. The most important equipment for any regional anesthetic procedure is the availability of a crash cart and a trained assistant. The other things are the equipment required for the procedure per se, a monitor, and skin preparation solutions. The crash cart should have emergency drugs and resuscitation equipments, and all of them should be clearly labeled and put in an organized fashion so that they can be accessed in emergency scenarios without any confusions and problems. Now, coming on to the individual equipment required for performing the regional anesthetic procedures. The first one, the most important, is the spinal needles. So whenever an equipment is asked to you, the first thing that the examiner would ask you is to identify. So when you are picking up an instrument, you should know how to describe it completely. Supposing this is a spinal needle. So here you have to talk about the size of the spinal needle, then whether it is stellated or non-stellated, whether it is disposable or reusable, and what is the tip type. So if I give you this spinal needle, I would expect an answer like it is a 22 gauge disposable Twinkies spinal needle with a stillet. Okay. Then the next question can be identify the parts. So the parts are the stillet has a stillet shaft and a stillet hub. The needle also has a shaft, the needle hub, and it is covered in a sterile sheath. How would you like to classify? So classification can be based on the sterilization, whether it is reusable or disposable. But the reusable syringes are not used, reusable spinal needles are not in common use now. So we are all using disposable needles. Next, based on the type of tip, it can be either a Dura cutting needle or a Dura splitting needle. Dura cutting needles are of the Quincke-Babcock style or Pitkin style. And Dura splitting are Greenies, Whittaker or Sprotty. So this is depends how the tip is placed and how the side hole is placed or the drug hole is placed. It is available in lengths of 70 mm to 150 mm and the sizes vary from 18 gauge to 27 gauge. The larger the size, it provides a better tactile sensation and higher chances of success of the block. However, the incidence of PDPH also goes up when the bore is high, so smaller sizes are preferred. What are the advantages of Dura splitting needle? It provides a better tactile sensation of the tissues and the incidence of PDPH is also low. Now, next you can be asked why it should be stillated. It should be stillated because it prevents the tissue from blocking the needle during insertion. And why is there an introducer in certain needle sets? It is because it helps in penetration of pencil point needles through the skin and subcutaneous tissues. And so in very small gauge, very thin spinal needles, an introducer is also given. It can be made of platinum, gold or platina, nickel, iridized platinum or gold, and stainless steel alloy. The hub is made of metal or plastic. The plastic or the transparent hub facilitates the identification of the flow of CSF. Now, what are the uses? So we all know it is for therapeutic use, as when you use it for subarachnoid block for giving anesthesia for lower limb procedures, lower abdominal surgeries, perineal and perianal procedures, and cesarean section. And the second is lumbar puncture, which is a diagnostic application. For lumbar punctures, you use wider gauge needles because you need to collect the CSF and send it for analysis. Whereas for spinal anesthesia, you use the smaller gauges needle. Smaller gauge as in the narrow needles, very 27 gauge, 25 gauge, 23 gauge, that is all. Then continuous spinal anesthesia. So continuous spinal anesthesia, you use the spinal needle and through the spinal needle, you thread in a micro catheter. The bore of the micro catheter ranges from 26 gauge to 32 gauge and the catheters are threaded only 2 to 3 centimeter inside the spinal space. The advantages are the ability to titrate the quality and the duration of the block. But the disadvantages are sometimes because they are very thin catheters, so there may be inability to place the catheter or inject through the catheter. Then the catheter may shear or break or kink, and it can cause irritation and lead to cauda equina syndrome. But with the advent of better materials, they are still available and being used and tried with the renewed success and renewed interest in the continuous spinal anesthesia procedure. Next, we come to the equipment used for epidural anesthesia. So sometimes there is a mini pack and the other type of epidural kit is the CSC kit. The mini pack has an epidural needle, which is also stiletted. There is a catheter. Then there is a syringe, which is the LOR syringe. There is a threading assist guide, and there is a hydrophobic filter. I will describe the parts one by one. But here what we remember is if it is an 18 gauge catheter, the needle would be of another gauge, which is a higher gauge, like 14 gauge catheter, 14 gauge needle, or a 16 gauge needle for passing of 18 gauge catheter. Then combined spinal epidural set. It is essentially, it contains the same elements as the mini pack, except there is an additional spinal needle, which is of a thinner gauge spinal needle, and it can pass through the epidural needle. So first you locate the epidural space, then you thread in the spinal needle, and you locate the subarachnoid space. You inject the drug in the subarachnoid space, and then you thread in the catheter. After that, you fix the epidural catheter and make the patient supine. Other things are the same. So the spinal needle can be either a 25 gauge or a 27 gauge, and the length is also longer than the epidural needle because it has to go through the epidural needle. So it is a 110 mm long spinal needle. This is one type of epidural set, or the CSE set, where the spinal needle and epidural needles do not lock into each other, but the chances of misplacement or displacement or secondary block failure are high in this case. So an improvement is there is a locking mechanism on the epidural needle and the spinal needle. And there are serrations which will also show the depth of insertion of the spinal needle beyond the epidural needle. Rest of the elements are same. And sometimes there may be a sponge which facilitates the placement or the fixation of the catheter. Then coming on to the parts one by one, you can be asked only the epidural needle. So the epidural needle, how will you describe? Again, the same elements as we described the spinal needle. So we will say that this is an 18 gauge or a 16 gauge, whatever you have been given by the examiner. Just read on the backside and on the paper, on the cover, and you will get to know the gauge. And then you talk about 18 gauge, the rest of the things. 18 gauge disposable Tooheys epidural needle with a stillet. So why do you say it's a Tooheys needle? Because you look at the tip, and the tip is slightly curved at an angle of 15 to 30 degrees. Then the shaft of the epidural needle is graduated. There is a mark at every 1 centimeter distance. Then there are wings which facilitate the holding and the placement of the epidural needle. Then there is a hub. Again, the hub can be transparent, which will allow you to monitor whether the CSF is coming out, which in case of accidental dura puncture, or there can be some blood also which can be seen in the hub. And then there is the stillet. Then types of epidural needles can be asked. So you have the Tooheys tip, which is a blunt bevel, and it has a directional tip which will guide the catheter in a particular direction, either cephalad or caudal, depending upon how you want it to go. There is a gentle curve which pushes the dura after passing through the ligamentum flavum, thus preventing the dural puncture. Previously, there was another needle still available, which is known as the Crawford needle, which is a straight needle, but there are higher chances of dural puncture with this. However, since it is absolutely straight, there is no resistance to threading in of the catheter. So catheter placement is a bit easier compared to Tooheys needle. It is available in 16 gauge or 18 gauge sizes, and the lengths are vary between 8 to 12 centimeter. And sometimes you need this 12 centimeter needle in case of obese patients. The markings I have already said, but in certain epidural needles, the first initial 3 centimeter may not have any marking, and then there are graduations at each centimeter. The catheter also of different types. It depends upon how the orifice, it is a multi-holed catheter, multi-oval orifice catheter, or a single orifice catheter, and where the orifice is placed, whether it is placed on the tip or whether it is placed beyond, on the, away from the tip. So it can be 85 to 90 centimeter long. There can be single end hole, or there can be blind tip with multiple side holes. The spring or wire reinforced polymer coated catheter is also there. Then their markings are radiopaque for identification when you want to do it, when you want to identify under the image guidance. And there can be magnetic resonance conditional catheters as well, when you are anticipating that you would, the patient would require an MRI. Then a catheter can be made of silk, rubber, plastic, or stainless steel, or PVC, nylon, polyethylene, or Teflon. Sometimes the wire reinforced one is the most recent technological advance, and these are good because they provide columnar strength for insertion and ensure luminal patency. They are kink resistant, and they are surrounded by a polyurethane or a nylon blend catheter. They provide flexibility to minimize the paresthesia and perforation of the dura. Then there is the filter assembly. The inline filtration, it is used for inline filtration of drugs during epidural injection, and it protects the patient from infection or other particulate matter. It has a 0.2 micrometer hydrophilic membrane, and it should be used with a 10 ml syringe to avoid undue pressure. Luer lock connections are there for proper fitting so that the leakage of the drug is not happening, and it is transparent. The cover is transparent, so you can do a visual monitoring of the filtration process, and it requires a low priming volume as well. Then other thing is the LOR syringe, or the loss of resistance syringe, because you utilize the epidural, the most common technique to localize the epidural space is the loss of resistance technique. So you need the LOR syringe. It is made of polypropylene, and the piston is made of thermoplastic elastomer. It gives a consistent feel, and the plunger is of low resistance for smooth action. There is a Luer slip or a Luer lock connection. So as you can see in this blue one, there is a Luer lock connection, and in this green one, there is the Luer slip connection. Other types of syringes which are not available in the epidural kit, but you might encounter them sometimes, are the glass syringe, which is made of high purity borosilicate. It is heavy, but it can be used a multiple number of times, as it can be autoclaved. Then there is the disposable syringe, which is single use polypropylene, and it is also lightweight syringe. However, the feel of epidural space is best when it is used with the LOR syringe, which is provided with the epidural set. Then for securing the catheter, you need fixation systems. You can do the indigenous fixation with the help of Dynaplast or with the white plaster that is available. But there are some specialized plaster systems also available which secure the catheter and prevent the kinking. Then another type of securing system is this one, which prevents the unwanted catheter migration into or out of the epidural space. The next type of needle that can be shown is the caudal epidural needle. These are the sizes range from 20 to 22 and 25 gauge, and the length is between 30 to 50 millimeter long. The one is available at 30, then there is a 35 centimeter long and millimeter long, and the third one is 50 millimeter long. They have short and blunt bevels, and the hubs are again transparent, and they are color coded as well. The markings are at every 0.5 centimeter depth, unlike the epidural needle, which has at a depth of a distance of 1 centimeter each. If you want these, if you've already threaded the catheter and now you want to give analgesia, so you require, if you want to give continuous analgesia, you require continuous infusion pumps, which can be of two types. They can be computer controlled, or they can be the elastomeric variety. So elastomeric pump, this is an elastomeric pump. Here this is the port from which you fill the elastomeric pump. Then there is a reservoir, drug reservoir, or the balloon, which is actually the elastomeric, which has the elastomeric property and which generates the pressure to push the drug into a infusion line, which has a clamp. So if the patient wants to switch it off, or then you can clamp it, and unclamp it as and when it is required. Then there is an inline filter, and there is a flow restrictor, which will control the accuracy of the rate of flow, and this is the patient connector. The elastomeric pump can vary in capacity from 60 ml to 500 ml, and the flow rates can be up to 250 ml per hour can be generated. However, with the elastomeric pumps, the ability to vary the flow with a particular device is not possible. So it gives you a fixed rate of infusion. And you cannot change it manually, and it depends upon the flow restrictor friction and the constriction that is happening over there. Plus, if whenever the elastomeric pump is about to get empty, then the pressure inside the chamber is too high and the flow rate may be higher than what the patient was initially receiving. So there is an inability to control or alter the rate of flow through this. So an improvement is the PCEA pumps, or the patient-controlled epidural analgesia pumps, which are computerized machine, and they can give bolus or the push of the button, and there can be a continuous infusion or a background continuous infusion or the basal infusion, which can be added to the bolus. So the infusion and the dosage of the infusion as well as the bolus is monitored by the doctor, and the patient can press the button and deliver the bolus as if the pain intensity is more, if the more medication is required. However, only the set volume, the volume which was already set by the physician, can be delivered. And even if the button is kept pressed for a particular period after the delivery of one bolus, the further boluses are not given. If the bolus has already, the maximum dose as per allowed by the physician has already been delivered. So that is called the lock-in period, when the patient cannot keep giving medication on his own. Then types of dosing which are allowed or the programmable dosages are the programmed intermittent bolus, patient-controlled analgesia, clinician-driven bolus, or the continuous delivery. So these are the modes that are available as settings on these devices. So that brings us to the end of the spinal and the epidural equipments. The next thing is the electrical nerve stimulation device, which gives for peripheral nerve blockade. So this gives a low intensity current over short duration and at an electrical stimulus of 1 to 2 hertz to obtain a defined response. And the response is the muscle twitch or sensation to locate a peripheral nerve or nerve plexus with an insulated needle before injecting the local anesthetic in close proximity to the nerve block. There can be a single injection technique, or you can insert in a catheter also for delivery as a continuous nerve block procedure. So a wide variety of these nerve locators are available in the market, and I have shown you two in these pictures. Overall, there is a cathode and there is an anode. The cathode should be attached to the stimulating needle. This is the stimulating needle assembly. Here, the needle is having an injection port also, to which the syringe with the local anesthetic is attached. And sometimes you have a clip which can be attached over to the stimulating needle. If you do not have a stimulating needle, then you can attach the clip, the alligator clip, to the normal needle also. But this is a specialized needle which has a port for attachment. Then this is also another type of device, and you can set the current, the frequency, and the duration of the twitch. Now, how do you use them? For superficial nerves, you start with 1 milliampere current, and for deeper nerves, you start with 1.5 to 3 milliampere current until you are able to elicit a motor response. If the current is too high, there will be direct muscle stimulation and discomfort to the patient. So that is what you do not want. So you reduce the, you start it with low current. Then you gradually reduce the current intensity and advance the needle slowly till the desired motor response is achieved at currents of intensity 0.2 to 0.5 milliampere at 0.1 millisecond frequency. So that is where you inject 1 to 2 ml of local anesthetic and wait, and then you see that the twitches have disappeared. So that means you are in close proximity to the nerve. Then you inject the rest of the local anesthetic after negative aspiration, because you don't want to inject it into the IV circulation. Now, what are the advantages of using the peripheral nerve stimulation? It makes the procedure safer as compared to the blind procedures, as you are able to identify when you are in close proximity to the nerve or you are in the intraneural space, because there will be abnormal movements, elicitation of the response. So also when you are in close proximity with lower current, then you know that you are very close to the nerve and you can deliver it accurately close to the nerve. So it improves the chances of block success, and there is no need to rely upon the paresthesia. So it is also reliable in the presence of spinal or epidural block, and it avoids the intraneural punctures also. Lesser current is required than the peripheral nerve stimulator. So now a question can come to you whether a peripheral nerve stimulator can be used interchangeably with this or not. Yes, if your PNS has sometimes the ability to give low currents as low as 0.2 millisecond, then you can use that peripheral nerve stimulator for this. Otherwise, you use the specialized equipment. And if you have both, how will you identify which one is which? So you have to look whether there are other modes available. If there is a TOF mode that you can see in the switches, or a double burst stimulus, or a post-tetanic count modes on your PNS, then you know that it may be used for dual, depending upon whether the lower intensity current can be given with it or not. However, if none of these modes are available, so most likely it is just a peripheral nerve locator rather than a peripheral nerve stimulator. Then coming on to the stimulating needles, which you use with the peripheral nerve locators. These are thin insulated needles. Why insulated? Because you do not want that the current should spread in all directions. You want that only the tip is in close proximity to the nerve. So you want only the tip to be able to conduct. So rest of it is insulated, so that the current is delivered properly only at the tip. So if they are echogenic, all the more beneficial, because you can use them with the ultrasound as well. Otherwise, if you are not using the ultrasound, then non-echogenic insulated needles are good enough. So they are short beveled, and the tip is non-insulated. It requires low current to locate the nerves, and the length varies from 50 centimeter to 100 centimeter and 150 centimeter. It depends upon the depth of penetration that you want, because for deeper plexuses or the nerve blocks, you will require longer needles. And for superficial blocks, short needles are required. The gauge or the bore is 22 gauge or 20 gauge, and they are disposable. They have markings for you to know the insertion depth. They have an integrated extension tubing, which is the injection port, and there is an insulated cable which attaches to the cathode, as I previously showed. So this is the extension tubing, and this one is the insulated cable. Then sometimes the non-invasive version of this is a stimulating pen, which localizes the superficial nerves through intact skin. It helps to reduce excessive and prolonged needle manipulation, and you can do the nerve mapping in advance, and it is a good tool for teaching and in block rooms as well. It is very cost effective compared to the imaging technologies which are used for mapping, and it is non-invasive and patient friendly and very easy to use. So this is also a good device. You attach it similarly to the peripheral nerve locator. Then the continuous peripheral nerve block system gives you the opportunity to insert the epidural or the catheter through this. So the needle is the Tooheys needle instead of a insulated hypodermic needle. This one is Tooheys insulated needle. Again, the tip is non-insulated, and the stimulating wire is attached to the needle, and a multi-orifice epidural catheter can be passed through it and placed at the close proximity to the nerve. Then sometimes you can use a stimulating catheter also, and insert the stimulating catheter from the stimulating needle. This technique allows you to move to provide long duration blocks, and there is minimal needle movement and catheter misplacement and chances of secondary block failure. The stimulating catheter itself has the ability to conduct the current to the distal end, and you can assess the exact proximity of the distal tip to the neural structures and reduces the likelihood of secondary block failure, as I already said. The catheter is a 20 gauge single hole catheter or a multiple hole catheter with which is made of polyamide, and there is a stellate inside which is insulated with the exception of the distal tip. So this is the stellate and this is the distal tip. So there is a plug or an integrated wire, just like you were connecting the needle with the PNS. Now when you are passing the catheter, you remove the connection of the PNS to the needle. You connect the catheter connection. You plug in the cable and connect the catheter connection, and then you stimulate with the catheter rather than the needle. Then so far what you have seen is the catheter. You were threading the catheter inside the needle. So far whatever we have discussed. So this is the catheter, and there is a needle which is outside, so catheter goes inside. Then the local anesthetic is inside the catheter. However, you withdraw the needle. So you withdraw the needle, but the needle had created a hole which was larger than the catheter. So now what will happen? There will be potential leakage around the needle insertion site, leakage of the local anesthetic. So a better technique is when the catheter is outside and the needle is inside. So where have you seen? You have seen such arrangements in IV cannulas when your puncture needle is inside and you slide the catheter over the needle. So what happens? The advantage is that skin forms a tighter seal around the catheter and the chances of extravasation are low. So you can have any type of assembly, catheter over needle or the catheter through the needle assembly. Another advancement in the field of regional anesthesia is the ultrasound. It was a revolution because the nerve blocks and the other procedures the regional procedures were no longer blind, and there is real-time visualization of nerve structures, needles, and subcutaneous structures. So it improves the safety and ease of performance of nerve block. So it relies on the generation of ultrasonic waves, which are generated from a transducer, and the transducer has a piezoelectric crystal. The piezoelectric crystal converts the electrical energy to sound energy. And this sound is received by the object on which they strike, and the object reflects these sound waves, and then they are received back to the piezoelectric crystal, where they are converted back into the electrical current and perceived on the monitor. And that is how you obtain the image. Now, these are the types of transducers with the piezoelectric crystals. They can be linear, curvilinear, or phased array. The linear ones can range from frequency between 2.5 to 12 megahertz. And since they are high frequency probes, they are used for superficial structures. As the higher the frequency, the less is the penetration of the ultrasound waves. Then their curvilinear probes are low frequency probes, and the ultrasound waves through them can penetrate deeper into the tissue. And so these are the ones which are used for deep seated abdominal blocks. And piezoelectric crystal is present in all of these. Now, probe should be held in such a manner that your hand is resting on either the patient or your hand is not hanging in the air, because you'll get tired, because the probe needs to be stabilized properly, and you need to apply pressure also. So you need to rest your wrist somewhere so that you can hold the probe properly. Then there is an indicator or orientation marker on the probe, which will give you an indication whether you are seeing the structure, where you are seeing, whether they are on the right side or on the left side or on the upper side or the lower side, whatever. So this is a marker which you should keep in mind, and it will correspond to the structures lying just underneath it. Then needle insertion. The needle insertion can be done in plane or out of plane. In plane means that the the needle is parallel to the ultrasound beam. So the ultrasound beam is falling directly on the needle. So what you are able to visualize is the entire shaft as well as the tip of the needle. So since the ultrasound waves are falling on this, there are more echoes which are transmitted back to the transducer and give a superior image quality. Whereas in the out of plane view or the short axis view, the needle is inserted perpendicular to or in any other plane other than parallel to the ultrasound beam. And this is how in this mode you will be able to see only the tip of the needle rather than the entire shaft. So what you do is identification of the tip is by visualization of a bright dot, and sometimes you also might need to put in or inject a little bit of injectate or the local anesthetic or the normal saline to visualize the tip. Then sometimes an advancement is the echogenic needles and echogenic catheters. So echogenic needles, the needle itself will have it is echogenic, so it will produce a sharper image on the ultrasound, and the visualization of the needle would be much better. It is a Quincke style needle if you want to use it for threading a catheter also, and it has a 30-degree bevel. And the catheters again can be echogenic for exact tip placement. So here you can see a standard needle and an echogenic plain needle and echogenic curved needle. So when you advance this needle, this is a normal needle. Look at the quality, and you look at the quality of the image when you advance a echogenic needle. So here, this is the normal needle and this is the echogenic needle. So when you are inserting the echogenic needle, the clear-cut picture is there. And then you insert in the catheter, which also has echogenic markings on it. So you can see exactly where the catheter is going. Now, a combination of the nerve stimulation along with the ultrasound guidance is also available. This is called dual monitoring. This is for improved procedural safety, and you can use the ultrasound as a guide along with the peripheral nerve stimulator, so that can avoid the stimulation of the insertion of the catheter or the needle tip very close to the nerve bundles or inside the nerve bundles. So the nerve needle relationship is confirmed in a much better way when both the techniques are utilized. So that brings us to an injection pressure monitoring device, which is a device which is used to, now you're injecting the drugs very close to the nerve. So sometimes this itself can cause paresthesia or injury to the nerves. The incidence of the nerve injury because of injection is very low, that is 0.02 to 3%. However, if the injection speed is regulated, then the incidence drops further. So this type of assembly, it is helpful in the objective determination of the pressure of injection and regulation of the injection pressure. So it avoids the injury to the nerve structures. Another equipment is the equipment required for IVRA or Bayer's block. So what is IVRA? It is short-term anesthesia for limb surgeries. It is safe and cost-effective procedure and provides a relatively bloodless surgical field. So equipments that are required include a double tourniquet system, IV cannula, local anesthetic, syringe, and Eshmark bandage. So how do you perform? So first of all, you place the IV cannula in the affected extremity, which needs to be anesthetized, and you place a double cup pneumatic tourniquet in the proximal area. You raise the arm and exsanguinate it using an Eshmark bandage. You inflate the proximal cuff to twice the systolic blood pressure, keeping the distal cuff deflated at this time. Then you inject the local anesthetic through the IV catheter. And after that, you inflate the distal cuff. Then the proximal cuff can be deflated after around 30 minutes of IV injection. So now the distal cuff area, which you inflated after the injection of the IV, also has the effect of local anesthetic, and therefore the tourniquet pain is very less in these procedures. But it is suitable only for procedures of duration around 30 to 40 or maybe up to 45 minutes. And you have to take care that the low concentrations of local anesthetics are used, and the anesthetic is vasoconstrictor free and preservative free because you're injecting them in the intravenous system. Bupivacaine should be avoided at all costs because it has high cardiotoxicity potential, and so it should not be used. So that brings us to the end of the equipments for regional anesthesia. The examiner can ask you questions ranging from anatomy to the physiology, factors affecting block height, duration, level of block. Then they can talk about the procedure, they can talk about the drugs that are used in the procedure, methods to identify epidural space or intrathecal, intravascular placement of epidural catheter, intraneural placement of the block, of the needles. Then labor analgesia or walking epidural can be asked. Then the basics of peripheral nerve stimulation, including Rio-base, Chronaxi, action potential generation, and how would you differentiate between a PNS and a nerve locator? Can you use them interchangeably, which we have discussed in the lecture. So local anesthetic toxicity management and all these things which I have not covered. They are theoretical topics which you should be knowing about, and they may be asked in your viva anytime. And now it's question time for you. Thank you.
Ma'am, you're muted. Yeah.
Thank you, Dr. Rashmi, for covering the subject so well. And you also showed them, the latest gadgets. And I'm sure the students must have benefited a lot, because that was really a good thing. And I would like to, add few points about the thing that about the neuraxial block. Like, as you said, last local anesthetic systemic toxicity is very, very important. It can be asked in the theory as well as in the practical exams. I mean, in the drug section, they can keep, this oil, they can, ask about it, about the local anesthetic as well as, how are you going to prevent it. And another thing is about, the local central neuraxial blockade and the anticoagulants. So anticoagulants these days, oral anticoagulants are becoming very popular. So the students must read about the oral anticoagulants. And with the, this neuraxial block, central neuraxial blocks as well as the peripheral blocks becoming, very popular for providing pain relief in the post-operative period. So you have to remember that whatever guidelines you followed as far as the anticoagulants, so you have to remember that you have to follow the same guidelines. So when you are removing the catheter, you have to take care about the position of the patient, in which position you are going to remove the cannula. The patient should be flexed, otherwise, the catheter can get kinked. You may have difficulty, at times it breaks also. So due precaution should be taken at that time. And you have to keep in mind about the coagulation, the INR. It should be should not be more than 1.5. That is very, very important. And similarly, when this very often these patients undergo major surgical procedures, they have a central line. So most of the time that it is there on the right side. So when you are fixing the epidural cannula, it is important that you fix on the opposite side, so that you are not, injecting the drugs which are meant for intravenous use into, the epidural space. Potassium chloride has been injected, for a laboring patient, and the patient became paraplegic. So all these things are very, very important. And another thing was about the elastomer pumps. Nowadays, elastomer pumps, I mean, they have the, the common problems because of the occlusion. There are no alarms when the, the catheter gets blocked or the elastomer pumps empties. So that's why they are not, used nowadays, but definitely they are cheaper as compared to the electronic pumps which we use nowadays. So, and you do get, elastomer pumps with, variable, rate. You can, the flow can vary from 2 to 6 to 7 ml. So those pumps are also available. And nowadays, at least in our center, we are using it, they are becoming more popular with the medical oncologists. They give the chemotherapeutic drugs, but the advantage is, like, you can give it either IV, subcutaneous, or, by epidural route. So I think, and another thing I would like to add is about the pumps. These pumps, about the ghost pressing of the pump. So whenever you put these pumps, or mechanical pumps, of course, not possible, but with the electronic pumps, you talked about the bolus doses, patient control, analgesia. So it is very, very important to, impress upon, the nurses and the attendants there, that only the patient is going to press the button, not the attendants. Because if the patient doesn't presses the button, the attendant does it. This is known as ghost pressing the button. And at times they can give overdose, and there can be medical legal problems. So this, concerns the safety of the patient. So that is an important aspect. So I think that was all I had to add, and very well covered, both the speakers. They dealt with the subject very well. And I think Dr. Nitin, we can take the questions, we have it in I can see a few questions in the chat box.
Thank you, Bimla ma'am, for a very constructive addition to this topic. And it is I'm sure, very useful for the students, whatever you have added, and you've given upon a few questions of the Viva to them already. So thank you. Thank you, ma'am.
Thank you. So Dr. Nitin, we can take questions from the chat box. Dr. Nitin, I can't hear you.
Unmute yourself.
And there's one question there's one question in the chat box for Dr. Rashmi, that what is the volume of the catheter and the filter, epidural catheter and filter?
Yeah, the equipment dead space, I think the question means.
Yes.
So it is very low. It is only around 1 ml. The dead space of the catheter and the filter combined is just 1 ml.
Thank you, ma'am. And that's the only question we have in the chat box, ma'am.
I saw another one which they are confused about. They want to know why the volume of LOR syringe is 10 ml and why not 5 ml. I think the previous speaker also addressed to this.
Yes.
It is a standard 10 ml syringe that is provided with the epidural kits these days. However, you can use a 5 ml syringe as well. But just as I told you that the injection pressure monitoring device should be there whenever you are injecting pressures. So you cannot really, monitor the speed of injection with larger syringes. So of course, higher syringes are not there. But here you are only doing a little bit of, you just need to know how much, just using it for LOR and not for injection purposes. And so probably, I'm not sure, but probably a 10 ml syringe will be a more handy and easy to handle syringe rather than a 5 ml syringe, which is a little less. And sometimes, you take only 3 to 4 ml of air in it. So with a 5 ml syringe, the plunger can accidentally also come out, or you can push in more air, which is not required in the epidural space. So probably that is why it's a 10 ml syringe, but I have not been able to find any concrete evidence in the literature as to why it is 10 ml and why not 5 ml or 2 ml for that matter. Thank you.
Thank you, ma'am. Thank you, ma'am, for your clinical pearls.
Can I add a point to that?
Yes, ma'am.
10 ml. So this is that the 10 ml syringe gives a very good bounce. That is the reason. If you use smaller syringes, the bounce is not so good. Whenever you use a 10 ml syringe, you should fill it up fully. So that gives very good feeling of bounce. And that is why we don't use bigger syringe, because 20 ml syringe has a lot of resistance. So the bounce is not there.
Okay. Thank you, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Thank you.
So,
thank you.
Thank you. So that brings us, to the end of this session. And I again would like to thank Dr. Kaur and her team for inviting me for this update. Thank you.
Thank you, ma'am, for giving your valuable time, and thank you for the speakers for their concise lectures. So moving on with our session, we have the long case presentation on a patient of large thyroid swelling posted for thyroidectomy. And we have a very esteemed faculty with us who will be the examiner for this particular long case. We have Dr. Kirti Nath Saxena. Ma'am is Director Professor and Head of the Department at Maulana Azad Medical College and Associated Lok Nayak Hospital and Guru Nanak Eye Center, New Delhi. And ma'am's area of keen interest are anesthesia, pediatric anesthesia, difficult airway, non-invasive pain therapies, and regional anesthesia. Welcome, ma'am. To moderate the session, we have Dr. Himanshu Bhasin with us. Can we have the CV? He's assistant professor at ABVIMS and Dr. RML Hospital with areas of interest of critical care, difficult airway, and regional anesthesia. And the case will be presented by Dr. Dasara. She's a third-year postgraduate student from Dr. RML Hospital. Over to you, ma'am, for the proceedings of the session.
Good morning. Firstly, my name is spelled wrongly on the side panel. So please correct that.
Sure. Sorry for the.
Yeah, but otherwise it was okay in this thing. But what is being shown here on my screen is Kriti. I'm not Kriti, I'm Kirti. So anyway, now coming to the case presentations. So Dr. Dasara can start the long case presentation, and then I'll be asking the questions which are usually asked in the exam. And then Dr. Himanshu will be summing up the thyroid case, whatever is important in a thyroid case. So over to Dr. Dasara first.
Good morning, ma'am.
Good morning.
Ma'am, should I start?
Yeah.
Good morning, everybody. Today I'll be presenting a case of a 42-year-old female with a large thyroid swelling posted for thyroidectomy. My patient, Mrs. Kajal, who is 42 years old, female, housewife by occupation and hailing from Faridabad, came with a chief complaint of swelling in the midline of the neck for 1 year, weight loss for the past 6 months. The patient was apparently normal 1 year back when she noticed a swelling in front of the side of the neck, which was insidious in onset, painless. Initially, it was the size of a lemon and gradually increased increased to the present size. She also complains of weight loss for the past 6 months, and she observed it by loosening of her clothes. She also had a complaint of sweatings for the past 4 months. The patient complained that she feels intolerant to heat even at rest while sitting under the fan and requires changing of clothes 2 to 3 times per day. She had no histories of tremor or anxiety, no history of irritability or bursts of emotions, no history of easy fatigability or restlessness, no history of diarrhea or constipation, no history of hoarseness of voice. There was no difficulty in swallowing of solids or liquids. There was no history of breathing difficulty. There was no history of pain in the swelling. There was also no history of other swellings in the neck. There was no history of fever. She can climb 2 flights of steps without significant breathlessness. There was no history of bone pain, no history of jaundice, and no history of cough with hemoptysis. On past history, there was no history of tuberculosis, diabetes, hypertension, respiratory illness, or COVID-19. There was no history of any radiation exposure in the past. There was no history of previous hospitalization, surgery, or blood transfusion. On personal history, she consumes a non-vegetarian diet. She has no addiction to alcohol or tobacco. Her bowel and bladder habits are normal, and as well as a sleep-wake cycle. Moving on to menstrual history, she attained her menarche at 11 years of age. Her history was regular menses, which lasted 4 days per 28 days with moderate flow. Family history, there was no history of similar complaints among her family members. An obstetric history, she had 2 living issues and no history of abortion. And all were full-term normal vaginal delivery, which was uneventful. On treatment history, the patient was consulted a physician 2 months back, and she was started on a tablet methimazole 5 mg thrice daily and tablet propranolol 20 mg twice daily. There was no previous medical, radiotherapy, or any other indigenous treatment taken for the swelling. On general examination, the patient is conscious, oriented to time, place, and person, and sitting comfortably in the bed. Her build is average. Nutrition was poor despite of good appetite. She weighed 48 kgs, a height of 160 centimeters, which was calculated to a BMI of 18.7 kgs meter square. She had no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or any edema. She had a heart rate of 104 per minute, which was regular, symmetrical, good in volume and character. There was no radio-radial or radio-femoral delay, and all peripheral pulses were palpable. Her BP was noted to be 180 by 84 mmHg, which was measured in the right upper arm in the sitting position. Her respiratory rate was 14 per minute, which was abdominal, thoracic, and there was no accessory muscles fuse. She had a temperature of 37.2 Celsius degree measured in the axilla, and her JBP was not raised. Moving on to head to toe examination, her faces, skin, and hair texture were all normal. The patient had an anxious look, but there was no apparent or true exophthalmos. No sclera above the cornea was seen. There was no retraction of the upper eyelid. There was no lagging of the upper eyelid on looking downwards. There was no wrinkling of the forehead on looking upwards. There was also no convergence of the eye. The carotid pulsation was not palpable, and there was no tremor seen in the hand or the tongue. Moving on to airway examination, the face was symmetrical. The nose was bilaterally, the nares were bilaterally patent. There was no gross abnormality seen in the face. There was no DNS on any other growth. The oral hygiene was good. Inter-incisor gap was 4.6 centimeter. The length of upper incision was 1.2 centimeter. There was no loose tooth, artificial tooth, or buck teeth. The upper lip bite test was grade 1. The modified Mallam Patti grading was 2. The palatal configuration was normal. Thyromental distance was not assessed. And mandibular space compliance was normal. The sternomental distance could not be measured, and the neck swelling was present in the midline of the neck. The extension was normal, while the flexion was limited due to the swelling. The cricothyroid membrane was also not appreciated. The spine was normal in alignment. The spinous process were palpable, and the interspinous spaces were normal. On local examination, on inspection, the trachea is in the midline, there was no deviation. A spherical swelling was seen in the midline around 4 by 5 centimeters. And the extent was laterally to the medial border of the sternocleidomastoid muscle, and the surface was smooth with well-defined margins. The skin over the swelling was normal. There was no scars, sinuses, or any dilated veins. On movement with deglutition was present, and movement with protrusion of the tongue was absent. The lower border of the swelling was visible, and the trail sign was negative. On palpation, there was no warmth, there was no tenderness, and the findings were confirmed to the inspection. The size was 4 by 5 centimeters approximately. Superiorly, 7 centimeters was from the mentum, inferiorly 6 centimeters from the suprasternal notch. It was soft to firm in consistency, and the lower border of the swelling was palpable. The tracheal rings were palpable below the swelling as well. There's no fixity to the skin, or there was no palpable thrill. On percussion, it was a resonant note heard over the manubrium sterni, and on auscultation, there was no brew heard. Moving on to the cardiovascular system, on inspection, there was no precordial bulge, there was no visible pulsation or no venous deformities. On palpation, the apex beat was felt at the left fifth intercostal space, 1 centimeter medial to the mid-clavicular line, and there was no palpable thrill, there was no parasternal heave or no other pulsation noted. The auscultation, the heart rate was noted to be 104 per minute, which was regular. S1 and S2 were heard, and there was no additional sounds noted. On respiratory system, the inspection, the trachea was seen to be in the midline. There was no deviation. The shape of the chest was normal. Bilateral chest movements were equal. There was no visible scar, swelling, venous pulsation over the chest wall. There was no usage of any accessory muscles on respiration. On palpation, the inspectory findings were confirmed. Tactile vocal frequencies were normal in the bilateral lung fields. On percussion, resonant in all the areas in the sitting position, and auscultation, bilateral vesicular breath sounds in all the areas. There was no added sounds, and the vocal resonance was normal. On central nervous system, the higher mental function was normal. Cranium and spine, there was no deformity seen. Cranial nerves were intact. Normal, the motor was normal in tone and power. There's no atrophy or no abnormal movements, and all the sensory functions and reflexes were normal. The gait was normal. Cerebellum and autonomic functions were also normal. On abdominal inspection, there was no distension, no fullness of the abdomen. All quadrants they moved equally with respiration. Umbilicus was normal. There was no scars, sinuses, or dilated veins. On palpation, it was soft, non-tender. There was no guarding or rigidity or no organomegaly. So my provisional diagnosis is a 42-year-old female presented with a non-tender midline swelling with symptoms of hypothyroidism and no retrosternal extension or examination, which was most probably a case of Graves' disease. And this is the X-ray neck in AP and lateral view.
Right. So the patient was on treatment with, what was the treatment that she was undergoing?
Ma'am, tablet methimazole 5 mg thrice daily and tablet propranolol 20 mg, ma'am.
Okay, so what does methimazole do? What is the importance of methimazole? What kind of drug is a methimazole?
Ma'am, methimazole is a good, ma'am, it acts on the, it prevents organification and, hello?
Yeah.
Hello?
Yeah, can hear you.
Ma'am, it prevents iodination and organification as well.
Okay, so basically it lowers the level of
TSH and the thyroid functions, the thyroid levels.
T3. Yes. Okay, specifically. And what about propranolol?
Ma'am,
propranolol given?
Ma'am, propranolol is a non-selective beta blocker. It doesn't act on the thyroid hormones, but ma'am, we give it to decrease the adrenergic actions, ma'am. So like tremors, heart rate in this patient.
Okay. So now if this patient is to be taken up for surgery and you are shown this patient sometime before and surgeons discusses in that sends you for pre-anesthetic checkup. So you've already examined the patient. How will you go about it?
Ma'am, firstly,
the patient.
Pardon, ma'am?
How will you optimize this patient?
Ma'am, first of all, I will see if this case can be done as an elective case or is it a case needed for emergency?
For elective case.
And for elective case, I will try to optimize the patient further and wait for 6 to 8 weeks until the patient is optimized and I can check her.
You say that it is optimized now.
Ma'am, I'll check if the patient is not clinically symptomatic. Like here, the heart rate is 104. So I'll try to bring down a heart rate to less than 80.
Which heart rate?
Ma'am, sleeping heart rate.
Yeah, so because you are this patient you are examining in sometime in the awake state. So it is the sleeping heart rate which is important and it should be brought down to less than 90. Okay, so we bring down the heart rate and what else? What else?
Ma'am, I'll ask her to continue all her anti-thyroid drugs. And also I'll give her Lugol's iodine or saturated solution of potassium iodide, which 3 to 5 drops per orally for 6 hours, or Lugol's iodine 4 to 10 drops every 6 hourly. And I'll also, ma'am, I can use steroids. I can give her injection hydrocortisone 100 mg 8 hourly.
No, but why do you want to use steroids? What help does steroids give?
Ma'am, the steroids can act on the dehydrated.
Is it routine to give steroids to prepare a patient for elective surgery?
No, ma'am.
So you don't give steroids for elective surgery, no? Your idea should be to reduce the symptoms,
yes, ma'am,
the signs, and the vascularity of the organ.
Yes,
vascularity of the organ is very important because surgeon will have problem in operating when the vascularity is high, and it becomes easier to operate on this kind of patient then. And intra-op management becomes easier. Okay.
Yes, ma'am.
So you optimize the patient and then you see for the TFT also, the thyroid function test.
Yes,
and the T3 should have come to normal, and then you take up the patient. Okay.
Yes, ma'am.
What other investigations would you like?
Ma'am, I would like the complete blood count. I would like a liver function test. I would like a kidney function test.
Why liver function test?
Ma'am, ma'am, as a baseline, and also, ma'am.
No. Just a moment. Liver function test is not a baseline test. Okay, it's a specialized test.
Yes, ma'am. Ma'am, actually, because the patient is on methimazole, so there can be side effects like hepatitis also induced because of the drug. So that's why.
After how long does hepatitis occur? So don't give such answers which cause you problems. Okay.
Yes, ma'am.
You should always answer to the point. It is a known side effect, hepatitis.
No, ma'am.
What is the known side effect of these drugs?
Ma'am, granulocytosis, rashes.
Yeah. So what other investigations? See, whenever you tackle a case for evaluation, there are three things that you have to see. One is age-related evaluation. Okay. Second is the surgical condition. So in this case, thyroidectomy. And third is any associated disease that the patient might be having. Okay, so this patient is not having any associated disease. Whatever disease is there is due to the surgical condition for which the patient is being operated. So now age related at 42, what to expect, and what do you?
Ma'am, sorry, your connection was disconnected.
Can you hear me now?
Yes, ma'am. Your voice is breaking, ma'am.
Now it is okay, ma'am. Now it is okay.
Hello? Hello?
Yes, we can hear you, ma'am. We can hear you. Please continue, ma'am.
After the age of 40 or 35, there are certain diseases that you expect in a patient. So you should evaluate for that. A young patient is different and a middle-aged patient is different. There are many diseases which make their appearance at around 40 years of age. So you should evaluate the patient for those diseases. Which are those?
Ma'am, like hypertension.
Yeah.
Then, ma'am, diabetes.
Yeah. And?
Ma'am,
ischemic heart disease?
Ma'am, ischemic heart disease, yes, ma'am.
Okay. So whenever we whenever we are evaluating a patient, this is what you should see. So LFT is not a routine investigation, it is a specialized investigation. Your routine investigation is only hemogram and urine examination for albumin and sugar. And in addition to this, patients who are 35 or plus, you should evaluate other things like ECG, blood sugar, KFT. Okay.
Yes, ma'am.
So, then in this case, even an X-ray chest. Why do we need an X-ray chest here?
Ma'am, here to see the extent of the mass as well.
Yes, very correct. So the mass is extended. Could you feel the lower border of the mass?
Yes, ma'am. It could be felt.
Palpated, which
Yes,
means that it is not extending externally. Okay. So this is very important. And investigations, as I told you, that these are the investigations. So ECG is important in this patient.
Yes, ma'am.
Why?
Ma'am, ECG, ma'am, because this patient can go into different types of arrhythmias. Also, the patient can have sinus tachycardia,
yes,
atrial fibrillation, SVTs.
Yes. Yes, very correct. So now, supposing that we have optimized the patient and patient is for surgery. So start from the pre-operative, pre-medication, from the medication onwards.
Okay, ma'am. So, ma'am, after giving the advice to the patient that he has to be an NPO of greater than 8 hours for solids, greater than 2 hours for liquids, then I ask him to take a written informed consent and even a high-risk consent for mechanical ventilation post-operatively.
Why? Why mechanical ventilation?
Ma'am, because sometimes there can be laryngeal nerve recurrent laryngeal nerve palsy. There can be edema postoperatively. There can be any type of stridor, ma'am.
Okay, but that's not always so. Most thyroid, see the size of the thyroid.
Yes,
it's not that big. Okay.
And ma'am, I will ask the patient to continue all the anti-thyroid treatments and even the beta blockers. Then I'll prepare the patient by giving him anti-anxiolytic, anti-aspiratic treatment also, anti-aspiration as well. Then
Aspiration, why anti-aspiration? Patient is fasting for 8 hours, so does he need anti-aspiration treatment?
Not exactly.
No, this is a mistake that all the residents are making. There is no need now. Routinely, it is established that there is no need for anti-aspiration prophylaxis in patients who are not at risk of aspiration. There are selected patients who are at risk of aspiration, and it should be given to only those patients. Okay. So thyroid patients are not among those.
Then after that, ma'am, I'll ask for
what anxiolytic will you like to use?
Pardon, ma'am?
What anxiolytic would you like to use?
Tablet alprazolam at the lower dose of 0.25 mg HS prior to the surgery, in the night prior to surgery.
Not on morning of surgery?
No, ma'am.
Why not? That's not medication exactly, no? Night. That what you
we can give both night and as well in the morning as well.
Because alprazolam is given for clear-headed recovery in the morning. So you don't want your patient with clear-headed recovery. You want the patient sedated. So it's better to give in the morning also.
Okay.
Okay. Continue.
Then, ma'am, we can ask for to arrange blood and blood products as well. And because the patient can bleed, and also, ma'am, we'll ask for an RT-PCR less than 72 hours prior to surgery in this scenario.
Okay. Right. Then your patient comes on the table. Now will you proceed?
Ma'am, after I have prepared all the OT with all the equipments and the drugs, ma'am, then I'll I would explain the patient about my plan of anesthesia, which is like general anesthesia with an ET tube, here a flexometallic and controlled mechanical ventilation. And after placing the patient on the OT table, I'll attach all my ASA monitors like the pulse oximeter, the ECG, non-invasive BP. And after securing the tube, I will also monitor for the temperature monitoring.
Patient. See, there are two things which you have missed out. One is you never ask the patient whether the patient is comfortable lying supine or not.
Yes, ma'am.
Okay. So with thyroid case, you should specially ask that whether the patient is comfortable lying in the supine position or not.
Yes, ma'am.
Because thyroid can press on the trachea.
Yes, ma'am.
And if you don't ask that, suddenly on the table, you will find that your patient is saying, I can't lie supine.
Yes, ma'am. In the history part, I have mentioned that the patient had no difficulty in breathing on supine or lateral.
Okay. So now how will you induce the patient? What will you do?
When after placing the patient in I'll pre-oxygenate the patient for 3 to 5 minutes and until the EtCO2 is greater than 90. Then simultaneously, after I've already secured an IV cannula, a large bore IV cannula.
What are you saying? EtCO2 is?
I'm greater than 90.
90?
Ma'am, the expired oxygenation greater than 90. 85 to 90.
90? That's too high. Why should EtCO2 be 90?
O2, ma'am, O2, the expired O2 during pre-oxygenation.
So say that.
Yes, Then, ma'am, I will induce by giving pre-medication simultaneously, injection midazolam here 1 mg and injection fentanyl 100 mics in graded doses. As well, after that, ma'am, I will give injection lignocaine 60 mg, just 2% of lignocaine. Then I will also give injection propofol induction at 100 mg in slow and titrated dose. And after I check ventilation, I will administer the muscle relaxant. Here I will use injection vecuronium 5 mg, ma'am. After that, I will do a smooth and fast laryngoscopy and insert the tube, and then I will fix it and then adjust the ventilatory settings accordingly.
Okay. Now you have put a reinforced tube, no?
Yes, ma'am.
A flexometallic tube. So what will you ensure when you put in the tube that does not come out?
Ma'am, I can use,
Can it come out? Can it come out?
Yes, ma'am. Yes, ma'am.
Why? Why?
Ma'am, because it's malleable, more malleable than the normal PVC tube.
Malleable, or that is not the answer. It can come out easily because the patient will go into an extension position. That is the reason. Okay. The position for thyroidectomy is that of extension, neck extension. So your tube should be sufficiently inside so that it does not come out when you extend the neck. Okay.
Yes,
and so metallic tube can go here and there. So what will you do about that?
I'll do oral packing.
Yes, you can do oral packing to see that it is in position.
Yes.
Right. Then so what are the things that you will see intraoperatively? What are the problems that you will encounter?
It can be that through airway, ma'am, the tube might, because of extension, it might there might be auto extubation. Then ma'am, we have to monitor the vitals. We have to also monitor the temperature, because of the thyroid manipulation, the patient can go into thyroid storm as well.
Then there's problems of bleeding also.
Yes, ma'am, because it's hyperthyroid case, so in case of bleeding, yes, ma'am.
Yeah. So you think that
then any arrhythmias also, it can be arrhythmias, or it can be tachyarrhythmias, or they can also be, because of the extended and the head up position, they can also be venous air embolism.
Yes. So another important thing during thyroid cases, IV access.
Yes,
okay, and measurement of blood pressure. So how will you ensure that your IV access is not interfered with? Because the surgeon is standing on the side of the patient, the assistant is standing on the other side. The arms are usually not approachable.
Yes, ma'am. Ma'am, you can use IV extensions.
Yeah. Anything else that you can do? What else? What other problem is there?
Ma'am, in positioning is because the hands are strapped to the patient, adapted position, so we can use IV lines. And ma'am, because of the extended neck position, ma'am, even the eyes, we have to protect the eyes by using any padding.
Something that you missed out, no?
Yes, ma'am.
That in any head and neck surgery, the eyes have to be covered.
Protected. Yes, ma'am.
Have to be protected. Okay. What about using anti-sialagogue in this patient? Should you use or shouldn't you use?
Ma'am, we'll try to prevent in these cases.
Why?
Because we don't want any sympathetic stimulation.
Anti-sialagogue doesn't do sympathetic stimulation. What does it do?
Ma'am, it decreases the secretion. So yes, ma'am.
Yes, but why don't we want to give it? Why don't we want to give it? It can raise the temperature, you know. Atropine is avoided in such patients because it can cause tachycardia, and it can also increase the temperature. Sweating is blocked, and the temperature can rise. So atropine is to be avoided. Glycopyrrolate, if you feel, otherwise one should avoid glycopyrrolate also. So then we come to the thyroid storm. Intraop, how will you detect that the patient has got thyroid storm? How do you diagnose?
There can be increase EtCO2.
Yes.
The increase of temperature. Then the canister.
You never talked about temperature monitoring, no?
Ma'am, I said like after induction, after I secate the tube, then I'll do a temperature monitoring as well. And check.
So where will you insert the temperature monitor?
I'm at the axilla or intraoral. Also.
Intraoral. Okay. So you'll do a core temperature monitoring, no?
Yes.
Okay. So there'll be rise in temperature, rise in EtCO2, and
yes. Then there can be tachycardia. There can be increase in BP. Then, ma'am, they can also be severe acidosis. Can be a metabolic acidosis.
Right.
And then.
So how will you treat?
Treatment, ma'am, we can do it in the 3 steps, ma'am. We can inhibit the peripheral conversion of T4 to T3. So we can use beta blockers, ma'am, at 60 to 80 orally if there is an RT inserted, or we can use 0.5 to 1 mg of propranolol, and then over 10 minutes, and continue it at 1 to 2 mg. Thereafter.
Can't you use esmolol?
Yes, ma'am. We can use esmolol infusion as well. Yes,
So
ma'am.
250 action, no?
Yes, ma'am. 250 to 500 mics per kg, followed by 50 to 100 mics per kg per minute.
Right.
And then after that, we will prevent the hormone synthesis by using the anti-thyroid drugs. So the drug of choice here being propylthiouracil. We can use 500 mg to 1000 mg loading dose, and followed by 250 mg 4 hourly. And then, ma'am, we can use Lugol's iodine also, 30 drops, or saturated solution of potassium iodide. And then, ma'am, we can use steroids as well. We can give injection hydrocortisone 300 mg IV, followed by 100 mg 8 hourly.
So you should always answer in a proper way. The answer is like this, that one is to reduce the levels of T3.
Yes, ma'am.
Then, and the second is to reduce the symptoms of thyrotoxicosis. Okay. Yes. So the symptoms of thyroid storm. So symptomatic treatment is, one is with beta blockers, and then other treatment is, you've forgotten some supportive treatment also, no?
Yes, ma'am. The supportive treatment, ma'am, we can give 100% oxygen, and then, ma'am, we will deepen the plane of anesthesia. Then we can use a cold IV fluids through RT or IV. Then we can use fan or cooling drapes, and tepid sponging as well. And then antipyretics like paracetamol at the rate of 15 mg per kg. Then we can also correct if there's any metabolic acidosis, we'll also correct it by using sodium bicarbonate.
Yes. So this is treatment of the crisis. And then what do you do? Allow the surgery to continue?
No, ma'am. If we can, we can defer the case and post it for an elective surgery.
No, this is elective surgery only.
Okay, ma'am. No, ma'am, we'll ask the surgeon to stop the surgery if possible, and then we'll shift the patient to a ICU for further management.
No, the surgery should be completed, because this thyroid storm occurs due to the surgery only.
Then, ma'am, we should tell the surgeon to stop, because it can be due to the thyroid manipulation that the stress has occurred.
Yeah. So once it comes out, the thyroid levels will come down.
Yes.
And that is the specific treatment for thyrotoxicosis, no? That is why we are doing the surgery. Okay. So that is as far as treatment of thyroid storm is concerned. Now, after the surgery is over, what will you do? What is your role?
Ma'am, after the surgery is over, I will switch off all the inhalational and also administer the neuromuscular. I'll reverse the neuromuscular blockade by using injection neostigmine and injection glycopyrrolate. And then, ma'am, I will keep the patient, I will assess the patient until the patient comes out. And when the patient is still in a sedated state, ma'am, I will check using a video laryngoscope, I'll check for the movement of the vocal cords as well.
Why are we checking for movement of vocal cords?
Most of the times the recurrent laryngeal nerve palsy occurs, and also because of the manipulation of the surgery, there can also be laryngeal edema as well.
Okay, so laryngeal nerve can be either injured or it can be cut also.
Yes, ma'am.
Okay, transection can also occur.
Yes, ma'am.
And the thing is that is why indirect laryngoscopy was something you missed out.
Yes, ma'am. Preoperatively, we can do that as well. Yes, ma'am.
So pre-operatively, one should always do an indirect laryngoscopy because these are medical legal issues.
Yes, ma'am.
Because later on the surgeon can say, the patient can, you can tell the patient that you already had a recurrent laryngeal nerve palsy, which may be there because of the thyroid. Supposing it is a malignancy, then it can cause recurrent laryngeal palsy from before also.
Yes.
Unilateral may not be discovered so much because patient may have gruffness of voice, which may be related to the thyroid swelling itself. So to get that history is very important, and to do an indirect laryngoscopy is very, very important, that you see that the vocal cords were moving before. And when you do the video laryngoscopy at the end of surgery, you are comparing that laryngeal view with that which was there pre-operatively. So is there any change or not? If there is a change, then it is due to the surgical condition. So what is the presentation? If it is injured or if it is cut, recurrent laryngeal nerve?
They can be unilateral or bilateral.
Yeah.
It can be permanent or temporary, partial,
so
partial or complete. Yes, ma'am.
Yeah, yeah. So if it is complete, what is the position of the cords?
Ma'am, if it's bilateral, bilateral complete, ma'am, or unilateral complete.
So you tell for each of them, no?
Ma'am, in unilateral complete is like the vocal cords are in the paramedian area.
That is called the cadaveric position. Okay.
Yes, ma'am. The cadaveric position unilaterally, because according to Siemens law, the adductors are affected first, then the adductors.
So this is if there is injury.
Yes, ma'am.
Okay. Otherwise, if it is cut, then it will be in the cadaveric position. Okay. So cadaveric position is better for the anesthetist because patient can breathe.
Yes,
okay.
ma'am.
But for the patient, it's not good. So if abductor is only injured or temporarily inactivated, then the vocal cord will be in the midline and will not move on abduction, on inspiration. Okay. So unilateral or bilateral, you can see if it is unilateral, then the other vocal cord usually moves over and makes up for the other side. And
Yes.
if it is bilateral, then both are not moving. That causes a problem. And what if it is bilateral? If
Then both of the sides of the vocal cords will be paramedian.
If it is injured and both are paralyzed, abductors are paralyzed, then what is the treatment?
Ma'am, then we'll intubate the patient, or you can do it.
The treatment is tracheostomy. Okay. Then the patient goes post-operatively into the post-op ward, and suddenly you are given a call that the patient is having stridor. Okay. So what will you suspect?
Ma'am, it can be a hematoma, it can be a laryngospasm, it can be laryngeal edema, and ma'am, 6 to 48 hours, it can be because of the hypocalcemia as well.
Okay, so why would hypocalcemia occur?
Ma'am, because the parathyroid during the surgery could be accidentally removed, or the blood supply to them will be hampered.
it is usually that the parathyroid is removed accidentally. Okay. So
Yes,
how do you differentiate each of these? Laryngeal stridor will be there in both.
yes, ma'am.
So,
Ma'am, if it's in a recurrent laryngeal nerve palsy, ma'am, we can see the vocal cords. Then
yeah.
if there is laryngeal edema, ma'am, if the patient is still intubated, ma'am, we can see
No,
if there's any.
doesn't go to post-op ward intubated. No, patient is extubated.
Yes, ma'am. Because of, ma'am, in the if the patient has hematoma, ma'am, the swelling, there might be a swelling, and there can be other features like difficulty in swallowing, anxiety, tachypnea.
Yes.
And then ma'am.
With hypocalcemia, there will be other signs of hypocalcemia also,
Yes,
no?
ma'am. Yes, ma'am. We can do the Chopstick sign and the Tweezer sign as well. Chopstick sign is when we tap the facial nerve just in front of the tragus, and there might be twitching of the mouth, around upper of the mouth. Then at the
yeah, tetany will also be there.
At
what is Trousseau sign? And what is Trousseau sign?
Yes, ma'am. Ala of the nose or bacterial. Ma'am, Trousseau sign is when we use the.
Yeah.
Hello.
Trousseau sign.
Ma'am, can you hear me?
Yes, I can.
Trousseau sign, ma'am. Ma'am, Trousseau sign is like when we use the BP cuff and we inflate it above the systolic blood pressure. Ma'am, there will be a carpopedal spasm of the hand, where the hand that metacarpophalangeal joint is flexed, whereas the interphalangeal joint is extended, and this flexion of the other four fingers.
Right. So, supposing that there's a hematoma, what will happen? What is your role now?
Ma'am, first of all, we will, if the patient is shifted to the ward, we will educate the nurse or the relative for any warning signs. And ma'am, if the patient is having a difficulty in breathing, ma'am, or there's any tachypnea, any stridor, ma'am, we will start with oxygen, 15 liters per minute, and we'll do a head raise of 45 degrees. And then, ma'am, we will assess it accordingly. If there's still any airway compromise, we will have to do the evacuation, and before that, we will have to call the surgeons.
Yeah, so mostly it is the surgeon who will call you. So he'll say that I want to reoperate now, open the sutures and then evacuate the hematoma. So that is why you need blood all the time for these patients. Okay, even if you don't use it intraoperatively, blood must be arranged for these eventualities which may occur. Okay. So that is, I think, more or less the problems which occur during thyroidectomy. And I think we can hand over to Dr. Himanshu to do his presentation.
Hello. Hello. Sir, please mute your mic.
Can hear you. Can hear you.
Yes, sir. It's a very good Viva presentation by Dr. Dasara. I think all doubts must have been covered. Shall I start my presentation?
Yeah.
Hello, can you see my screen?
Yeah, yeah.
So a thyroid case can come as a long case as well as a short case in the exam. And what all you can be asked in the exam and what all you should be knowing. You should be knowing the basic anatomy of the thyroid, the physiology related to thyroid, the clinical features of hyperthyroidism and hyperthyroidism, as well as the pathophysiology, the concerns related to the thyroid mass, as well as the retrosternal goiter, the pre-anesthetic evaluation, the anesthetic concerns, both intraoperatively and perioperative and postoperative complications and its management, and some idea you should also be having about the recent advances in the field of thyroid surgeries. So a thyroid gland is a H-shaped gland with the right and left lobe with an isthmus connecting both the lobes. It is located just anterior to the trachea, just below the thyroid cartilage, cricoid cartilage, and from second to the fourth tracheal rings. It weighs about 20 grams. So what is very important in terms of the anatomy of thyroid is the blood and the nerve supply. The blood supply, the arterial supply is from the superior thyroid artery as well as the inferior thyroid artery. And the nerve supply, even more important, is from the superior laryngeal nerve and the recurrent laryngeal nerve. Both the nerves can be injured during the surgery, and the recurrent laryngeal nerve is more commonly injured. The superior laryngeal nerve supplies the sensory nerve supplied above the vocal cords and is motor to the cricothyroid muscle. The recurrent laryngeal nerve, which is most commonly affected during the surgery or injured during the surgery, it supplies sensory to below the vocal cords and is motor to all the muscles except the cricothyroid. And as an anesthetist, you should know the anatomy of the cervical plexus, as the cervical plexus, both superficial and deep, are very commonly used during the surgery for providing analgesia. The cervical plexus block is formed by the anterior rami of the C2 to C4 cervical nerves, and you should know where the insertion point is for doing a cervical plexus block. In the superficial cervical plexus block, the insertion point is the midpoint of the sternocleidomastoid muscle, just posterior to its border, and where the four nerves are traversing: the great auricular nerve, the lesser occipital nerve, the transverse cervical nerve, as well as the supraclavicular nerve. So this is the insertion point of, and it's a field block. You have to give a field block in the superficial cervical plexus block. And this is again a cut section of the neck, which shows the superficial cervical plexus as well as the deep cervical plexus. And in the superficial cervical plexus block, you have to inject the drug between the nesting layer of the deep cervical fascia and the prevertebral fascia. Whereas in the deep cervical plexus block, you have to insert the drug deep to the prevertebral fascia. This is showing a cadaveric diagram of the cervical plexus and the various nerve traversing, and this is the insertion point where you have to insert the needle to give a cervical plexus block. You should be knowing about the brief physiology about the thyroid hormones. How are they synthesized? First, the iodine is transported into the thyroid cells, and it is uptake is done, which is again organified or oxidized by the enzyme peroxidase, and this enzyme is inhibited by the drug thiamides, which is very commonly used in hyperthyroidism. And again, then there is organification of the these iodide into the tyrosine residues to form the MIT and the DIT, which then with coupling forms T3 and T4 hormones. These are again stored in the thyroglobulin residues, and after proteolysis, this is released into the blood as T3 and T4 hormones. This step again is inhibited by the iodide, and lastly, the T4 is converted to T3 in the peripheral tissues by deiodination, and this step is inhibited by the iodines, the beta blockers, amiodarone, thiamide, and even anesthetic drugs like thiopentone. Okay, so you should be knowing is the T half of both the hormones T4 and T3. It is 7 days for T4 and 2 days for T3. You should also be knowing normal values of these thyroid hormones. The TSH, it is 0.5 to 5 million international unit per liter, and the important thing to know is that the free hormones is more important than the total. So the free range you should be knowing. For T4, it is 0.7 to 1.8 nanogram per deciliter, and for T3 is 0.2 to 0.5 nanogram per deciliter. The action of thyroid hormones is again very important, and you should be knowing the actions on different systems of the body. In the CVS, it has a chronotropic and inotropic effect. It increases the cardiac output and causes peripheral vasodilation. In the respiratory system, it is important for surfactant production and increases the rate and depth of respiration. It is important for oxidative metabolism, increases the oxygen consumption, heat production, and affects the synthesis and breakdown of carbohydrates, fats, and proteins. This is required for normal development of the skin, skeletal tissues, and the CNS, and it is very important for erythropoiesis. The thyroid case can present as to the anesthetic as a case of hyperthyroidism or a thyroid mass, which is mostly a euthyroid. First, we tackle hyperthyroidism. It is defined as a clinical syndrome of excess thyroid hormones production, and of course, the TSH is low, less than 0.1 million international unit per liter, and the thyroid hormone levels are increased. The etiologies can be grave disease, a toxic multinodular goiter, TSH secreting pituitary tumor, toxic adenoma, or overdose of thyroid hormones. And as an anesthetist, you should know the signs and symptoms of the hyperthyroidism, and you should be using these as to elicit the history. The symptoms and signs are in the decreasing order of frequency, hyperactivity or irritability. It can be heat intolerance or sweating. Palpitations can be there. Fatigueness, weakness can be there. It can be weight loss with increased appetite. Diarrhea, polyuria, and oligomenorrhea in females can be there. The signs, the most common sign is, of course, the tachycardia. There can be tremors. There can be a swelling. The skin can be moist, warm. It can be muscle weakness and gynecomastia. The systemic manifestation of hyperthyroid patient in the cardiovascular system, it is very important for the anesthesiologist. There can be increased systolic blood pressure, reduced diastolic blood pressure, widened pulse pressure. The stroke volume and cardiac output is increased. The SVR and PVR are low. The blood volume is increased, and there can be high output cardiac failure. The pulses are bounding. There can be arrhythmias, SVTs, or atrial fibrillations are also very common. And a cardiomyopathy in these patients known as thyrotoxic cardiomyopathy, mostly a dilated cardiomyopathy, can also be present. In the CNS, there is impaired concentration. There can be resting tremors and depression also. In the gastrointestinal tract, the gastric transit time is decreased, and there is secretory diarrhea and vomiting, which can of course lead to electrolyte disturbances in these patients. In the hematological system, there can be anemia, neutropenia, or thrombocytopenia, and there can be muscle wasting, and proximal myopathy is also common. In the respiratory system, there can be hypercarbia or increased oxygen consumption due to increased BMR. The minute ventilation is increased, the tidal volume and respiratory rate is also increased. The vital capacity is, however, decreased in these patients due to respiratory muscle weakness. The pleural and pericardial effusions can also be present. The various ocular signs can also be positive, and the process can also be present, which has to be taken care during the surgery. Eye care is very important. So the goal is to make the patient euthyroid, and it takes around 6 to 8 weeks to make the patient euthyroid. The drug of choice, of course, are the anti-thyroid drugs. Propionate uracil is a drug of choice, 100 to 200 milligram every 6 to 8 hourly. Or methimazole or carbimazole can also be used in a dose of 10 to 20 milligram, 8 to 12 hourly. The beta blockers, the non-selective beta blockers, are better than the selective for treatment of tachycardia, and they also block the peripheral conversion of T4 to T3. Propranolol in the dose of 40 to 80 milligram every 6 to 8 hourly is used. So as an anesthesiologist, you should know the side effects of these anti-thyroid drugs, and you should rule out the side effects before taking up the patient. The most severe but uncommon side effect is agranulocytosis. Hepatotoxicity can also occur with propionate. Vasculitis and acute renal dysfunction can be also seen, and teratogenicity is seen with all the anti-thyroid drugs. The non-medical therapy includes radioiodine and surgery. The radioiodine destroys the thyroid cells and is used as initial therapy after relapse of anti-thyroid drugs. And the point to be noted is the anti-thyroid drugs need to be stopped at least 3 days prior to this radioiodine therapy to optimize the iodine uptake. And of course, radioiodine can cause hyperthyroidism. It is not recommended in pregnancy. The indications of surgery is the large toxic multinodular goiter, a solitary toxic adenoma, failed medical therapy, or underlying carcinoma. Mostly a subtotal thyroidectomy will suffice. So how will you proceed when a hyperthyroid patients come for a non-thyroid surgery? So in case the disease is subclinical and the lab findings suggest low TSH and normal T4, we can proceed with an elective surgery. And of course, any urgent or emergency surgery, we have to proceed. We have to monitor for perioperative atrial fibrillation in these patients. So if the disease is mild to moderate, there is low TSH and the T4 is high, the decision to proceed with surgery depends on the degree of thyroid dysfunction and the presence or absence of clinical features. Of course, in case of any urgent surgery, we have to proceed. In that case, endocrine consultation, beta blockers should be started with a heart rate goal of 60 to 80. Propionate, methimazole can also be started, and potassium iodide if thyrotoxicosis is severe. In case of a very severe disease or thyroid storm is present, of course, elective surgery has to be delayed. And in case of an urgent surgery, we have to proceed for the urgent surgery. With these points to be noted, the patient should be transferred in the ICU. High dose of proprietary uracil should be started. Beta blockers should be started. Inorganic iodide can be used. Steroids are started, and other supportive care, cooling fluids, glycemic control to be done, and workup should be done for other precipitating causes. So you can be asked in the Viva how you manage a hyperthyroid case who comes for an emergency case. Of course, apart from the general management, the anti-thyroid drugs to be started in the dose of propionate uracil 200 to 400 milligram every 6 or a methimazole can be started 20-40 milligram iodide to be given 1 hour after the anti-thyroid drugs, 5 drops every 6 hourly, or either Lugol's iodine 30 drops can also be given. Beta blockers should be given intravenously, propranolol 0.5 to 1 milligram per kg IV bolus, or esmolol can also be given 500 microgram per kg bolus followed by an infusion. The target heart rate to Novotil is less than 90 per beat per minute. Steroids has to be started for cover dexamethasone 2 milligram every 6 hourly, 8 to 10 milligram per day. Hydrocortisone 40 milligram every 6 hourly. Important is the steroids also decrease the peripheral conversion of T4 to T3. Now let us tackle hyperthyroidism. Hyperthyroidism is, of course, an impaired secretion of thyroid hormones or underactivity of the thyroid leading to hypometabolic state. The TSH is increased and both hormones are decreased. The causes can be primary hyperthyroidism, it can be autoimmune, can be post-thyroidectomy, it can be overdose of anti-thyroid medications, iodine deficiency, or even secondary hyperthyroidism. Again, the signs and symptoms, knowing these is very important whenever you are listening history or doing physical examination. Again, in decreasing order frequency, these are tiredness, dry skin, cold intolerance, difficulty concentrating, constipation, weight gain with poor appetite, dyspnea can be there, hoarseness of voice, and menorrhagia. The signs: the dry, coarse skin, cool peripheral extremities, alopecia, bradycardia, peripheral edema, and delayed tendon reflexes can be there. You should be knowing the systemic manifestations of an hyperthyroid case in the CVS, which is again very important. There can be bradycardia, the myocardial contractility can be decreased, the blood volume is low, there can be pericardial effusions. These patients have abnormal baroreceptor function, and the ECG shows low voltage complexes, TVH flattening, and ventricular arrhythmias. In the CNS, there's slow and dull speech, slowed mental function, fatigueness, and lethargy. In the gastrointestinal tract, the gastric emptying time is increased, which again can lead to increased risk of aspiration. In the respiratory system, there's reduced ventilatory response to hypoxia and hypercarbia. Pleural effusions and pericardial effusions are also can be seen. If these patients have large tongue, there can be sleep apnea and laryngeal edema can be present. In the hematological system, anemia is very common, mainly due to pernicious anemia due to atrophic gastritis. There can be platelet dysfunction, coagulation factor abnormality, hypercholesterolemia, hypertriglyceridemia can also be present, and these patients are prone to develop hypoglycemia also. In the genital unit, there can be amyloid nephropathy and inappropriate secretion of ADH hormone, which can lead to water retention and hyponatremia. This is again very important. Electrolyte disturbances present in hyperthyroid patients. Now, how will you proceed for a non-thyroid surgery in a hyperthyroid patient? If it is a subclinical disease, TSH is increased, but the hormone levels are normal, we can proceed with elective surgery. And of course, urgent surgery has to be, we have to proceed. The mild to moderate degree of hyperthyroidism, of course, the decision to take up the patient depends on the degree of dysfunction and presence of clinical features. And in case of any urgent surgery, it has to be proceed. We can replace, in that case, we have to replace the thyroid hormones in a dose of 1.7 microgram per kg per day. And we have, if the case has been postponed, we can need to adjust the dose every 4 to 6 weeks based on the TFTs. If the disease is very severe, the TSH is very high, more than 200, but there is mixed edema coma, we have to delay any elective surgery. And in case of any urgent surgery, we have to proceed. These patients need to be transferred to the ICU, and endocrine consultations is to be done. And emergent hormone replacement with T3 and T4 should be done. There is mixed edema coma, and steroid cover should be started with the hydrocortisone. You can be asked in the exam, how will you optimize a patient of hyperthyroid in an elective surgery? The surgery has to be delayed if for severe hyperthyroid patients till the patient is euthyroid. Oral T4 is to be started 50 microgram per day and gradually increased over 100 microgram per day in increments of 12.5 to 25 microgram. And in case of an elderly, we have to start with a lower dose, or patient has a CAD, preferably 25 microgram per day. And of course, we have to continue the thyroid medication in the perioperative period till the morning of surgery. In case of severe hypothyroidism or there is mixed edema coma, the patient need to be admitted to the ICU. He may or may not require mechanical ventilation. Active warming can be done only if the temperature is less than 30 degrees Celsius. Volume resuscitation is very important. He may require vasopressor support, and cardiac monitoring can be done. Corticosteroids need to be added. The thyroid hormone replacement should be initiated in a loading dose of 200 to 400 microgram per oral or intravenously, and followed by 1.6 microgram per kg daily in a maintenance dose. If T4, with T4, of course, we can give IV T3 also, it acts more fastly, and lower doses should be started in a patient who has a CAD or is elderly. In case of an emergency surgery, we have to take the patient immediately, and IV levothyroxine 300 to 500 micrograms should be given over 1 to 5 minutes, or IV T3 25 to 50 microgram intravenously, followed by 25 microgram 8 hourly should be given. And steroid coverage should be started with dexamethasone or cortisol. Now moving on to a goiter or a swelling, it is an abnormal enlargement of a thyroid gland that results from compensatory hypertrophy and hyperplasia of the follicles. And we should know the most large goiters even are euthyroid. The etiology can be a neoplasm, it can be an autoimmune, iodine deficiency, inflammation or infection, or even goitrogens. The problem with a goiter or a large mass in the neck is it can press on the structures in the neck as well as in the thorax. It can press upon the airway, esophagus, or the nerves, and in the thorax it can press upon all the cervical nerves or the vessels, large vessels, if it is a retrosternal goiter. And airway issues are major concern with these large goiters besides the hyper or hyperthyroid status. So like in every case, there's a 3 corners of managing every case. The pre-anesthetic evaluation should be done, the operative room management, and as well as the post-operative management. So in a pre-anesthetic evaluation, thorough clinical assessment with history and physical examination should be done. The investigation should be ordered. Optimization of the thyroid status should be done. Airway assessment and preparation is very important, and pre-medication should be done. In the operative room, airway management takes priority. Positioning is important. Intraoperative complications should be sought and managed, and temperature changes are also very important. The post-operative complications should be managed, and pain management is a part of post-operative management should be done. Pre-anesthetic evaluation, the history is of duration of swelling is very important. At long-standing goiter can cause tracheomalacia. There can be symptoms of hypo or hyperthyroidism which should be sought in the history, as we previously discussed. There can be compressive symptoms on the trachea, esophagus, or recurrent laryngeal nerve, or any positional changes should be sought. Any other comorbidities should be ruled out. Any other endocrine or autoimmune disease which can be present should be ruled out. A thorough history of the medication patient is on should be taken, and a history of past surgery or radiation should be taken. In the examination is even more important in case of a goiter. and especially for the size and extent of the goiter. Any fixed hard nodule present, we should rule out any malignancy and possible invasion to the surrounding structures, which may limit the movement and cause any difficult airway. Examination of trachea for any deviation should be seen. Signs of hyperthyroidism should be sought, as we previously discussed. The cardiorespiratory disease, associated cardiorespiratory disease should be ruled out, and the inability to feel the bottom of the swelling may indicate a retrocellular goiter, and signs of retrocellular goiter should be seen. The CVS examination is very important in case of hyper or hyperthyroid patients. Tachycardia or bradycardia can be there depending on the disease. The atrial fibrillation or arrhythmias are very common. The signs of heart failure should be ruled out, and any systolic murmur should be ruled out. The airway assessment, of course, it is very important when there is a large thyroid mass. So examiner can ask you what investigations will you order. Full blood count, of course, is important as a baseline, as well as there can be a potential for blood loss in case of a large goiter. Any side effects of thyroid medications can be ruled out, and anemia is, of course, very common in both hypo and hyperthyroid patients. Thyroid function test preoperatively, you have to order, as these patients should have a normal TFTs to avoid any thyroid storm or mixed edema. In a test within last 6 months is okay if the therapy has not changed. You should have a baseline calcium levels, as these patients can develop hypocalcemia postoperatively. In electrolytes and KFTs should be ordered preoperatively, as these patients have electrolyte disturbances in both hypo and hyperthyroid patients, and severe dehydration can be present in the patient of hyperthyroid. Imaging, coming on to the imaging, the X-ray, chest X-ray, you have to order. There can be pulmonary congestion due to heart failure. There can be dilatation of heart. You can see a retrosternal goiter in a chest X-ray. A neck or thoracic inlet X-ray, APL lateral should be ordered to assess the size of goiter and to detect any tracheal compression or deviation. CT scan and neck and thorax is even more specific. You can see the location of the trachea narrowing and retrosternal extension. And a helical CT, you can construct a 3D virtual airway for you and to see the extent of narrowing of the trachea. The special investigation, as previously mentioned, the vocal cord examination by ENT specialist is very important for a medico-legal purpose to document the vocal cord function in the preoperative period, and any laryngeal inlet or deviation from the normal anatomy can be seen. Flow volume use, though not done routinely, will show a fixed upper airway obstruction. ECG in the preoperative area is important as to rule out any dysarrhythmias or previous myocardial infarction or a bradycardia or any arrhythmias. Echocardiography, it can be ordered in a very severe hypo or hyperthyroid patients. Now, what preoperative orders will you order or write? The informed consent is very important, and also postoperative order for consent for mechanical ventilation tracheostomy in case it is a very large mass. You should explain the patient about awake fiber optic if you are anticipating a difficult airway. Pre-medication and anxiolytic can be given in a pre-apprehensive patient who doesn't have an airway compromise. Order for an adequate blood and blood products should be there, and you should clearly write no sedation on the PAC chart if the patient has an airway compromise. And the disease-specific orders in case of hyperthyroidism, iodine should be started 7 to 10 days prior to surgery to reduce the blood loss, and anti-thyroid medications and beta blockers to be continued to the morning of surgery. In case of hyperthyroid patients, you have to continue the thyroid medications till the morning of surgery. Aspiration prophylaxis can be given as they have a delayed gastric emptying, and sedative should be used cautiously in these patients as they have prone to drug-induced respiratory depression. Next examiner will ask you how you prepare the OT. General preparation, the machine check, difficult airway card should be kept ready. You should know what you will keep in the difficult airway card. Towel rolls, IV extensions should be kept ready. In case of a hypothyroid patient, warming devices should be there. Neuromuscular monitoring device should be there. Ephedrine and steroids should be kept ready. In case of a hyperthyroid patient, cold saline, beta blockers, antipyretics, phenylephrine, a direct acting vasopressor, and steroid should be kept ready. And if case there is a huge goiter, retrosternal goiter, a fiber optic bronchoscope and a rigid bronchoscope should be there. Next, the Vivo goes on to the anesthetic plan. So you can say your plan is the general anesthesia and followed by endotracheal intubation or of awake fiber optic intubation if it is a difficult airway. Bilateral superficial deep cervical block as well as cervical epidural anesthesia has been used to provide anesthesia to conduct of surgeries, but they have their own complications and not that commonly used. Here is an algorithm to manage the airway in a patient with large goitrous swelling. So if there is any tracheal deviation is present or absent, if the tracheal deviation is absent, you can go for a conventional intubation. If the tracheal deviation is present, but there is no retrosternal extension and no tracheal compression, you can go with conventional intubation. If there is a retrosternal, there is no retrosternal extension and compression is present, you can do a CT initially to see the extent of compression. And when the compression is significant, go for an awake fiber optic intubation. If retrosternal extension is present and there is no tracheal compression, you can go for inhalational induction followed by fiber optic intubation. And if both retrosternal extension and compression is present, then awake fiber optic is the modality of choice. Moving on to a retrosternal extension, some points about retrosternal goiter. The definition includes any part of thyroid that extends below the thoracic inlet or a thyroid gland reaching the level of aortic arch. And the most commonly used is the greater than 50% of the gland is below the thoracic inlet. The problems with retrosternal goiters are it can cause tracheal compression and deviation and lead to positional dyspnea. There can be hoarseness of voice or dysphagia. SVC syndrome can be there. Cerebral hyperperfusion can occur because of arterial compression, thyrocervical steel. It can cause recurrent angular palsy or phrenic nerve palsy. And sudden enlargement can also occur due to hemorrhage, cystic change, or malignant change. The concerns of retrominate is a difficult airway, causes difficult airway situations. The blood loss can be more as the goiter swelling is very large. The tracheal compression can worsen with manipulation of the surgeon, and there can be tracheomalacia as these goiters are mostly long-standing. So if you get a large swelling, you should know how to prepare for an awake fiber optic intubation. It is a very common and very sought out question from the examiner. So first, explain the patient, explain what you are doing. You should pre-medicate with glycopyrrolate 30 minutes prior to the procedure. Nasal cavity should be prepared with xylometazoline or any other drug. Standard ASA monitor should be attached. Nebulization with 4% lignocaine should be done 15 to 30 minutes prior to the procedure. You can use lignocaine spray 10%. Blocks, they are not commonly used in a thyroid swelling as the landmarks are not easily palpated, but you should be knowing the blocks, how they are done in a awake fiber optic. Then the spray as you go technique, 2 to 4% lignocaine topicalization can be done. Patient can be mildly sedated with dexamethasone infusion and trachea intubated with the appropriate size ETT. And you can be asked what is the maximum dose of local anesthetic used. Then you can be asked what endotracheal tube is preferred by you. You can go with a conventional endotracheal tube, but this has a disadvantage of it can get kinked. Flexometallic tube can be used. It is less likely to get kinked away. RAE or North Pole ET tube can be used as it keeps the breathing tubes away from the surgical field. And if there is a tracheal compression, a smaller size tube should be used. So can you use a supraglottic airway device to conduct this surgery of thyroid surgery? Yes, you can use. It is an advantage that vocal cords can be seen via fiber optic intermittently at the end of the procedure. But the disadvantage is there is risk of displacement and laryngospasm. And also it is contraindicated if there is any tracheal deviation and compression. Some points about anesthetic induction in a hyperthyroid patients. You should avoid the drugs which increase the sympathetic activity like ketamine, atropine, Propofol, the clearance and distribution volume is increased in hyperthyroid patients. You should achieve adequate anesthetic depth prior to intubation and or surgical manipulation. Indirect acting sympathomimetic drugs like ephedrine should be avoided for hypertension, and direct acting drugs like vinaphrine should be preferred, and nitrous oxide and opioids are safe. Some points about anesthetic induction in hyperthyroid patients. Ketamine and etomidate, of course, can be induction agent of choice in these patients, and they are more sensitive to hypertensive effects of anesthetic drugs because of decreased cardiac output, blunted baroreceptor reflexes, and decreased intravascular volume. And titrated drugs should be used. In case of any hypertension, pharmacological support with ephedrine, dopamine, or epinephrine can be used. Positioning this, the position of the surgery is the head is extended with a sandbag between the shoulders, and head is rested on a head ring. The head end is slightly head up, and eyes should be protected in these patients as they may have proptosis, and hands are abducted by the side, and IV extensions should be used. And you can be asked what monitoring will you use in these patients. The standard ASA monitors, neuromuscular monitoring, even more important in a hyperthyroid patient, should be used. Urine output can be measured if the surgery is more than 2 hours. Temperature monitoring, of course, is very important in these patients, and your IVA can go to even temperature monitoring. And invasive arterial monitoring and CV monitoring can be done based on patient base, individual patient basis. And surgeon can ask you for an electrophysiological monitoring of the recurrent laryngeal nerve. So intraoperative recurrent laryngeal nerve monitoring can be done with special tube. This is a EMG tube with surface electrodes, and this is used mostly in high-risk surgeries like large goiter, challenging dissections, or extensive lymph node dissections. So what are the intraoperative anesthetic concerns of a hyperthyroid patient? There is decreased neuromuscular excitability, and it is exacerbated by the anesthetic drugs. Succinylcholine and NDMRs are generally safe. Peripheral nerve or neuromuscular monitoring should be used in these patients, and there is increased sensitivity to volatile anesthetics. Hypothermia occurs very quickly, and temperature should be monitored. There is hematological dysfunction also, anemia, platelet and coagulation dysfunction can be, there's a close monitoring is required. Electrolyte imbalances can be there. These patients are prone to get hypoglycemic, and extubation and emergence may be delayed in these patients due to hypothermia, respiratory depression, or the slowed drug metabolism. What are the intraoperative anesthetic concerns in hyperthyroid patients? An adequate depth of anesthesia should be kept in these patients, and any stimulus should be avoided. Supplemental and judicious opioids should be used. Isoflurane, sevoflurane, desflurane, there is no significant increase or decrease in the MAC values, and even TIVA can be preferred in these patients. At the end, you have to manage the pain. The pain management is very important in these patients. Multimodal approach is most commonly used. The opioid should be used judiciously, and sets cervical plexus block, ultrasound guided, as we have discussed previously, and local can be infiltrated. And important is in this patient is the reversal and extubation. Ensure complete reversal of neuromuscular blockage in these patients. And at the end of the surgery, the surgeon may ask you to assess the vocal cord movement. You can do this by direct laryngoscopy, a video laryngoscopy, or the nasal fiber optic, or through a supraglottic airway device, which you call a Bailey's maneuver. You have to insert the LMA from the side of the tube, and then you can extubate the patient and see the vocal cord through a fiber optic through a supraglottic airway device. And there's another modified Bailey's maneuver. You can insert the tube. At the time of induction, you can insert a LMA, either a LMA protector or a LMA fast track, and you can insert the tube through the LMA and deflate and keep the LMA there. At the end of surgery, you can just remove the tube and see the tubes, vocal cords through the LMA through a fiber optic, and observe the patient on the table for some time before you shift to the post-operative area. What can be the post-operative complications in the thyroid surgery? It can be early complications or late complications. Early can be a hematoma, a laryngeal edema, nerve damage, tracheomalacia, thyroid crisis can occur, and even pneumothorax may occur in case of a retrosternal goiter. And late complications of hyperparathyroidism or hypocalcemia can occur, and hypothyroidism. So hematoma, the incidence is 0.3 to 1%, but it can be a fatal. Majority do occur within the first 6 hours post-operatively. The symptoms include a neck swelling, dyspnea, and stridor. It is an acute emergency, and acute airway obstruction can occur, and cannot intubate, cannot ventilate situation can also be there. Bedside, you have to tell the surgeon to remove the sutures, and emergent re-expiration may be required. That you may be taken back to the OR for evacuation and definitive hemostasis. Even the prevention is even better, always better than cure. At the end of surgery there should be good hemostasis, and surgical expertise is very important in these. And your role is that to attenuate the hemodynamic responses at the end of extubation, at the time of extubation, and avoid any coughing and swelling during extubation. And in case these patients have to be re-explored, it is preferable to maintain a spontaneous respiration while you're securing definitive airway. Video laryngoscopy, of course, very helpful in these situations. And in case of a CVCI situation, tracheotomy is a choice. Laryngeal edema can also be seen in these patients, maybe because of traumatic tracheal intubation or large hematoma, and it can lead to a stridor or airway obstruction and may require re-intubation. And always consider difficult airway whenever you're suspecting laryngeal edema. A smaller size ET tube should be available. Video laryngoscopy and fiber optic are also very helpful. Coming on to the nerve injuries, as we discussed, the recurrent laryngeal nerve injury is the most common nerve injured. It can get injured due to traction, transaction, entrapment, or even ischemia. So it can be transient or permanent. It can be unilateral or bilateral, or it can be partial or complete. Of course, the most dreaded situation is when the nerve injury is bilateral and partial, in which the cords are totally adducted, as the abductors are more prone to injury than the adductors. So these situations, the tracheostomy is the preferred choice to manage the airway. At the end of surgery, you can get a complication known as tracheomalacia. It is very common when there is a large size goiter and the duration of the goiter is of long duration. It leads because the tracheal wall and the tracheal rings get weakened over time because of the large pressure symptoms of the mass. And at the end of surgery, you can rule out tracheomalacia by a test known as cuff leak test. At the end of surgery, you just deflate the cuff of the endotracheal tube and see for any leak through that tube. If the leak volume is less than 110 ml or less than 10 to 15% of the delivered vital tidal volume, then the test is positive and you should suspect a tracheomalacia. And lesser the leak volume, there is a higher chances that the post-extubation stridor can be there. And also fiber optic examination can be seen before extubation to see the collapse of the trachea with inspiration. And if it is ruled out and you still suspect there can be a tracheomalacia, you can extubate through over an airway exchange catheter to facilitate re-intubation. A thyroid storm, very dreaded complication, can also occur in patient of hyperthyroidism. It is of course rare nowadays because widespread use of anti-thyroid drugs and beta blockers. It most likely occurs 6 to 48 hours post-operatively and mainly precipitated by inadequate preoperative preparation of the patient. The mortality rate is very high, around 20%. It can present, of course, under anesthesia or in a post-operative, most commonly in the post-operative area. Under anesthesia, symptoms are increased bleeding can be there. The EtCO2 rises. There can be soda lime exhaustion, tachycardia, hypertension. Arrhythmias can occur, followed by failure, shock. In the awake patient, there can be restlessness, irritability, delirium, seizures, a coma can occur, tachypnea, vomiting, increased sweating, and dehydration.
Dr. Himanshu,
how you manage the thyroid storm?
that the
For the general supportive care, 100% oxygen. If it is happened under during the surgery, deepen the pain of anesthesia. IV administration of glucose-containing crystalloids should be added. Tuning measures, which include ice packs, cooling blankets. If there is any arrhythmias or atrial fibrillation, beta-energic blockers, and digitalis should be used. Anti-thyroid drug should be administered propafluouracil 200 to 400 milligram every 8 hourly through a RAS tube. Tachycardia, if the present, should be beta blocker should be started and titrated to maintain heart rate less than 90 per minute. Steroid should be added, dexamethasone 2 milligram every 6 hourly or hydrocortisone 200 milligram every 8 hourly. And if there is circulatory shock, vasopressors, direct acting vasopressors like phenylephrine should be added. A late complication of thyroid surgery is hypoparathyroidism. It is of course mostly due to the devascularization of the parathyroid gland or maybe due to direct trauma. The risk factors are large size goiter, a retrosternal extension, or a redo surgery. The signs of symptoms of hypoglycemia occurs 24 to 48 hours post-operatively. Mostly neurological presentation is there. There can be paresthesia of perioral region, hands and feet. Hyperreflexia, cramps and muscle spasm can be there. Positive and cautious sign can be positive. Hypocalcemic stridor, laryngospasm, convulsions, then it is an emergency. And in case of any asymptomatic, no treatment is required. And if it is symptomatic, IV calcium gluconate 1 gram followed by oral calcium and vitamin D supplementation should be added. Some recent advances, most of the time the surgeries are done open thyroidectomy, but nowadays endoscopic thyroid surgeries are being done in various centers. The approaches remain. The cervical approach can be there, or an extra cervical approach can be there. The cervical approach, the endoscope and the probes are inserted through the neck, and in case of axillary or breast approach, the probes are inserted through the breast or the axilla. The considerations and anesthesia considerations remains almost the same. The surgeon can be standing beside the patient and inserting the probes beside the patient, or to a robot may be handling the case, and the surgeon will be sitting somewhere outside. So the anesthetic consideration then go on to the robotic surgeries. Okay, thank you so much.
Okay, thank you, Dr. Himanshu. So he has dealt with this topic very comprehensively, and
you're not.
There's just one point that we.
There are some questions.
Yeah. So the tracheomalacia did not cover in our case because this was not a very long-standing thyroid nor such a large thyroid. But in large thyroids, we have seen tracheomalacia occurring. Now, the question there here, one is, ma'am, is it safe to give? No, first question is, respected ma'am, is the assessment of vocal cord movement done routinely prior to extubation? Since some literature also says the predictive value is less. So prior to extubation, you cannot see the full range of movement of the vocal cords. And during the years, I have a considerable experience. So during all these years, I've seen this evolving from direct laryngoscopy to seeing through an LMA. So direct laryngoscopy is actually the best, but it's the most difficult to perform because patient is usually awake and is struggling, and it becomes very difficult. But when you see through an LMA, or if you see with a tube in place, the same range of movement is not seen. If you see, actually, even through an LMA or a ProSeal or a ILMA, what happens is that these LMAs, when inflated, do compress the laryngeal nerves. And what seems like a nerve palsy may actually not be there because it was compressing some nerve. And when you extubate, then you find that there is no nerve palsy. So that is why we have now moved to video laryngoscopy, because this is the best method, that it gives you the advantage of direct laryngoscopy. No nerve is being pressed without it overly stimulating the patient, because you are doing it, the laryngoscope can be kept outside. It doesn't have to go into the glossoepiglottic fold. So, and doing it before has no advantage except when you think that there is tracheomalacia and the whole thing is going to collapse. For that also we have a leak test as described by Dr. Himanshu. Then here you are saying that please tell regarding different units in picogram and nanogram. The one I've seen in Stolting is in micrograms per deciliter. So I think you stick to any one. You can convert picogram to nanogram and all that. But what is important is the level of T3, not T4. Okay. So one value, whichever you stick to that. Now coming to the next question, is it safe to give bilateral cervical plexus block? Books do not recommend it due to, yes, you are right that there is high risk of phrenic nerve injury, and cervical plexus block is recommended only when it is not as a supplement to GA, but it is recommended as the sole anesthetic when it may not be safe to give GA. Some people give it. I have never given a cervical plexus block for thyroid, or never seen it being given also. So see, recommendations are many. There are many recommendations, and there's no doubt that you have to see the risk-benefit ratio. Phrenic nerve injury is not exactly a desirable thing to have in a patient who's having a thyroid. Then what is the expected duration of occurring hypocalcemia post-operatively? So hypocalcemia is usually seen around few hours after the surgery, and it may be even seen up to 48 hours. So usually it is seen in the post-op period. Patient goes into the post-op ward, and then you see hypocalcemia. So
we have answers on the questions in the chat box.
Yeah. Anything else? You'd like to answer?
Thank you, ma'am. Thank you so much for your work. Ma'am, I think. Thank you, ma'am. Thank you for your valuable time. I think we can close this session. We had a very extensive discussion about thyroid. I'm sure it has answered all the questions. Thank you, ma'am. Moving on to our next session, I would like to invite the chairperson for this session, Dr. Madhvi Chaudhary. Ma'am is professor and head of the department at Pramukh Swami Medical College, Karamsad, Anand, Gujarat. And ma'am's area of keen interest are obstetric anesthesia, trauma management, airway management, and labor anesthesia. Ma'am, we welcome you. And I would like you to kindly go ahead with the proceedings of the session.
Good afternoon, everybody. It is my pleasure to introduce Dr. Nidhi Bhatia, who is professor, core faculty at Department of Anesthesia and Intensive Care, JIPMER, Chandigarh. Her areas of interest are trauma, obstetric anesthesia, airway management, USG-guided regional anesthesia, and resuscitation. Over to Dr. Nidhi Bhatia.
A very good afternoon to all of you. So today I'll be talking about the anticoagulants in anesthesia. Now, why is this topic important for us? This is because the perioperative management of patients receiving anticoagulant therapy is a frequently encountered clinical scenario, especially with the aging population, and 10 to 15% of these require treatment interruption annually for an elective surgery or for some invasive procedure. Then many of these patients are on combined antiplatelet and anticoagulant therapy, which is associated with increased bleeding risk during surgical intervention. Further, the perioperative management of patients on both antiplatelet and anticoagulant drug remains a dilemma with respect to balancing bleeding versus the thrombotic risks. So coming on to this case scenario, we have a 65-year-old diabetic hypertensive lady who's a known case of rheumatic heart disease and has undergone a successful mitral and aortic valve replacement 12 years back. She now sustained a fall and fractured her left femur neck and is now scheduled for a left hemiarthroplasty. She is on oral warfarin 2 milligrams OD. Her ECG shows atrial fibrillation with a rate of 90 to 100 per minute, and her echocardiography shows an ejection fraction of 45% with normally functioning valves. So how do we manage this patient in the perioperative period who is now scheduled for a hemiarthroplasty? So once we come across cases like these, there are a number of questions that come into our mind. These include what are the type of anticoagulant which the patient is on and what is their mechanism of action? How do we perioperatively manage such patients? What is the duration for which these oral anticoagulants must be stopped before the procedures can be performed? Then which of these patients require bridging therapy with low molecular weight or unfractionated heparin? Then following surgery, when should these anticoagulants be restarted? And how do we manage patients if they come to us for an emergency procedure? So during the course of this lecture, I'll try to answer these queries. So antithrombotic drugs are frequently used to prevent or treat various common cardiovascular disorders like acute coronary syndrome, stroke, peripheral vascular diseases, atrial fibrillation, and venous thromboembolism. These antithrombotic drugs are mainly of two types. We have the antiplatelet drugs, which mainly prevent or temper the inadvertent or inadequate platelet activation and initial clot formation. And then we have the oral anticoagulants, which mainly include the vitamin K antagonists and the direct acting oral anticoagulants. These mainly act by slowing down the clot formation by controlling and reducing thrombin generation and formation of stable clots. So I'll be first discussing the oral anticoagulants, which mainly include the vitamin K antagonists and the direct acting oral anticoagulants. So firstly, coming on to the vitamin K antagonists, their main mechanism of action is by inhibition of the epoxide reductase enzyme, which is mainly required to recycle the oxidized vitamin K back to reduced vitamin K. And this reduced vitamin K is a cofactor in the production of the carboxylated coagulation factors. Further, the vitamin K is also essential in the hepatic production of protein C and S anticoagulants. So these vitamin K antagonists mainly have an indirect mechanism of action. And because of this indirect mechanism of action, it takes several days to reach the onset and offset of action. So despite being largely replaced by direct-acting oral anticoagulants, the vitamin K antagonists still remain the only approved therapy in patients with mechanical heart valves. And the vitamin K antagonist of choice is warfarin, though other alternatives are also available. So the half-life of these antagonists is mainly drug specific and spans from 36 hours to 72 hours. They have a highly variable half-life and drug effects of these are mainly because they are highly protein bound, but might be easily displaced by other highly protein bound drugs. Then secondly, almost entirely they are metabolized in the liver, which exposes them to changed degradation with genetic polymorphism and drug interactions. Further, additional interactions may occur with food intake. So the main advantages of vitamin K antagonists is their long safety history, the cheap and widely available antidote which we have to these antagonists, then their easy monitoring, and they are not associated with any major gastrointestinal effects. They are relatively inexpensive and have a single daily dose. Their disadvantages is their need for monitoring, highly variable dosing, then their increased requirement for bridging, and their association with food and drug interactions, slow onset and long half-life. So how do we manage the vitamin K antagonists in the perioperative period? These are typically stopped 3 to 5 days prior to any surgical or invasive procedures to allow for their anticoagulant effect to dissipate. And the therapy is subsequently resumed within 24 hours after the intervention. The preoperative laboratory testing by prothrombin time or INR is recommended due to large inter-individual variations in recuperation of vitamin K dependent coagulation factors. Now, if we are planning to give regional anesthesia to the patient who's on vitamin K antagonist, in that case, timely interruption of this therapy 3 to 5 days before intervention is recommended. The PT or the INR should be within the normal range before the initiation of neuraxial anesthesia. When the neuraxial anesthesia is carried out and you have an indwelling catheter, then how do you remove the catheter once the patient is on vitamin K antagonist? First is, if the INR is less than 5, the catheters can be safely removed. In patients with INR 1.5 to 3, the catheters can be removed, but with a lot of caution, and neurological status needs to be assessed carefully and regularly until the INR normalizes. In cases where the INR is more than 3, vitamin K antagonist should be withheld or at least reduced until the INR has dropped. Now, once we, during the perioperative period, when we decide to stop the vitamin K antagonist, another important question that arises is that during that time interval, should we put the patient on bridging therapy with heparin? So the perioperative interruption of vitamin K antagonist, it decreases the bleeding risk during and after major surgery. However, because of this interruption in therapy, the patients are exposed to subtherapeutic anticoagulation for roughly 10 to 15 days. So perioperative interruption raises the question of whether a pre and post-interventional bridging anticoagulation is warranted to shorten the periods with subtherapeutic anticoagulation. So the important question is whether or not to give bridging therapy with the heparin, and if we plan to give heparin, then how do we do that? So the key points to remember are that warfarin should not be interrupted for procedures which are associated with low bleeding risk. And patients who are at a low risk of venous thromboembolism, they do not require bridging therapy once we decide to interrupt vitamin K antagonist therapy. In patients who are at highest risk of venous thromboembolism, but not excessive bleeding risk, in these patients, bridging should be considered. And patients who are intermediate risk cases, in those cases, whether bridging is required or not should be considered on an individual patient basis. So a number of studies have been carried out to see whether bridging is required or not. And based on these studies, it was found that benefits of heparin bridging with the intention to mitigate the risk of perioperative thromboembolism were not actually evident in these studies. However, it is to be remembered that most of these studies mainly included low-risk patients, and the perioperative bridging therapy might still be indicated in patients with a high risk of thromboembolism. So who are these high-risk patients in whom perioperative bridging therapy is indicated? These are mainly divided into 4 main pathological groups. The first is those with mechanical heart valves. Second is with patients having atrial fibrillation. Third, patients with thrombophilia with or without history of venous thromboembolism. And fourthly, patients in whom there is a risk of venous thromboembolism due to surgical intervention. So the patients with mechanical heart valves, if these mechanical valves are in the mitral position, these are always considered as high-risk patients, and bridging therapy is indicated in all of these. On the other hand, patients in whom aortic valves have been replaced, these are mainly divided into 2 types depending upon the type of mechanical aortic valves. The older caged or tilting disc valves are considered high risk, in whom bridging therapy is indicated, whereas the newer bileaflet valves are low or medium risk depending on the additional risk factors. So bridging therapy might not be absolutely necessary in all mechanical aortic valves. Then the patients with atrial fibrillation, in these patients, perioperative bridging therapy is recommended in patients with a CHATS score of 7 to 9, those patients with a rheumatic valvular heart disease, and patients with history of stroke or a transient ischemic attacks within the past 3 months. Then again, perioperative bridging therapy is recommended in patients who are high-risk candidates for thromboembolic events, like those patients with the deficiency of protein C, protein S, or antithrombin, patients with antiphospholipid syndrome, and patients with homozygous factor V Leiden or prothrombin gene mutation. Perioperative bridging may not be necessary in those patients who have a lower risk of venous thromboembolism, like those with heterozygous factor V Leiden or prothrombin gene mutation. So it is important to remember that decision to bridge or not to bridge with heparin should be considered based on the patient's individual risk profile for thromboembolism, as well as the interventional risk for bleeding. Recent evidence suggests that vitamin K antagonists might not be stopped for procedures with low bleeding risks, like those involving gastroscopy or endovascular interventions. And because unnecessary interruption of this therapy has been known to be associated with increased stroke risk within the first week of reinitiation. So when we do decide to do a bridging therapy, how do we go about it? First and foremost, the last dose of warfarin should be 5 days before you decide to do a surgical intervention or a procedure. Then once the warfarin is stopped, a rest day should follow with no anticoagulant. This allows effect of warfarin to diminish and INR be less than 1.5 before heparin is initiated. So after 1 day of stopping warfarin, then after that, the heparin is started. Now we could either give a low molecular weight heparin or an unfractionated heparin. Low molecular weight heparin is more commonly used because it has a more predictable pharmacokinetic profile, less frequent dosing. It has a reduced requirement for monitoring assays and a reduced cost of administration with greater convenience and similar efficacy like that of unfractionated heparin. So if we decide to give low molecular weight heparin, it can be given either as a once a day dose of 1.5 mg per kg or twice a day dose of 1 mg per kg. A regimen of 1 mg per kg twice daily is more efficacious and should be used for high-risk patients. The daily dose mandates a 24-hour period between the last dose of heparin and surgery. And if you're prescribing a once a day schedule, the last dose should be halved to 0.75 mg per kg to allow adequate time for the anticoagulant effect to subside. Now, patients, if the patients are on low molecular weight heparin and you decide to give regional anesthesia, then in that case, the needle placement should be done at least 12 hours after the prophylactic dose of heparin and 24 hours after therapeutic dose. The first dose of low molecular weight heparin should be given 12 hours after the needle or catheter placement. And if you decide to remove the Neuraxial catheter, this should be done 12 hours after the last heparin dose. And the administration of low molecular weight heparin should be delayed for 4 hours after the catheter removal. Now, if the patient is on unfractionated heparin, in that case, Neuraxial blockade can be given 4 to 6 hours after discontinuing heparin. And the first dose of heparin should be given 1 hour after needle or catheter placement. And the indwelling Neuraxial catheter should be removed 4 to 6 hours after the last heparin dose, and reheparinization can be done 1 hour after catheter removal. Now, since heparin-induced thrombocytopenia may occur during heparin administration, it is recommended that patients receiving heparin for greater than 4 days have a platelet count assessed prior to any Neuraxial block or catheter removal. Now, if the patient is on vitamin K antagonist and an urgent surgery is needed, in that case, it is recommended to administer vitamin K to accelerate the hepatic production of coagulation factors. Now, restoration of adequate levels of these coagulation factor by oral or intravenous administration of high dose of vitamin K takes several hours. So if faster reversal is required, then in that case, you can administer 4-factor prothrombin complex concentrate at a dose of 20 to 30 units per kg. Alternatively, FFPs can also be administered, but they require to be given at higher doses of 15 ml per kg. So now coming on to the other class of anticoagulants, which is the direct acting oral anticoagulants. These are either direct thrombin inhibitors or factor Xa inhibitors. Since they have a direct action, so they have a quick onset and offset of action, and they reach the maximum inhibition concentrations in less than 4 hours. These direct acting oral anticoagulants they have more reliable pharmacokinetics and pharmacodynamics, and they have fewer interactions with other drugs and food. They do not need regular laboratory testing, have a shorter half-life and quick onset and offset, and bridging is not required in most of these cases once we stop these drugs in the perioperative period. Their disadvantages include their relatively higher costs and adverse gastrointestinal effects. So how do we manage these drugs in the perioperative period? Their perioperative handling as compared to vitamin K antagonists is relatively simple in elective surgeries. Due to their short half-life, interruption intervals of 24 to 48 hours are recommended, depending upon the invasiveness of the procedure and the bleeding risk of surgery. Now, bridging is generally not recommended because the duration necessary for the drug to be withheld before surgery is short, and the restoration of clinical effect upon the reinitiation is rapid with no procoagulant effect. Now, when the patients are on direct acting oral anticoagulants, generally perioperative coagulation testing is not required like you require when the patient is on vitamin K antagonist. However, there are certain situations when preoperative coagulation testing should be considered. These are done in patients with risk factors for persistently high direct acting oral anticoagulant levels. These include the patients with impaired kidney function, very low body weight, or advanced geriatric age. Now, if these patients have to undergo non-cardiac surgery, in these cases, the drugs are omitted for 1 day before a low bleeding risk procedure and 2 days before a high bleeding risk procedure. And the drugs are resumed 1 day after the low risk procedures and 2 to 3 days after high risk procedures. Like already mentioned, perioperative bridging is not required, and prolonged discontinuation intervals might be necessary in patients with impaired renal function, with very low body weight and advanced geriatric age. If the patients have to undergo a cardiac surgery, then since it's a major surgical intervention with high bleeding risk, these drugs should be discontinued for 2 days before an elective cardiac procedure, and no routine monitoring is recommended. In patients with renal or hepatic impairment or additional risk factors for bleeding, preoperative plasma levels of direct oral anticoagulants should be monitored. And in situations where the plasma level monitoring is not feasible, the discontinuation interval should be prolonged to 4 to 5 days, which corresponds to almost 10 elimination half-lives. If regional anesthesia is planned in these patients, then the discontinuation interval should be of at least 5 half-lives, that is for approximately 72 hours. And the clinicians should consider checking the plasma levels of anti-10 inhibitors if the interval is less than 72 hours. The patients who are prescribed dabigatran with a creatinine clearance of more than 30 ml per minute should have Neuraxil blocks only 3 to 5 days after the last dose. And in those treated with dabigatran with a creatinine clearance of less than 30 ml per minute, in these patients, the Neuraxil anesthesia should be omitted. Now, if these patients require urgent surgery, we have certain direct oral anticoagulant specific reversal agents which are available and have been approved in cases associated with life-threatening or uncontrolled bleeding. A secondary analysis of patients from a large cohort study suggested that these should be given without awaiting the laboratory results in patients scheduled for emergent surgery. Lastly, coming on to the antiplatelet agents, a number of these drugs are available, including the COX inhibitors, P2Y12 receptor blockers, glycoprotein 2B3 inhibitors, and phosphodiesterase inhibitors. Aspirin is one of the commonly used drug. Now, the perioperative evaluation of the impact of aspirin continuation or cessation on serious cardiovascular events of bleeding has disclosed controversial results. Aspirin should be continued if bleeding risk outweighs potential cardiovascular benefit. Among patients on long-term aspirin, stopping it 3 or more days before surgery may decrease the risk of major bleeding. And in patients who are undergoing non-emergency, non-cardiac surgery, it may be reasonable to continue aspirin when the risk of potential increased cardiac event outweighs the risk of increased bleeding. Now, patients may be on dual antiplatelet therapy, most commonly aspirin and clopidogrel. These could be patients with acute coronary syndrome with or without PCI, or PCI in patients without an acute event. PCI could either be a balloon angioplasty or it could be stenting, which again could either be a bare metal stent or a drug-eluting stent. So while non-cardiac surgery performed early after balloon angioplasty is not associated with an increased risk of cardiac events, however, stenting dramatically changes the scenario. Premature cessation of dual antiplatelet therapy in patients with recent coronary stent implantation is the most powerful predictor for stent thrombosis. So if the patient has undergone a bare metal stenting, in these patients, the dual antiplatelet therapy should not be stopped before 3 months. So elective procedures should be postponed to beyond 3 months. In cases when surgery cannot be delayed for a longer period, a minimum of 4 to 6 weeks of dual antiplatelet therapy might be acceptable. However, such surgical procedures should be performed in hospitals where 24/7 catheterization laboratories are available. Importantly, whenever possible, single antiplatelet therapy, preferably aspirin, should be continued. If the patient has received a drug-eluting stent, in these cases, if it is a first-generation drug-eluting stent, the dual antiplatelet therapy should not be stopped for 12 months. And in cases of new generation drug-eluting stents, the dual antiplatelet therapy should not be stopped for 6 months, and elective procedure should be done beyond 6 months. In cases where surgery cannot be delayed for longer period, a minimum of 3 months of dual antiplatelet therapy might be acceptable, and single antiplatelet therapy should be continued. If surgery cannot be postponed, continue dual antiplatelet therapy throughout the perioperative period. And for patients receiving antiplatelet therapy who have excessive or life-threatening perioperative bleeding, transfusion of platelets is recommended. In patients at low risk of cardiac events, withhold these drugs for 5 days. This is clopidogrel and ticagrelor for 5 days and prasugrel for 7 days prior to surgery, unless there is a high risk of thrombosis. Dual antiplatelet therapy should be resumed as soon as possible after surgery, and if possible within 48 hours. Now, patients who have had a recent balloon angioplasty postpone non-cardiac surgery until at least 2 weeks after the intervention. If regional anesthesia is being contemplated in these patients, NSAIDs do not create a level of risk that will interfere with the performance of neuraxial blocks. And in patients receiving these medications, there are no specific concerns as to the timing of single injection or catheter technique or the timing of neuraxial catheter removal. Time interval between discontinuation of thienopyridine therapy and neuraxial blockade varies from 5 to 10 days depending upon the drug which is being given, and this therapy may be reinstituted 24 to 48 hours post-operatively. The same recommendations apply for deep nerve blocks, whereas superficial nerve blocks might be performed without discontinuation of antiplatelet therapy. So to conclude, management of perioperative anticoagulation requires an interprofessional approach to determine the duration and discontinuation of temporary interruption of anticoagulation. There is limited evidence for perioperative management of anticoagulants and antiplatelets, especially in emergent situations. Appropriate interruption of anticoagulation in the perioperative period is a delicate balancing act between the potentially severe complications of bleeding and thrombosis. Whereas common recommendations are valid in many patients, individual decision-making is required in specific patients. Thank you for your patient hearing.
Ma'am, please unmute yourself, Madhi ma'am.
Doing it. There are few questions in the chat box.
Yes, ma'am.
The question is, ma'am, can you please tell regarding why? No, this is the other one. Sorry. Ma'am, in a patient having atrial fibrillation, how to decide when to switch between warfarin and unfractionated heparin during perioperative period? Is it solely based upon INR value?
Yeah, so like, very good afternoon, ma'am.
Good afternoon, madam.
So like I mentioned in my lecture as well, in patients with atrial fibrillation, whether to stop, first is whether we need to stop warfarin or no. So warfarin, stopping warfarin depends upon the perioperative risk of bleeding. So in patients who are undergoing a procedure which has a low risk of bleeding, the current guidelines suggest that there is no need to actually stop warfarin. Whereas if you are concerned about the risk of bleeding, of course, it needs to be stopped. So first is you have to decide whether the bleeding, whether warfarin needs to be stopped or no. Now, once you decide to stop warfarin, the next question is whether during that period of warfarin stoppage, do you need to bridge it with heparin or no? So this is again decided on a number of factors. It's not solely based on the presence of atrial fibrillation. So if, like I already mentioned, if the patient has atrial fibrillation along with a number of other comorbidities, like the CHADS scoring is done, like the patient has a congestive heart failure, is hypertensive, is elderly, has a recent history of stroke, has a rheumatic heart disease, in that case, of course, you need to bridge it with heparin, whereas not all cases of atrial fibrillation need bridging.
Just to add to it, if echocardiography has some mural thrombosis,
Then
along with
definitely.
atrial fibrillation, definitely they'll require
Yes,
bridging.
definitely. Then definitely you need to bridge.
Another question is, ma'am, to reverse warfarin in patient who is posted for emergency surgery, which is the better, PCC or FFP?
Yeah, so definitely PCC is better. And plus there are recommendations depending, the dose of PCC depends upon your INR values. So if the INR values are higher, you need to give a higher dose of PCC. But if you do not have PCC available with you, in that case, FFP is the other alternative. However, when you are planning to reverse with FFP, larger volumes of FFP need to be given as compared to PCC. So PCC is definitely better. And I would just like to mention that there are two types of PCC, the 3-factor and the 4-factor PCC. So 4-factor PCC is definitely better.
Madam, is there any role of IV vitamin K in emergency situation where in a small setup like ours, the PCC or the FFP may take time to come?
Yes, definitely. There is a role of vitamin K. However, the problem with vitamin K is it takes a few hours for the effect to happen. So if you need, so there is, two types of surgeries. One is an urgent surgery where it can be delayed for 24 hours. And the other is emergent surgery where the surgery, you cannot postpone it for more than an hour. So in emergent surgeries, definitely vitamin K would not work that much because you need the patient to undergo surgery within the next hour or so. So in that case, we need to reverse it immediately. So you use either an FFP or a PCC. However, if you have an urgent surgery where you can wait for a few hours, say 12 to 24 hours, in that case, vitamin K is definitely helpful.
This will be a challenge, particularly when patients are having metal stents and on warfarin therapy.
Yes.
Meet with a road traffic accident and a blunt trauma.
Yeah.
So they have to be taken for emergency surgery. And by the time we get PCC or FFP, we have to give anesthesia to explore such patients.
Yes.
That is a challenge. Madam, what should be done in following situation? Patient needs urgent retrobulbar block for ophthalmo procedure, but is on warfarin therapy with INR of 1.7.
Yeah, so like the blocks, especially eye blocks, because it's a closed space, so there is a high risk of bleeding and you have to be very, very careful. So if possible, it should be avoided, such blocks. Otherwise, superficial blocks can be given. But when it comes to retrobulbar blocks, something like this, which is a closed compartment and the bleeding can be catastrophic. So in those cases, it is best to avoid, or you can do an urgent reversal with the concentrates if available.
Okay. The last question is, Madam, in patient post-op ongoing DIC, which is better, cryo or FFP?
Yeah, so if cryo or FFP. Cryo, I assume you're asking for fibrinogen levels. So if you have to maintain fibrinogen levels, the current guidelines suggest that in bleeding patients, fibrinogen is one of the earliest coagulation factors to decrease. So fibrinogen levels should always be monitored and ideally should be maintained above 1.5 to 2 grams per liter. Now, if your fibrinogen levels are decreasing, it's best to replace them, and the best is to give cryoprecipitate if available. So the thing is that in most of the centers, it is not available or it is costly. So we use FFP, which is the next choice. So for fibrinogen, either we have fibrinogen concentrate, or second is cryoprecipitate, and third is FFP. So most of our institutes, we have FFP and we have cryoprecipitate. So if either of the two can be used for replenishing fibrinogen levels, better is cryoprecipitate, definitely.
Thank you, madam. It was very enlightening.
Thank you so much, ma'am.
Because of increase in the lifespan, nowadays we come across many orthopedic injuries where the patients are geriatric with more number of comorbidities and anticoagulant therapy.
Yeah. So a number of these patients come to us now.
This is always confusing, when to start, when to restart.
Yes.
And vascular surgeons particularly, they insist on giving regional anesthesia when the anticoagulant therapy is going on.
Yes.
Now, one of my observation during COVID pandemic was patient had a history of COVID, Delta variant, and they had trauma for some reason. So when we used to get the D-dimers done, the D-dimers were pretty high, say in thousands, 8,000 and 10,000. So in this situation, what should be the safe D-dimer to give consents in elective cases? These patients usually had twice a day low molecular weight heparin therapy. So is it advisable to stop or continue and go ahead with general anesthesia?
See, it's a very dicey situation because on both sides, I mean, it's a double-edged sword. We actually do not want to stop and do not want to continue as well. So it depends on patient to patient. Actually, you cannot give cutoff values. It depends upon the type of surgery, how urgent it is, what is the bleeding risk. And depending upon that, you have to continue or stop. Actually, you cannot give a clear-cut guideline like in this patient, this should be stopped and this should be the level. So it depends from patient to patient basically, and depends upon the type of surgery and how emergent it is.
Okay. Thank you.
Thank you, ma'am.
Thank you, madam.
Thank you, ma'am. Thank you, Madhuri ma'am and Nidhi ma'am. I'm
Thank you so
sure
much.
seeing the number of questions that the delegates have asked, I'm sure it was a lecture which was watched for many and was a much awaited lecture by the postgraduate students. It's always a very confusing area. Thank you so much for this enlightening talk, ma'am.
I thank the organizers to give me the opportunity to chair this important session.
Thank you so much, and thank you, ma'am.
Thank you, madam.
So moving on with the next session, we'll be skipping the lunch break as we are already running late. So there won't be a lunch break. We'll directly move on to a 2 o'clock session, for which I would like to introduce our chairperson for the session. I welcome Dr. Usha ma'am. Ma'am is professor, consultant, and ex-HOD at VMMC and Safdarjung Hospital, New Delhi. And ma'am's area of special interest are emergency medicine, pediatric anesthesia, and skill learning. Ma'am, we welcome you. And now I hand over the session to you for the proceedings.
Thank you, Dr. Nitin, for that lovely introduction. And today I'll be chairing a session on perioperative. Am I audible to you, please?
Ma'am, we are not able to hear you. Ma'am, unmute yourself, ma'am. Usha ma'am, can you unmute yourself, please? Ma'am, we still are not able to hear you. Your mic is on mute mode, ma'am. Yeah. Okay. Ma'am, it's still mute. It's still showing that it's mute.
Can you hear me now?
Yeah, now it's unmute, ma'am. Yeah.
Yeah, I'm sorry about this audio problem, and thank you for the kind introduction. And
Ma'am, we are not able to hear you despite the unmute.
thromboembolism.
Can you be louder, ma'am? The audio is little on the lower side.
Okay. Can you hear me right now?
Yeah, ma'am. Now it's better. Now it's better. Much better.
I'm so sorry for delaying this because of audio issues. Today, the next topic of discussion will be perioperative thromboembolism, and the speaker is Dr. Aanchal Kakkad. Dr. Aanchal Kakkad is a very young, promising associate professor from ABVIMS and RML Hospital, and her main area of interest is airway resuscitation, laparoscopic surgery, and obstetric anesthesia. And the topic may be not very prominent topic, but it is a very important one, and particularly from the postgraduate point of view. And yes, over to you, Dr. Aanchal Kakkad. Please start the topic. Thank you.
Good afternoon, everyone. I am Dr. Aanchal Kakkad, Associate Professor in the Department of Anesthesia at ABVIMS, Dr. RML Hospital. So I will be speaking about perioperative thromboembolisms. This is a very important topic as pertaining to your question answers asked in theory exam, and as well as in many of the long and short cases, thromboembolism may be asked. So to start with, let us define thromboembolism. Thromboembolism is the blocking of a blood vessel by a particle that has been broken away from a blood clot at its site of formation. So a thrombus is formed at the site, and from there it actually gets broken away to another site and blocks the blood vessel, hampering the blood supply of that particular area. So there are two components of thromboembolisms there. One is deep vein thrombosis and pulmonary embolism. So most commonest site for thrombus formation is the vessels which are in the lower limbs, and from there thrombus usually get dislodged, and the fatal outcome is there if there is a pulmonary embolism. So incidence is, it is the third most common cardiovascular diagnosis being made, and half of the venous thromboembolism events occur due to hospital admission, either for surgery or for any medical illness. The risk factors for venous thromboembolism in hospital are certain diagnoses like malignancies, elderly age, previous history of venous thromboembolism, central line insertions, and majorly the immobility because of the admission. So what is the pathophysiology? So we all are aware that there is a continuous venous flow, and because of which there is the balance between the procoagulant and the anticoagulants, and this balance actually this balance is maintained, and there is no formation of thrombus. And this continuous peripheral venous flow is being maintained because of the muscle contractions of calf muscles, which cause the pulsatile flow. So when this calf muscle contraction is not there, there is absence of pulsatile flow, then that time there is ineffective emptying of the venous valve pockets. So there are venous valves in the veins. So there are pockets which is the commonest site for deep vein thrombosis. When there is ineffective emptying, so the blood is stasis, there's stasis of blood over there, which causes hypoxia and inflammation at the perithalous endothelium of the cast. This further leads to the procoagulants and disrupts the delicate balance between the pro and anticoagulants, leading to thrombus formation. This is more clear via this diagram, in which you can see this is the vein and these are the valves. This side of endothelium is known as perithalous endothelium. This forms the pocket of valve pocket. And when there is absence of contraction from the calf muscles, there is ineffective emptying of these pockets, leading to the stasis of blood and hypoxia and release of procoagulants. So recently, American Society of Hematology, they have come up very good risk assessment modules, and these have they have certain points given to either of the condition. They have included 11 conditions in PODA venous thromboembolism risk assessment module, and there are 7 in improve venous thromboembolism risk assessment modules. Depending on the scoring system, you can actually identify patients who are at a higher risk for venous thromboembolism and manage accordingly. So the PODA venous thromboembolism RAM score, they include reduced mobility, active malignancy, previous history of VT, known thrombophilic condition, trauma, surgery recent within 1 month, elderly age of more than 70 years, heart or respiratory failure, acute myocardial infarction or ischemic stroke, ongoing hormonal treatment, obesity, acute infection or rheumatological disorders. So there are points given as 1 to certain parameters, 2 to 1 and 3 to others. If more than 4 score is there, the patient is at indicates that patient is at a higher risk for developing venous thromboembolism. Similarly, in improve risk assessment module, there are 7 points. Previous history of VTE, known thrombophilia, lower limb paralysis, active malignancy, immobilization of more than 7 days, ICU or CCU stay, and age more than 60 years. In this, more than 2 of the score indicates that there is higher chances of developing venous thromboembolism. So, since we are dealing with the perioperative situation, perioperative time period, we know that surgery itself increases the chances of developing thromboembolism, thrombus formation by 5-folds. This is because there is tissue trauma, there is acute inflammatory response, and further leading to activation of the clotting cascade, leading to formation of thrombus in the prone patients who are prone for developing thrombus. So incidence in general surgery is 0.3 to 1.6%. In prostate procedure, it is up to 5.8%. Orthopedic procedure have a high association up to 30%, and their hip fracture repairs are associated with 4.3% to 24%. So what type of anesthesia actually can reduce the chances of venous thromboembolism? Regional anesthesia, that is neuroxyl blockade or epidural, they are associated with lower risk of venous thromboembolism because they maintain the hyperkinetic blood flow in the lower limbs. Whereas general anesthesia, it causes vasodilatation, venous stasis, and decreased venous return, thereby making the hypercoagulable and hypofibrinotic state and leading to more chances of developing thrombus. That is why there is a recommended prophylaxis for these patients, mechanical prophylaxis and pharmacological prophylaxis. I will not go into details of this because this has already been discussed in the previous lecture. Just to name, mechanical prophylaxis is the graduated stocking intermittent pneumatic compression device. Vena cava filters are there. And in pharmacological, anticoagulants like low molecular weight heparin, unfractionated heparin, direct oral anticoagulants, vitamin K antagonist, and antiplatelet agents. So now we will make it case oriented because it gets registered in a better manner. So we have a case of 82 years old male who has a history of emphysema, type 2 diabetes mellitus, obesity with BMI of 42, and has a history of deep vein thrombosis 15 years ago. She's admitted in intensive care with the diagnosis of pneumonia, and he is on metformin, amlodipine, ramipril for his chronic illnesses, and now started on antibiotic and supplemental oxygen. He has not been ambulating for last 10 days because of dyspnea, which he was developing, and generalized weakness. So this is the history. Now we have a question that after being admitted in the ICU, which of the following should be started as prophylaxis for thromboprophylaxis? So which has a low molecular weight heparin, direct oral anticoagulants, compression stockings, or no prophylaxis because patient is low thrombus. So this last line actually gives us a hint that we have to assess now, depending on our risk assessment modules, that what are the risk of this patient for developing thromboembolism. So now coming to the PODA-RAM factors, I have already highlighted that there is a previous history of venous thromboembolism. There is age more than 70 years. There is reduced mobility for last 10 days. Respiratory failure, there is no respiratory failure, but patient has dyspnea. So this is plus minus. There is obesity because BMI is more than 42. And there is infection because patient is admitted with the diagnosis of pneumonia. So more than more than 4 is the score. Similarly, for improve, there is history of previous VTE, and there is history of the age is more than 60 years, and here also the score is more than 2. So the patient should be put on thromboprophylaxis. So the question is now, which of the following? So I would actually start the patient on lower molecular weight heparin, since I have not ruled out whether the patient still has any venous thrombus in the lower limbs. Okay, and also in acutely ill hospitalized medical patient, recommendation is for lower molecular weight heparin for VTE prophylaxis. Okay. So now we have started with the lower molecular weight heparin in patient, and after 2 days, the patient is shifted to ICU with pain, abdomen, fever, right hypochondriac tenderness, and the surgeon makes a diagnosis of acute peritonitis, probably because of the appendicular perforation, and an emergency surgery is indicated. His lab investigations, as shown, are within normal limits, and he has been taken for surgery. So as per discussion in the last lecture, what will happen, because we will have a 12 hours gap for the lower molecular weight heparin if the patient can wait for the surgery. So after the surgery, now the patient has been extubated and transferred to intensive care and is on supplemental oxygen at 5 liters per minute. Now, which of the following you will start as a thromboprophylaxis? So now, because we had time for 2 days, we have evaluated the patient, and now the patient, a Doppler, lower limb Doppler has been done. There is no thrombus found in the veins of lower limb. We will start the patient on graduated compression stocking device, and after 12 hours of the 12 to 24 hours of the surgery, we will start the lower molecular weight heparin also. Now suppose intraoperatively, while the surgeon was doing laparotomy, there was a sudden change in the hemodynamic parameters, and the heart rate, it went from 80 to 140 beats per minute, blood pressure from 100 by 60 to 70 by 40 millimeters of mercury, and SpO2 started falling, and it had reached 90% in spite of giving 100% oxygen, and EtCO2 also has a falling trend as shown in the graph. Now, what would come to your mind? What is the diagnosis that would come to your mind? I'm 100% sure that all of you must have thought about pulmonary embolism. So because he is at a higher chances, he has a history, he has been immobilized, so there is a chance that patient can develop pulmonary embolism. So if a short note comes on pulmonary embolism, you have to tell signs and symptoms. So the signs and symptoms are unexplained hypoxemia, unexplained hypotension, tachycardia, elevated GVP, gallop rhythm at the left sternal edge, accentuated second heart sound, bronchospasm, hypotension that requires inotropic support of vasopressors, and it is high chances of having a patient as a cardiac arrest patient. Okay, so ECG, specifically ECG, you will see right axis deviation. There will be incomplete or complete right bundle branch block. S1, Q3, T3 pattern, that means that S wave in lead 1, Q wave in lead 3, and T inversion also in lead 3 may be seen. P pulmonale may be seen in the ECG. There might be various kind of dysarrhythmias like atrial fibrillation, atrial flutter, ventricular dysarrhythmias may be there, and the patient may have AV, various degrees of AV block also. All of this may not be present in the patient, but some of the findings may be present in the patients having pulmonary embolism. So diagnostic test, it is basically a diagnosis of exclusion. You should have a high suspicion high level of suspicion to diagnose ventricular thromboembolism. Lab tests which support the diagnosis of VTE are ABG because it shows hypocapnia, hypoxemia, respiratory alkalosis. D-dimers, troponin T and BNP, they are elevated. Imaging does have a role in diagnosis of venous pulmonary embolism. Chest X-ray is usually not useful, but CT scan has a sensitivity of 85%. Transesophageal echocardiography also is very sensitive and specific. The gold standard one is pulmonary angiogram, CT angio as commonly called. It is a gold standard, it is non-invasive. The only problem is it is very expensive and at many centers it is not available. So coming to the treatment, pulmonary embolism, supportive management is there. You have to support the hemodynamics and the ventilatory part of the patient. Hemodynamic stability can be provided by vasopressor, norepinephrine, dopamine, epinephrine, dobutamine, and inhaled nitric oxide in the institutes which can be used because it is a pulmonary vasodilator and it improves the right ventricular function and pulmonary gas exchange. Anticoagulants have to be added, subcutaneous or IV. Subcutaneous lower molecular weight heparin, they are usually added in acute non-massive pulmonary embolism, and unfractionated ones are added in massive acute PE because they are shorter duration of action, they are quickly titrable, and the situations where there is hypotension, renal insufficiency and morbid obesity where the absorption from subcutaneous route is not sure, then also IV unfractionated heparin can be used. So the doses in which these are used are IV unfractionated heparin as a bolus of 80 units per kg or 5,000 units and as an infusion of 80 units per kg per hour, and you have to monitor the APTT levels and NT10A activity. Subcutaneous unfractionated heparin, if you are not able to monitor, if you don't have facility to monitor it, then you give in bolus of 333 units per kg and maintenance of 250 units per kg BD. If you have a facility of monitoring by APTT and NT10A level activity measurements, then you can give it to 250 units per kg either twice daily or adjust every 6 hours, adjusted as per the levels achieved in APTT or NT10A activity. Subcutaneous low molecular weight heparin, enoxaparin, that is commonly used, commonly known as Clexane, is used. Deltaparin can be used. Fondaparinux can be used in patients who have renal dysfunctions also. So in the doses less than 55 milligrams QID, 50 to 100, 7.5 milligram QID, and more than 100 as 10 milligram QID. Further, thrombolysis can be done in patients who are hemodynamically unstable, who have refractory hypoxemia, and who have a lesser risk of bleeding. Whereas vena cava filters can be put if there are lower limb DVT is present and the patient is at a higher risk of bleeding. So you can put go for a lesser invasive vena cava filter. Pulmonary thromboembolectomy can also be done, but it is invasive. It is associated with mortality risk up to 27%. Also, it requires expertise and it is only done in patients who are unresponsive to medical treatment. Coming on to the next scenario, we have a 50-year-old female. She's posted for posterior fossa tumor surgery and in a sitting position, and intraoperatively there is sudden hemodynamical instability. And you can see heart rate is 120 per minute. BP is 64 by 38 millimeters of mercury. SpO2 is falling. EtCO2 is falling. So with this, patient who is going to be operated, who is being operated for posterior fossa tumor in a sitting position, what comes to your mind? I'm sure air embolism. Air embolism, also known as gas embolism, it is one or more than one air bubbles. They enter the vein or the artery and block it. So surgeries, most commonly it is there in surgeries which are above the heart level, commonly neurosurgery. It is iatrogenically also created if the pressure gradient is created and while inserting the central venous catheter. And also during the mechanical insufflation in the laparoscopic surgeries. So pathophysiology, if the operative site is more than 5 centimeters above the right atrium, higher chances of having patient the air embolism. Numerous larger uncompressed venous channels in the surgical field are open. They suck in air and that air gets sucked in. If the smaller amount of air is sucked in, it is absorbed in the circulation. If moderate pulmonary vascular injury is there, pulmonary hypertension can occur, pulmonary edema can occur. If larger volumes are absorbed, then what can happen? Right ventricular flow obstruction can occur, leading to death. In patients who have a patent foramen ovale, paradoxical embolism can occur, and it can go into the cerebral or myocardial ischemia, cerebral circulation or in the myocardium circulation. There is no such fixed amount of air which can be fatal. A smaller air can also sometimes become fatal. Otherwise, the literature says that 200 to 300 milliliters bolus or 3 to 5 ml per kg of air when inserted into the circulation can be fatal. Sign and symptoms, again, chest pain, dyspnea, tachypnea, hypoxia, wrongly mentioned as hypercarbia, it is hypocapnia actually. Pulmonary edema is there. And in heart, there is bradyarrhythmias, tachyarrhythmias, mill wheel, murmur may be there, ECG, ST segment changes, and right ventricular stain patterns are there. And because of the hypoperfusion, there are signs and symptoms of neurological signs and symptoms. Investigations, EtCO2 is decreased. N2 shows earlier changes, but because we are not usually measuring these levels, so it is missed. Transesophageal echocardiography, it is most sensitive and it can actually detect 0.02 ml per kg of air. Pericardial Doppler ultrasound with the help of ultrasound can also detect 0.05 milliliters per kg of the air. Pulmonary artery catheter, if it is there, it will show rise in pulmonary artery pressure. And CT scan can actually tell you about air in the central venous system, ventricles, pulmonary artery, or even the pneumothorax can be detected. Okay. So the treatment, our goal is to prevent further air entry, reduction in the volume of air which is entrained, and support hemodynamically. So how will we do? Since our patient who is being operated has developed air embolism, we will inform the surgeon, tell him to cover all the surgical site with saline or the dressing. Then sitting position is there, then you can give a jugular compression, which can actually limit the entry of air into the further circulation. Head down or lateral decubitus position, if possible, should be done. You should administer 100% oxygen, stop giving nitrous or air. IV fluid should be rushed in, inotropic support for maintaining the blood pressure. If you have inserted a central venous catheter, ideally, what we follow here in our institute is we insert a central venous catheter in posterior fossa tumors, and through one of the ports, we take a extension, IV extension, we put a 3-way, we attach a 20 cc, half-filled 20 cc syringe to it. So whenever such unfortunate incidents occurs, you can actually aspirate. So try and aspirate air from the right atrium, and later on you can give a hyperbaric oxygen therapy also if the patient survives. Coming on to the last case scenario in the perioperative thromboembolism. This is a 31-year-old male admitted in ward with fracture of right femur following a bike accident 36 hours back. So we received a call in ICU saying that patient has tachypnea. They have measured the SpO2, which is 91% on room air. He is mentally confused, delirium is there, and blood pressure is also lower, on the lower side. So whenever as a residence we get this call, I'm sure most of you must be getting. So what comes to your mind is fat embolism, because there's a history of long bone fracture and there is tachypnea, mental confusion, and low blood pressure. So fat embolism, commonly called as FES, fat embolism syndrome, it's a diagnosis of it's a clinical diagnosis. There are fat globules in the pulmonary circulation which actually cause all the symptoms. It usually occurs in 24 to 72 hours of the injury associated with orthopedic long bone closed fractures, also associated with joint replacement surgeries. Most commonly in males, the accidents, the patients who are more prone for fat embolism syndrome after the orthopedic trauma, common age group is 10 to 40 years, and it is associated with mortality of 5 to 15%. So early signs are dyspnea, tachypnea, and hypoxia. There is a triad of fat embolism syndrome, that is hypoxia, pulmonary involvement is there, neurological abnormalities are there, and petechial rash is there. Other symptoms are fever, thrombocytopenia, and retinopathy. So we will take up these symptoms one by one. Talking about the pulmonary part, the breath sounds may be harsh. You may hear creps or wheeze. Hypoxia will be there. Chest X-ray in earlier duration, it will be normal, but later on you can actually have snowstorm appearance. Bilateral infiltrates may be there. ARDS may be there. CT scan will also may show ground glass opacification with interlobular septal thinking, and patient may require mechanical ventilation. In neurological abnormalities, the incidence is 80% in fat embolism syndrome. It usually follows the pulmonary symptoms. The CT scan generally shows non-specific general edema. It is mostly transient and reversible. Coming on to the rash, it is petechial in nature. It is usually present in conjunctiva, neck, or axilla. Fat globules actually occlude the dermal capillaries. So when the occlusion is there, exudation of RBCs happens, and which causes the petechial rash. This usually resolves in 5 to 7 days. This kind of rash is actually pathognomic of fat embolism, and incidence is 5 to 20%. So there's a GERDS criteria, which is usually and commonly used in today's practice also to identify fat embolism. It has major features and minor features. Major features we have discussed: pulmonary, petechial rash, and cerebral signs. And minor features: tachycardia, pyrexia, retinal fat or petechiae, urinary fat, globules, sudden drop in HP, more than 20%, sudden drop in thrombocytopenia, more than 50%, and high ESR. So if you have a 1 major plus 4 minor and plus fat microglobulinemia, then the diagnosis of fat embolism is confirmed. So treatment for fat embolism is largely supportive. You have to support hemodynamically by giving vasopressors, inotropes. You have to support the pulmonary part also by giving either continuous positive air pressure or either ventilate the patient mechanically. You have to add antibiotics. You have to give nutritional support, because sometimes these patients take longer time to come out of the ventilation. And other things are corticosteroids, and heparin also needs to be added. Okay, so we have covered the thromboembolisms. Take home message for all of you are: there are some high risk patients and some high risk surgeries, and you have to keep a very high level of suspicion in these patients to identify the venous thromboembolism phenomena promptly and start the early management to have a better outcome. Also, early venous thromboembolism prophylaxis actually decreases the incidence of perioperative venous thromboembolic phenomena. So it is better to be vigilant than to be sorry later on. Whenever you have an unexplained hypoxemia, hypotension, and tachycardia with reduced EtCO2 values, you should always think about the perioperative thromboembolism phenomena. You should do an assessment of risk assessment module. Based on risk assessment module, you should check the patient whether he or she is at a higher risk or not, and do the needful. So with this, I conclude my talk, and I wish good luck for your exams. I know your exams are near and all of you are trying hard to pass it. You are stressed, but keep in mind that you can easily do it. Don't overthink it and take it easy. Good luck.
Usha ma'am, could you please unmute yourself?
Yeah, thank you. Can you hear me? Hello?
Yes, ma'am.
Yeah, thank you very much, Dr. Anchal, for that lucid presentation and very practical from the point of view of examination. But I also would like to ask you that do you practice any preventive measures
in a patient to prevent thromboembolism, venous thromboembolism in suspected patients where there is a very high risk of having a venous thromboembolism? Do you have any protective measures you do for preventing them?
Yes, ma'am. We usually start the thromboprophylaxis in high-risk patients. So as I've already said that we assess the patients, especially patients who are geriatric or who have a history of stroke or previous thromboembolic phenomena or deep vein thrombosis or have malignancies. We usually start them on low molecular weight heparins. Once they are admitted to the hospital and they're planned for surgery, if they are already taking oral anticoagulants, they are shifted to low molecular weight heparin and then thereby taken for the surgery.
Do you use any compression stockings or?
Yes, ma'am. In the post-operative periods, yes, we do use.
In critical care areas.
Yes, ma'am. We do use intermittent pneumatic compression devices in the immediate post-operative period.
I have certain questions for you, Dr. Anchal.
Hanji, ma'am.
From Dr. Lavanya Thakur, she's asking mechanism of pulmonary hypertension in air embolism.
So shall I answer, ma'am?
Yeah.
So basically, once there is venous air embolism, it actually goes into the circulation and gets blocked into the pulmonary circulation, thereby causing the hypoxia and release of what we call VGEF molecule, and it causes the pulmonary hypertension.
Yeah.
So there's another question.
There is another question. What is the role of separation phenomenon in thromboembolism?
So basically, separation phenomena is described as decrease in the EtCO2 level and thereby increase in the PaCO2 level. That is the separation phenomena. So that is the diagnostic of pulmonary embolism. If you have that points towards the pulmonary embolism.
Yes. And the third question is, how can we measure end-tidal nitrogen?
So we usually don't measure, we don't have that facility, but in books it is definitely mentioned that EtN2 levels, that is end-tidal nitrogen levels, they are early to change. But it is also mentioned that they are biphasic, so it has a confusing effect. So later on, once you have embolic phenomena, still it may keep detecting the EtN2 level.
And since you have a better method of detecting air embolism, this may not be one of the...
Yes, ma'am. It is basically EtCO2 levels are better. They are more sensitive.
Yeah.
But the early change may be there in the EtN2 levels.
Right. Thank you so much, Dr. Anchal.
Thank you so much, ma'am.
Thank you so much for that wonderful presentation. And I also want to thank the organizers of RML Hospital for giving me this opportunity to be part of this lecture. Thank you, Dr. Anchal. Thank you very much. Thank you, organizers.
Thank you, ma'am. Moving on to our next session, which is a long case discussion, which apparently is the last presentation. Which is the last case presentation of EPEC 2022. So for this, it's a patient of diabetes mellitus who is posted for radical mastectomy. So this is a very common scenario which we all come across and is a very important topic, very pertinent topic, a topic that you face every day in your operation theaters. And to deal with this topic, we have a very eminent faculty with us, Dr. Monisha Agarwal. Ma'am is Director Professor at Maulana Azad Medical College and Lok Nayak Hospital, New Delhi. Ma'am's area of special interest are fibroscopy, difficult airway management, ACLS and BLS, pediatric anesthesia, anesthesia for pediatric surgery, teaching and training, and medical oxygen infrastructure, logistics and management. We welcome you, ma'am. To moderate the session, we have with us Dr. Neha Gupta. Ma'am is Associate Professor at ABVMS and Dr. RML Hospital, New Delhi, with area of special interest as pediatric anesthesia. We welcome you, ma'am. The PG who will be presenting the case is Dr. Vijay. Dr. Vijay is a third-year postgraduate student at Dr. RML Hospital. I hand over the session to you, ma'am. You can go ahead with the case presentation. Thank you.
Thank you, Nitin, and the organizing team. Good afternoon, Vijay.
Good afternoon, ma'am.
So, did you have a good lunch?
Yes, ma'am, I had my lunch.
So, what is your body's response to this postprandial phase?
I'm feeling a bit energetic to start the case. Confident.
Pardon? I didn't get you.
Well, bit energetic after my meal.
Okay. What about the insulin secretion? This you should know.
Yes, ma'am.
So, what is a normal daily secretion by the pancreas in a normal adult patient?
Ma'am, basal insulin level, it is less than 25 international units per liter. Postprandial, it will increase up to 30 to 300 international units per liter.
Okay. So let's hear what you have to tell us about your case. You can start with your history of your patient.
Yes, ma'am. Ma'am, shall I start?
Yeah, start.
Good afternoon, everyone. I'm presenting a case of 50-year.
Vijay, can you share your slide?
Yes, 1 second. Ma'am, is the screen visible?
Yeah, it's visible.
Yes, ma'am. I'll start.
Go ahead.
Good afternoon, everyone. I'm presenting a case of 50-year female patient who is a resident of New Delhi. She has studied up to 12th standard and she belongs to upper middle class of socioeconomic state. She presented with the chief complaints of lump in the right breast since 6 months. Patient was apparently normal 6 months back. She accidentally felt a mass in the upper part of the right breast 6 months ago, which is progressive in size. Initially, it was around 1 inch size. She also complains of increase in the size from the past 2 months. Currently, the size is twice the initial size. The lump is not associated with any pain or discharge. There is no history of fever or trauma to the breast. No history of nipple retraction or nipple discharge. There was no history of loss of weight or loss of appetite. Patient went to the general surgery department with these complaints 1 month back, and she was diagnosed with carcinoma of breast and she was advised surgical excision of the same. There was no history of similar complaints in the other breast, no history of swelling in the axillary region. There is no history of backache, dyspnea, hemoptysis, pain abdomen, jaundice, headache or seizures. There was no history of radiotherapy or chemotherapy in the past. Coming to the past history, patient is a known case of diabetes mellitus from past 4 years. She had increased frequency of micturition, increased appetite, and increased the easy fatigability 4 years back. She went to a clinic with these complaints and she was diagnosed with diabetes mellitus. She was put on oral hypoglycemic agents for the same, and her symptoms got relieved over a period of months. Since then, she is complained to her treatment and she is on regular follow-up with the physician. There was uncontrolled sugars 2 years ago, and dose modification was done 2 years ago for the same. There is no history of increase in appetite, increased urination or thirst at present. There is no history of decreased sensation, tingling sensation or numbness in the upper limb or lower limbs. No history of facial swelling, decreased urine output, burning micturition or recurrent urinary tract infections. There was no history of blurring of vision or frequent change of spectacles. There was no history of pain during walking or wounds on the lower limb. There is no history of breathing difficulty, chest pain, palpitation, sweating, feet swelling, or poor exercise tolerance. There is no history of repeated falls or LOC or weakness of limb. There is no history of giddiness on standing, nausea, vomiting, abdominal bloating, constipation, diarrhea, or lack of sweating. There is no history suggestive of hypo or hyperglycemic attacks in the past. There is no history of previous hospital admission or any other chronic medical illnesses like hypertension, asthma, tuberculosis, or thyroid disease. There is no history of allergy or previous surgical exposure in the past. There is no history of COVID infection in the past, and my patient is vaccinated with 2 doses of vaccine. Family history. She is married for 28 years, and there is no history of diabetes mellitus or breast cancer in the family members. There is no history of chronic medical illnesses like hypertension, asthma, tuberculosis, or thyroid disorder in the family. Personal history. She follows a mixed diet, and her sleep pattern is normal. Bowel and bladder habits are normal. She is non-alcoholic and non-smoker. Obstetric history. She is married for 28 years. It's a non-consanguineous marriage. She has 2 children. Both were full-term and normal vaginal delivery, and breastfeeding was adequate. Her age of menarche was at 12 years, and she attained menopause at 45 years of age. There is no history of OCP or hormone replacement therapy. Treatment history. She is on treatment for diabetes mellitus for past 4 years. Initially, she was started with the tablet metformin, 500 mg BD before food. And 2 years back, she had increased glucose levels, and she started with glimepiride 2 mg BD. She was never on insulin. She is complement to her treatment. There is no history of giddiness or lightheadedness after skipping a meal. No history of any other drug intake or drug allergy. And drugs and dosages were confirmed by seeing the prescription. Examination. Patient was examined after taking proper informed consent and in presence of a female attendee. Patient was conscious, oriented to time, place, and person, and sitting comfortably on bed. Her height was 165 centimeter, weight was 60 kg, and her BMI was 22 kg per meter square. She is afebrile to touch. There was no signs of pallor, icterus, cyanosis, clubbing, or lymphadenopathy seen. There was no wounds or scars over the feet. Her JVP looks normal, and venous access were easy. Vital examination. Her pulse rate was 80 beats per minute, measured in right radial artery, regular rhythm, good volume, normal character, and there was no radial or radiofemoral delay, and all the peripheral pulses were palpable. BP. First I measured BP in supine position, which was 128 by 84 millimeter of mercury, and in standing position after 3 minutes it was 120 by 80 millimeter of mercury. Her respiratory rate was 15 cycles per minute, and which was thoraco-abdominal type. Saturation was 99% on room air. Low airway examination. There was no obvious craniofacial abnormality seen. Bilateral nares were patent. There was no DNS or no growth. Mouth opening was adequate, which was more than 3 fingers. Inter-incisor gap was 5 centimeters. Oral hygiene was good. There was no loose teeth, artificial teeth, or buck teeth. Modified Mallampati grading was 2. Neck, sternomental, thyromental, and hyomental distances were within normal limit, and range of movements were normal. There was no signs of stiff joint syndrome. Coming to the local examination, inspection of the breast was done in sitting position. Level of the nipples, right nipple appears little lower when compared to the left. Left breast looks completely normal. Right breast examination, a mass is seen in the outer quadrant of the right breast, measuring approximately 6 into 5 centimeter. Skin over the swelling looks normal. There was no prominent veins, redness, edema, or pudy orange appearance. There was no dimpling or puckering seen. No nipple retraction or discharge seen. And bilateral axilla looks normal. Palpation of the swelling. left breast was normal, right breast, there is no local rise of temperature. An ill-defined lump was palpated, approximately palpated 6 into 5 centimeter in the outer upper quadrant of the right breast. Lump was hard, non-tender and mobile, fixed to the skin, but free from nipple areolar complex, pectoralis muscle and chest wall. And nipple areolar complex was normal. Bilateral axillae and palpation was normal. Systemic examination. Cardiovascular system examination. Shape of the chest was normal. There was no visible precordial bulge seen, no scars, sinuses or dilated veins, no visible pulsations or rise in JVP.
Vijay, are there any positive findings in any of the systemic examinations you would like to tell us?
Ma'am, no, ma'am. My systemic examinations were within normal. Cardiovascular.
Okay. So, what's your tentative diagnosis based on your history and examination?
Ma'am, a 50-year-old female patient with diagnosed case of diabetes mellitus with carcinoma breast or modified radical mastectomy without complications of that.
Okay. So she's 55 years old with diabetes, posted for modified radical mastectomy.
Yes.
Is it?
Yes.
Okay. So how do you diagnose diabetes? What is the criteria?
American Diabetes Association criteria. We will do fasting blood sugar, postprandial blood sugar, and HbA1c levels. If the fasting blood sugar levels are more than or equal to 126 milligram per deciliter, and second hour postprandial blood sugar more than 200 milligram per deciliter, or HbA1c levels of more than 6.5% is diagnostic of diabetes mellitus.
Okay, so what is the relation between blood glucose levels in the whole blood and the plasma? Is there any difference?
Yes, ma'am. Serum blood glucose level is 15% higher than the whole blood glucose level. 15%.
Okay. Okay. What about the arterial versus venous?
Arterial and capillary blood glucose were equal, and these are 7% higher than the venous blood glucose.
Okay. Okay. So how do you classify various types of diabetes?
Ma'am, diabetes can be classified into primary and secondary. Under primary diabetes, we have type 1 diabetes, which is also called as insulin-dependent diabetes mellitus, which is further classified into 1A and 1B. 1A is because of autoimmune disorder, and 1B is iatrogen. We have type 2 diabetes mellitus, which is also called as a non-insulin dependent diabetes mellitus. And third one is gestational diabetes mellitus. Under secondary diabetes, we have secondary causes. The primary causes like endocrinological disorders like acromegaly, Cushing syndrome, hyperthyroidism, glucagonoma, somatostatinoma, pheochromocytoma, and we have drug-induced diabetes mellitus, and the drugs are glucocorticoids, beta blockers, phenytoin.
Okay, so based on your history and examination, can you infer what kind of diabetes your patient has?
Ma'am, since my patient is on oral hypoglycemic agent, and her age is more than 40 years, and it might be type 2 diabetes mellitus.
Okay, so what are the medication she is on? She's on OHAs, isn't it?
Yes,
metformin and glimepiride.
Yes, ma'am.
So what are the other oral hypoglycemic agents? How do you classify them?
Oral hypoglycemic agents are classified under insulin secretagogues, which increases the release of insulin. Example are sulfonylureas and biguanides. Under sulfonylureas, we have first generation and second generation. First generation like tolbutamide and chloropropamide. Second generation sulfonylureas are glimepiride, gliburide, gliclamide, glibenclamide, etc. And biguanides are metformin and fenformin. And we have alpha glucosidase inhibitors like acarbose and peglytol, thiazolidine diones like rosiglitazone and pioglitazone, and glucagon like peptide 1, and we have DPP-4 inhibitors, and we have SGLT2 inhibitors, sodium glucose transport 2 inhibitors.
Okay. And the other kind of diabetes where you need to put the patient on insulin. So what are the various kind of insulin? Just name them, enumerate them available to us.
Ma'am, we have short-acting, intermediate-acting, and long-acting. Under short-acting, we have insulin Lispra and Aspart, and regular insulin. Intermediate-acting, we have insulin NPH, that is Isofen, and insulin Lente. Long-acting insulins are insulin Glargine and insulin Ultra Lente, Detimer and Degludec also.
So what are the why is it necessary to control the blood sugar levels in these patients? What are the adverse effects of hyperglycemia per se?
Hyperglycemia, it induces osmotic diuresis. There are higher chances of dehydration and electrolyte imbalance in these patients. And immunity is also decreased in these patients. Chances of wound infection is high, and wound healing is delayed, and there are higher chances of mortality and morbidity and ICU stay, hospital stay. And
hyperviscosity is also there.
Yes,
so it can lead to thrombogenic complications.
Yes, ma'am.
And there is metabolic and electrolyte derangement also, isn't it?
Yes, ma'am.
Okay. So how does what all other, as you have elicited very nicely in your history, high blood sugar levels lead to, persistent high blood sugar levels lead to end organ damage, isn't it? Various kind of complication. Can you tell us about that?
Diabetes mellitus complications, which are classified as acute and chronic complications. Under acute complication, we have diabetic ketoacidosis, hyperosmolar non-ketotic coma, hypoglycemia, and lactic acidosis. And chronic complications are microvascular complications and macrovascular complications. Microvascular complications are diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. And under macrovascular, we have cerebrovascular accidents, peripheral vascular disease, and cardiac coronary artery disease. And
how do you usually assess the glycemic control in any patient? What all tests do you do?
Investigation wise, we'll ask for fasting blood sugar, postprandial blood sugar, and HbA1c levels.
Okay, what is HbA1c? What does it tell you?
Ma'am, it's a glycosylated hemoglobin percentage. It tells the glycemic control preceding the 60 to 90 days preceding period.
Okay, so what is normal and what is abnormal? HbA1c.
HbA1c levels normal is less than 5.7%, and 5.7 to 6.4 is borderline. More than 6.5% is diagnostic of diabetes mellitus.
And patients who have HbA1c more than 6.5, they are more prone to develop various micro and macrovascular complications following diabetes. Okay, so your patient is posted for MRM. How all will you investigate her?
Ma'am, first I'll order complete blood count. I would like to see the hemoglobin and TLC levels. Hemoglobin level as a baseline for major surgery, and it might be decreased in chronic nephropathy patients. TLC levels, because diabetic patients are more prone for infections, and to rule out infections, I'll see TLC. And I'll order fasting blood sugar, postprandial blood sugar, and HbA1c level to see the glycemic control. I'll order urine routine to see proteinuria, glycosuria, and ketone levels. I'll also order serum electrolytes with renal function test to rule out nephropathy. And I would like to order ECG and chest X-ray, and LFT to see the baseline liver function test. And
anything else?
Ma'am, that's it. Ma'am, in complicated cases, we can ask for 2D echo also.
Okay. So, what would be your anesthetic plan for this patient? Yeah, how will you decide what anesthesia to give this patient? Are there any factors according to which you decide your anesthetic management in any patient?
Ma'am, it is based on the type of the surgery, duration of the surgery, and
Okay.
urgency of the surgery.
Okay.
Ma'am, and time required to resume the oral intake after the surgery. Ma'am,
So you must decide what type of diabetes your patient has.
Yes, ma'am. Yes, ma'am.
For how long it has been persisting? What is the glycemic control like? What medication the patient is on? Whether she or he has any comorbidities, whether they are under well control or not. Then, as you said, the type of surgery, whether it is elective or emergency, and something else.
Minor and
It is major or minor, and then need for post-op ICU requirement also should be taken into account. So you have told us the history, examination, we have reached to a diagnosis. Now tell me, what is your anesthetic plan for this patient?
Ma'am, I would like to give I would like to give general anesthesia with intubation, endotracheal intubation and controlled mechanical ventilation for my patient.
Okay, so you talked about this types of surgeries which can affect your anesthetic management. What is the difference between a major surgery and a minor surgery? What would be this MRM surgery? Where will you place this kind of surgery?
Ma'am, it depends on the time period for restarting the regular diet after the surgery and the duration of surgery. And if the duration of surgery is less than 30 minutes, it's minor. If it is more than 3 hours, it is major. 30 minutes to 3 hours is intermediate. And if the patient can restart the oral diet within 24 hours of surgery, it will come under minor surgery. And if a 24-hour period is required, it comes under major surgery.
So where will you place your patient? What kind of surgery is MRM?
Ma'am, intermediate surgery.
Intermediate, okay. Because it's her this diabetic management is likely to be effective, at least on the day of surgery.
Yes.
Okay. So you talked about various end organ complications, microvascular and macrovascular. So coming to those first and their anesthetic implications. So tell me about diabetic nephropathy, the important highlights and its anesthetic implications.
Ma'am, diabetic nephropathy, the pathogenesis is initially there will be glomerular hyperfiltration followed by increased glomerular hyperosmolality causing the glomerular membrane damage, and it presents with microalbuminuria. It's the first sign of nephropathy. And those who have nephropathy, we should consider that drug excretion is impaired in these patients, and these patients are more prone for post-surgical renal failure.
Yeah, that's very important. They are very prone to UTIs and post-op renal failure. And most of this patient, very high percentage, 27 to 58%, do have hypertension associated. It is usually the hypertension which accelerates the renal dysfunction. So that has to be taken into account. Okay, what else? And what kind of drugs are helpful for such patients? ACE inhibitors. They are usually, diabetic nephropathy. They are usually given ACE inhibitors to improve that. Okay, then what next? Then you have talked about nephropathy. Then peripheral neuropathy. That's another microvascular complication.
Yes, ma'am. Ma'am, peripheral neuropathy, it's a symmetric.
What all do the patients complain of if they have peripheral neuropathy?
Ma'am, tingling sensation, decreased in sensation of numbness over the lower limb, and patient might complaining of non-healing chronic wounds over the lower limb, and difficulty in standing, history of repeated falls. And
okay. So what are the anesthetic implication if your patient had peripheral neuropathy? What precautions do you need to take?
Ma'am, these patients are more nerve injuries are more common in these patients. We have to adequately pad the pressure areas in these patients, and local anesthetic.
So while positioning them, you have to take care of the pressure points.
Yes.
What else?
Ma'am, local anesthetic drug requirement will be less in these patients, and we should avoid epinephrine in these patients because it causes vasoconstriction and further ischemia of the nerve.
Okay. What about diabetic retinopathy? What are the complaints the patient has?
A patient complaint of blurring of vision or frequent change in the spectacles power, and we should ask for fundus examination if suspected.
Okay, so anesthetic implications. If suppose patient has proliferative retinopathy, then what can occur?
During laryngoscopy, the intraocular pressure might increase and chances of damage to the retina.
Vitreous hemorrhage can occur.
Vitreous hemorrhage, yes.
Yeah. So what are the effects of high blood sugar on cardiovascular system? How this system is affected? Coming to the macrovascular complications.
Yes. Ma'am, there is increased chances of premature atheroma formation and increased coagulability and decreased fibrinolysis. The patient might present with history of MI or acute MI, and they are unaware of these MI symptoms of these attack, silent MI, and chances of systolic or diastolic dysfunction are there. Diabetic neuropathy is there, autonomic neuropathy, and these patients are more prone for positional change, like compensatory mechanisms are compromised in these patients. They are more prone when there is a position change or when there is an increase in demand.
So are you? Is there anything else you would like to tell about the cardiovascular system? So these patients are more prone to CAD, hypertension, cardiac dysarrhythmias. All right. Then what are the effects on the respiratory system?
Ma'am, respiratory system, there is a decrease in functional residual capacity and residual volume, and response to
why should be there are decrease in residual volume and FRC?
Ma'am, because of glycosylation and decrease in elastance compliance of the lung.
Okay, what else?
Ma'am, there is a decrease in response to hypoxia and the hypercarbia, and patients are more prone for depressive effects of the anesthetic drugs. And oxygen hemoglobin curve, it shifts to the left side. Decreased oxygen delivery.
Okay, so these are the changes of the respiratory system. And now just tell me, how do you diagnose, what are the signs and symptoms of diabetic autonomic neuropathy? You have elicited very nicely the history pertaining to that. So what are the signs and symptoms of diabetic autonomic neuropathy?
Ma'am, diabetic autonomic neuropathy, it affects all the system. So under cardiovascular system, we'll have orthostatic hypertension and decrease in heart rate variability, and silent MI, and decreased exercise intolerance. And under gastrointestinal system, we have gastroparesis, early satiety, bloating, postprandial vomiting, and under urinary system, we have urinary retention, retrograde ejaculation, and repeated urinary tract infection, decreased urine output.
So when a patient has diabetic autonomic neuropathy, regarding the cardiovascular system, the cardiovascular response to things like blood loss, change in the position, IPPV, various induction agents, and your even regional anesthesia like spinal anesthesia, the degree of hypotension, they do not respond. Compensated response is blunted. Even if you treat it with atropine, the response is not good. Okay. Then their ventilatory response to hypoxia, hypercarbia is depressed. So they may go into respiratory arrest. Then because of the gastroparesis, there is increased risk of aspiration, isn't it? And so what is the other anesthetic implication? You may need to do RSI, rapid sequence induction, in many of the patients who have this diabetic autonomic neuropathy, right? Then there is urinary stasis. You may need to catheterize them. And what else? They are prone to, because of this, they are prone to intraoperative hypothermia also.
Yes.
Isn't it? What else? What else? Anything else? Then they are prone to dysarrhythmias because of loss of heart rate variability. Yeah. So how, are there any tests or investigations by which you can infer that your patient has or does not have diabetic autonomic neuropathy?
Ma'am, diabetic autonomic neuropathy, it involves both parasympathetic and sympathetic system. It in early stages, it involves parasympathetic sympathetic system, and we have tests to diagnose these. Under parasympathetic test, we have heart rate variability to deep-breathing, heart rate variability to standing, and heart rate variability in Valsalva maneuver and resting tachycardia. Under sympathetic system tests, we have blood pressure variations, blood pressure variation for standing, blood pressure variation for hand grip test, and Valsalva in Valsalva maneuver. Resting tachycardia more than 120 beats per minute, heart rate variability to deep breathing. We'll ask the patient to breathe at a rate of 6 breaths per minute. That is 5 seconds for inspiration and 5 seconds.
Okay, once you perform all these tests, then there is a DANS scoring, isn't it?
Yes,
after you have performed all these tests, we calculate the DANS scoring. So tell me about that.
No.
What's the normal DANS scoring?
Normal is 0 to 0.5. It's normal.
Yeah.
Early changes, it is 1 to 1.5. 2 to 3.5 is definitive derangement. And more than 4 to 5 is severe impairment.
Okay. So your patient, does she have any signs, symptoms suggestive of diabetic autonomic neuropathy?
No, ma'am. There was no.
Okay. All right. So this patient, would you say that she is controlled as far as her glycemic control is there? Is she a controlled patient on OHS?
Yes, ma'am. She is controlled under oral hypoglycemic.
Okay. So when do you shift the patient from OHS to insulin? What is the criteria?
Ma'am, if the patient is undergoing any, if she's undergoing major surgery, we have to shift from oral hypoglycemic agents to the insulin regimen. And if there is uncontrolled glucose levels with oral hypoglycemic agents, we have to shift her to insulin preoperatively.
Okay. So what pre-op orders will you write for your patient? Suppose she's scheduled for surgery tomorrow morning at 9 a.m. and you are visiting her today evening. So what pre-op orders will you write for this patient?
Ma'am, I'll order to keep the patient first on the day of surgery to be taken as first case, and I'll keep her NPO for 8 to 10 hours, and I'll ask her to omit the morning dose of oral hypoglycemic agents. And
Why 8 to 10 hours? Why 8 to 10 hours?
Ma'am, diabetic patients are they might be having undiagnosed gastroparesis, and they are considered full stomach. So I would like to keep little
longer fasting period. Okay. What else? NPO next.
Ma'am, I'll ask her to omit the morning dose of oral hypoglycemic agents.
Okay.
And I'll ask to send the blood glucose cross matching. And on the day of surgery, I'll ask to send fasting blood sugar and serum electrolyte levels. and informed consent to be taken. And on the morning of surgery, if her blood glucose levels are more than 100 milligram per deciliter, I'll ask to start the glucose insulin infusion from 8 a.m. 100 ml per hour.
Anything else would you like to write or prescribe your patient?
Ma'am, I'll prescribe tablet ranitidine 150 milligram on the night and morning of surgery.
So aspiration prophylaxis, a prokinetic and an antacid should be given. Okay. Anything? Anxiolytic, sedative?
Ma'am, for anxiolysis, if difficulty is anticipated, usually we won't give.
You have examined the patient. Does your patient have any difficult
No,
in airway management?
She doesn't.
So, okay. Then what would you give as in for anxiolysis?
Ma'am, tablet alprazolam 0.25 mg night before the surgery.
Okay. And one should arrange adequate amount of what? Blood and blood products.
Yes, ma'am. Cross matching.
Okay. And anything else? You will arrange for glucometer, insulin, glucose sticks for the theater. Okay. So coming morning, what do we do?
Ma'am, we'll ask for the fasting blood sugar levels and serum electrolytes on the day of surgery. And
okay.
I'll arrange the OT for my patient. I'll check the anesthesia machine. I'll make the emergency drugs available and the induction agents according to our body weight. I'll arrange intubation trolley, including airways, intubation, ET tubes, supraglottic airways.
Okay. Suppose let's assume that just 2 days prior to the surgical procedure, it was scheduled, her blood sugar levels were not very much under control. And because it's a carcinoma, surgeons did not want to wait. And she was shifted on to regular insulin.
Yes, ma'am.
Okay. Okay.
Yes,
so instead of OHs, she's now on regular insulin. So how would you manage the glycemic control of this patient perioperatively? Would you write any different pre-op orders for her in addition to what you had written earlier?
Ma'am, since she's on regular insulin, she can continue the regular insulin night before the surgery. On the morning of surgery, I will ask to omit the morning dose of regular insulin, and I'll start the glucose insulin infusion for this patient. So
okay.
I would like
how much glucose, how much insulin? What regime are you following?
Ma'am, I would like to use Velo regimen for my patient. For this patient.
Okay.
Ma'am, Velo regimen will give 100 ml of 5% dextrose, and we'll check the blood glucose level of the patient. If the blood glucose level is 70 to 100, we won't add any insulin for this patient. For every 50 milligram insulin more than 100 milligram, we'll add 1 unit of insulin to that 100 ml 5% dextrose. And if the blood glucose levels are more than 300, we'll change the fluid. We'll add normal saline 100 ml and 1 unit of insulin for every 50 milligram increase in blood glucose level more than.
So 1 gram of glucose is neutralized by how many units of insulin?
0.32 international units of regular insulin.
Okay. Now, just 1 millimole of glucose is equivalent to how many milligrams?
18 milligram per deciliter.
Okay. So, and 1 unit of insulin neutralizes how many grams of glucose?
Ma'am, in vitro it neutralizes 3 gram of glucose, and in vivo it reduces 25 to 30 milligram per deciliter.
Okay. Okay. So now the patient is on the table. What all monitoring will you ensue?
Ma'am, first I will attach ASA standard monitoring, which includes pulse oximeter, ECG, non-invasive blood pressure, and ETCO2 and temperature monitoring. And I'll arrange blood glucose, glucometer and strips for continuous blood glucose monitoring. And then I'll take two large bore cannulas, one for glucose insulin infusion and one for fluid deficit management.
Okay, tell me about the induction. How will you proceed for the induction of anesthesia?
Ma'am, since my plan is general anesthesia with endotracheal intubation, I'll start with deoxygenating my patient with 100% oxygen and flow rate of 10 liter per minute. Since the end tidal oxygen till the end tidal oxygen levels will come to 85 to 90%. Then I'll give injection midazolam 1 mg, injection fentanyl 120 micrograms, and I'll start.
What is the weight of your patient?
Ma'am, 60 kg.
Okay.
And I'll give induction agent propofol 2 mg per kg in titrating doses, and I'll check for the ventilation. If the patient is able to ventilate, I'll give muscle relaxant injection vecuronium 6 mg stat, and I'll do positive pressure ventilation for 3 minutes, and I'll give xylocaine 1.5 mg per kg to reduce the laryngoscopic response. And after 3 minutes of positive pressure ventilation under direct laryngoscopy, I'll secure the trachea with endotracheal tube of size 7.5 mm, and I'll fix the tube to the right angle of the mouth, and I'll confirm the bilateral air entry equality, and then I'll put her on controlled volume control ventilation with oxygen, nitrous oxide, and sevoflurane.
What will be your intraoperative goals as regards the glycemic control of the patient?
Intraoperatively, I'll maintain her blood glucose levels between 120 to 180 milligram per deciliter.
Okay. And you should minimize hyperglycemia. What else is important?
Ma'am, we should avoid hypoglycemia, and we should avoid ketosis. And
okay, how will you avoid ketosis? What leads to ketosis?
Insulin deficiency and surgical stress response, which causes the synthesis of glucocorticoids, glucagon, cortisol, and these are anti-insulin and ketogenic property.
And what about the metabolic and electrolyte balance?
Ma'am, electrolytes, every 4th hourly we have to monitor electrolyte levels in these patients. There are higher chances of hypokalemia in these patients, and hyponatremia, hypokalemia.
So when would you replace potassium?
Ma'am,
when would you replace potassium?
Ma'am, if it is less than 3.5 milliequivalent per liter, we have to replace. We have to supplement potassium also. 10 milliequivalent per hour.
Okay. So how do you decide what kind of fluids to infuse intraoperatively besides your GI infusion? What other fluid will be used?
Ma'am, normal saline, we can use normal saline.
Okay, what about ringer lactate?
Ma'am, ringer lactate, it has lactate in it, and there is chances of it gets converted into glucose after infusion. So it's better to use normal saline than ringer lactate.
Okay, it is not absolutely contraindicated, because even if you rapidly infuse 1 vac of ringer lactate, it will increase the glucose by 1 millimoles per liter. So though it is inappropriate to use ringer lactate, you can use normal saline.
Yes, ma'am.
So suppose when you were, how frequently do you check the blood glucose intraoperatively?
Intraoperatively, I check every 1 hour.
Okay. So after an hour, when you check the blood glucose level, it was 60 milligram%. What will you do?
Ma'am, we have to stop the insulin infusion, and we have to give 100 ml of 5% dextrose and repeat the glucose levels after 15 minutes.
Okay, and the next reading comes between 70 to 100 or 80, say. What will you?
Ma'am, continue 100 ml per hour infusion, 5% dextrose. No, we should not start insulin.
So how can you recognize hypoglycemia under general anesthesia? What is the best way to detect hypoglycemia under general anesthesia?
Ma'am, under general anesthesia, patient does not show any signs, so we can monitor bispectral index.
So what's the relation between bispectral index and hypoglycemia?
Ma'am, hypoglycemia, it causes neuronal hypoxemia, and patient's BIS level will decrease. He will go into deep anesthetic, he will go to deep anesthesia for normal concentration of drugs.
See, the best way of monitoring hypoglycemia under general anesthesia is by doing the blood glucose level. That's the best way. And there are anecdotal reports of clinical reports where they have found that BIS was abnormally low. And when they did the blood glucose, and it was found to be, the patient was hypoglycemic. So if you find unusually low, BIS values, and it is not getting clinically correlated, then you must suspect hypoglycemia. Okay.
Yes, ma'am.
So what is the other regime you can follow? This is the Velo regime.
Yes,
there's another, what is tight control regime?
Tight control regime will control the glucose levels between 70 to 110 milligram of deciliter. It is
What is the level of blood glucose which is maintained?
Ma'am, 70 to 110 milligram per deciliter. And
Where especially it is recommended?
Ma'am, it is recommended in type 1 diabetes patients and patients undergoing cardiac surgery, neurosurgery, transplant surgery, patient with sepsis, pregnant patients, and patients on glucocorticosteroids and obese.
Or your patient gets shifted to your critical care unit.
Yes,
then also tight control regime is followed. Okay. So any other intraoperative problem you anticipate in this patient?
Intraoperatively, patient he might go into cardiac arrest or resistant hypertension, hypoglycemia.
Okay, so the surgery is over. How do you reverse the anesthesia process in this patient?
And before
what about analgesia, post-op analgesia?
For post-op analgesia, I would like to give PEC1 and PEC2 block for my patient. So since it is a open surgery, I'll ask the surgeon to infiltrate the drug between PEC2 block.
So where is PEC1 and where is PEC2 block given?
PEC1 block, it is given between two muscles, pectoralis major and pectoralis minor. PEC2 will give PEC1 plus we also infiltrate between pectoralis minor and serratus anterior muscle. So,
what drug would you like to use?
Ma'am, I would like to use bupivacaine for 0.25% concentration, 10 to 12 ml in both the places.
Okay. So you have extubated the patient. Now you have shifted, everything is okay. You have shifted your patient to post-operative area. So how will you manage and what important precautions will you take once you have shifted your patient to the post-op area?
In post-op area, I would like to continue the glucose monitoring till it becomes normal. Every second hourly I'll be doing till it becomes normal. Thereafter, we can monitor every 4th hourly. And we should make sure that patient is pain-free because pain can induce hyperglycemia. And
what other post-op complications do you expect in your patient?
Hypoglycemia and hypoxemia.
Once you had, let's say that you had shifted out your patient in the post-op area and you went to your theater and you started the next case. Yes, after about 40-45 minutes, the nursing staff comes running to you and tells you that the patient has become drowsy, heart rate is 120, blood pressure is 80 millimeters of systolic blood pressure. So what do you think has gone wrong with your patient and how will you manage?
My differential diagnosis will be hypotension, hypovolemia causing hypertension, hypoglycemic coma, and I'll check the BP of my patient and RBS level immediately, and hypoxemia can also cause
So
hypertension.
how will you manage? What will you do? Tell me stepwise.
Ma'am, if it is because of hypoglycemia, I'll infuse 50% dextrose 25 ml.
See, any patient having patient with such an emergent situation, the first and the primary thing that you do is take care of ABC. Isn't it? I told you that patient is drowsy, tachycardic, hypotensive. The first thing you should do is ABC, and along with that, you search for the cause as you have enumerated and treat the patient accordingly. So first of all, you have to maintain, you might lose the airway of the patient if she's drowsy, GCS goes below 8, isn't it? So you have to maintain a patent airway, give 100% oxygen, fluids, and
Yes.
meanwhile you rapidly check her blood glucose, whether it is hypo or hyperglycemia. You must also check for what else? What are the other acute complications of diabetes you were mentioning earlier?
Yes, ma'am. Ketoacidosis and hyperosmolar non-ketotic coma.
So what is diabetic ketoacidosis? How does the patient present?
Ma'am, diabetic ketoacidosis patient will have nausea, vomiting, abdominal pain, drowsiness, ketotic breathing, small signs of dehydration, like tachycardia, hypertension.
So this patient, could she be in ketotic acidosis?
Yes, ma'am.
Okay. So how do you treat such a patient? A patient of diabetic ketoacidosis.
Ma'am, our main goals will be to correct the dehydration and correct the hyperglycemia and treat the ketosis. So we'll start the IV fluids in diabetic ketoacidosis. We'll infuse 1 liter over half an hour, and we'll start insulin 0.1 international units per kg per hour start, followed by infusion 0.1 units per kg per hour. If potassium is more than 3.5, if potassium is less than 3.5, 3.5, we have to correct potassium before starting the insulin.
So once your blood sugar level comes below 250 or 250, then what change do you do?
Ma'am, we'll add 5% dextrose in the fluids.
Okay. So how do you differentiate this diabetic ketoacidosis from non-ketotic hyperosmolar acidosis? What are the major differences? Biochemically, if I do the investigations?
Yes, ma'am. Ma'am, diabetic ketoacidosis patients will have blood glucose levels of more than 250 milligram per deciliter, whereas in hyperosmolar, the blood glucose levels will be more than or equal to 600 milligram per deciliter. And in diabetic ketoacidosis, we'll see acidosis that is a pH less than 7.3. In hyperosmolar, it is more than 7.3. And bicarbonate levels less than 15 milliequivalents per liter in ketoacidosis and more than 15 milliequivalents in hyperosmolar. And there is an anion gap of more than 12 in ketoacidosis and less than 12 in hyperosmolar, and serum osmolarity less than 310 in ketoacidosis and more than 350 in hyperosmolar coma. And
how do you treat?
Ketone bodies are positive in diabetic ketoacidosis. That is a 2+ in dipstick method. Okay.
So how do you treat hyperosmolar non-ketotic coma?
Ma'am, these patients will have higher levels of dehydration compared to diabetic ketoacidosis. We have to give more fluids for these patients. First, we'll start with dehydration correction. And most of the patients, the hyperglycemia level will come down with the dehydration. And we'll start the—
How large are the fluid deficits? Approximately, how large are the fluid deficits in such a patient?
50 to 100 ml in diabetic ketoacidosis and 100 to 200 ml per kg in hyperosmolar non-ketotic coma.
Okay. When would you start giving insulin to this patient?
Ma'am, after correcting 2 hours after correcting dehydration, I'll start insulin 0.05 international units per kg per hour. Bolus dose.
Okay. How rapidly or slowly do you correct blood glucose levels in these patients, and why?
Ma'am, there are higher chances of cerebral edema if we correct rapidly.
Okay. So, why? What is the problem? Why cerebral edema can occur if you correct the hyperglycemia very swiftly in these patients?
Ma'am, before starting the correction, there will be hyperosmolarity in both plasma and central that is neurological cells, neural cells. Once we correct the hyperglycemia rapidly, it will become plasma will become more hypoosmolar than neuronal cells, and there is a shift of fluid from plasma to the neuronal cells, causing edema.
So you should never correct the hyperglycemia rapidly.
Yes, ma'am.
In these patients. So suppose apart from this patient, what are the advantages of regional anesthesia in any diabetic patient?
Ma'am, regional
Would you
anesthesia.
have done this patient of yours in some regional anesthesia?
Yes, ma'am. We could have used thoracic epidural and paravertebral block also we could have used. Ma'am, regional anesthesia, since the patient will be awake, we can easily monitor the signs and symptoms of hypoglycemia, and it will prevent the stress response when compared to GA. It will decrease the stress response, and patient can start the oral feeding early, and there is less chances of hospital stay, and it also produces post-surgical analgesia also.
Okay, so you are aware of the latest guidelines on perioperative management, which have come up in 2021? Any gist? Have you read? Okay, just I'll just enumerate. In UK, there was a large confidential inquiry into the patient's surgical outcomes and deaths, and they found that 18% of their beds in almost all the hospitals were occupied by diabetic patients, and they had very poor perioperative outcome. So following that, they issued a report known as highs and lows. And what they found was why these patients had a bad perioperative outcome was that there was a very poor communication between the multiple disciplinary departments which look after the patient. For example, the medicine, the endocrinologist, the surgeon, and the anesthetist. Okay, that was one of the major reason for the poor outcome, as well as very inadequate intraoperative as well as post-operative blood glucose monitoring, which was contributing to the bad outcome. So what they recommend is that there should be a good referral system between each of these specialities so that the patient's perioperative glucose levels are well managed. And it is ideal to maintain the blood glucose level between 6 to 12 millimoles per liter. And they have stressed again and again on very good intra as well as post-operative blood glucose monitoring. Then they have also emphasized on something known as early dreaming, where dreaming word stands for early drinking, eating, and mobilization. All right, all these help so that as early as patient can resume his or her oral intake, you can manage the treatment part in a better way, isn't it? And then a very important thing which we perhaps don't do very frequently, then they emphasize on proper handing over of patient by the anesthetist into the to the person who is managing the post-operative area. There should be proper handover. How much insulin to be given, what fluids should be given, what are the telltale signs, what all to be monitored, what all complications can occur to the patient, for example, hypoglycemia, hyperglycemia, electrolyte imbalance. So these are the red flags that they had raised. So it's a very good article that you should be reading about. So just another question, you know what is Whipple's triad? You have heard of Whipple's triad?
Yes, ma'am. It is seen in hypoglycemia patient. Patient will have symptoms of hypoglycemia and blood glucose levels less than 40 milligram per deciliter, which will recover after infusion of glucose containing food.
Okay. So I think Dr. Neha will be summarizing the case presentation.
Good evening, ma'am.
Good evening.
Thank you. It was such a detailed and exhaustive discussion. I guess it makes things easy for our residents. And good, Vijay, you answered all the questions quite well. I'll just share my screen. Is it visible?
Yeah.
Okay, so already these things have been discussed. So just let me summarize them. Now, the diagnostic criteria for diabetes, as we have already discussed. 1 minute. The fasting blood sugar of more than 110 milligrams per deciliter, or a plasma sugar of more than 126 milligram per deciliter on 2 or more occasions, or a random blood sugar sample of more than 180 or plasma sample of more than 200, or glucose or a glucose tolerance test producing results in diabetic range, that is a blood sugar of more than 200 milligrams per deciliter. Any of these criteria, if they are fulfilled, a diagnosis of diabetes can be made. Now, just an enumeration of the complications. The acute complication, as we know, is diabetic ketoacidosis seen in type 1 diabetes, non-ketotic hyperosmolar hypoglycemic coma in type 2 diabetics, and hypoglycemia. Chronic complications can be divided as macro and microangiopathies. Macroangiopathies would be CAD, cardiomyopathy, your peripheral vascular disease, CVA. Microangiopathy can be in the form of nephropathy or retinopathy. Neuropathy could be peripheral or autonomic. Then from our airway point of view, stiff joint syndrome is very important. And lastly, diabetic scleroderma. Now, what are the anesthetic considerations in a patient with known diabetes? We could be dividing them into patient-related problems, disease-related problems, or surgery and anesthesia-related problems. In patient-related problems, one needs to know the presence of other comorbidities. Obesity is commonly associated in type 2 diabetes mellitus. Since these patients are prone to infections, so any presence of concurrent infections needs to be ruled out. And lastly, the glycemic control of the patient, which is decided by the compliance to treatment. Now, the disease-related problems, almost every system of the body is affected by diabetes. We begin with the cardiovascular system. The primary pathology is premature atheroma formation, which leads to an increased incidence of hypertension and CAD. Silent MIs are very common in diabetics. There's a decreased threshold for arrhythmias. In patients with autonomic dysfunction, there could be sudden hypotension on induction, and there's a poor response to atropine and beta blockers. Then there could be diabetic cardiomyopathy and sudden death. In nervous system, there's increased incidence of CVAs. In peripheral neuropathy, there's a high risk of nerve injuries, so care has to be taken during patient positioning and transport. The local anesthetic requirement is decreased in neuraxial blocks as well as your nerve blocks. One needs to avoid epinephrine containing local anesthetic solutions to avoid ischemic injury to the nerves. Coming on to autonomic neuropathy, the patients could present with postural hypotension. Gastroparesis is common in these patients, thus making them more prone to aspiration. So aspiration prophylaxis and post-op nausea vomiting prophylaxis is important. There could be hypoglycemic unawareness, and because of urinary stasis, UTIs are quite common in them. In respiratory system, there's decreased ventilatory response to hypoxia and hypercapnia. There's increased risk of respiratory tract infections. The sensitivity to ventilatory depressant effect of drugs is highly increased. FVC and FEV1 could be decreased, and there's a reduced level of 2,3-DPG, leading to decreased oxygen release to the tissues. In airway, as has been discussed, stiff joint syndrome needs to be ruled out by doing the prayer sign and the palm print test. In case these tests are positive, so that indicates there might be a restriction in the cervical spine and atlanto-occipital joint movement, leading to an anticipated difficult laryngoscopy and intubation. In renal system, UTIs are very commonest post-op perioperative complication in these patients. There are high chances of patients going into ARF. It could be due to renal, pre-renal, or post-renal reasons. Then proliferative retinopathy is common in chronic uncontrolled cases, which increases the risk of vitreous hemorrhage on laryngoscopy and intubation. These patients are prone to infections, so there will be poor wound healing, trophic ulcers, more chances of them of going into sepsis. Acute complications, as we know, are always associated, and there's increased risk of going into intraoperative hypothermia. Coming on to surgery and anesthesia related problems, there's a stress response to surgery and anesthesia. One needs to prevent the acute complications. Preoperative estimation of end organ damage is very important. There has to be a greater concern for aseptic precautions. High chances of aspiration are there, so aspiration prophylaxis is mandatory. One needs to take care of the medical legal aspects of regional anesthesia. And lastly, fluid and electrolyte balance has to be appropriately managed. Thus, intensive monitoring is mandatory. Now, what are the factors which influence the perioperative management in these patients? As ma'am had already discussed, one needs to determine the type of diabetes and how is it being managed, whether it's managed on diet alone, on OHS or insulin. One needs to ascertain the level of glycemic control of the patient. All the medications need to be reviewed. One needs to consider the presence of chronic complications and end organ damage, and specifically presence of autonomic dysfunction. Nature of surgery is very important in deciding what perioperative glycemic control regime we would be using. So whether the surgery is elective or emergency, like how much time is available for achieving the target blood sugar, and then whether the surgery is major or minor. And lastly, one needs to identify the patients who require a post-op ICU management. Now, the classification of surgeries into minor, intermediate, and major depends mainly on duration and the duration of post-op fasting. The surgeries which last about half an hour, like your endoscopies and cystoscopies, are considered as minor procedures. Intermediate ones are those lasting up to 3 hours, like your cholecystectomy, hysterectomy. And major surgeries are where the body cavities are entered, which are lasting more than 3 hours, for example, are resection and anastomosis. Now, how do we decide like what glycemic control the patient is in? So how do you define an excellent glycemic control? A fasting blood sugar of less than 110 milligram per deciliter and an HbA1c of less than 6.5% is known as an excellent glycemic control. And in contrast, a poor control is if the fasting blood sugar is more than 140 or your HbA1c levels are more than 8.5. Now, how does diabetes affect the pharmacology of our anesthetic agents? Starting with propofol, especially when given as infusion, the lipid loading leads to an impairment of metabolism. Etomidate, it decreases the adrenal steroidogenesis, thus decreasing the glycemic response to surgery. Ketamine, it may cause significant hyperglycemia. Midazolam, if given in high doses or given as infusion, can decrease the glycemic response to surgery. Alpha-2 adrenergic agonists like clonidine and dexmedetomidine, they also improve the glycemic control. Opioids, if given in high dose, offer hemodynamic, metabolic, and hormonal stability. Dexamethasone, as we know, steroids, they tend to increase the blood sugar levels. Now, what are the anesthetic management goals in these patients? The first and foremost is to maintain the perioperative glycemic control of the patient. Then one needs to avoid further deterioration of pre-existing end organ damage. It needs to be estimated before, and then further deterioration needs to be avoided. And finally, to shift the patient back to his preoperative glycemic control regime as soon as possible. This is a systematic way in which we go about the pre-op evaluation of the patient to assess the blood sugar control. All this has been discussed already. One needs to take a history, whether the patient has had any previous hospitalizations, how is the compliance with the drugs, any hypo or hyperglycemic episodes. From investigations point of view, blood sugar fasting, PP, and HbA1c is needed. For nephropathy, any history of periorbital swelling, recurrent UTIs, decreased urine output, or hypertension is important. Investigations, urine routine microscopy to exclude albuminuria and UTI, and your renal function tests. For cardiac status, history of angina and MI needs to be taken, or any history of swelling of feet, exercise intolerance, or dyspnea on exertion. One can be ordering a 12-lead ECG, chest X-ray, and 2D echo. For peripheral vascular disease, history of any intermittent claudication, blanching of feet, any non-healing ulcers needs to be taken. In retinopathy, whether the patient has any history of any visual disturbances. Fundus examination is mandatory if the patient gives such a history. Then coming on to autonomic neuropathy, patient would give a history of early satiety, abdominal bloating, anhidrosis, impotence, or orthostatic syncope. Autonomic function tests need to be done in such a patient. To assess the metabolic and electrolyte control of any previous starvation episodes, infections leading to any signs of BKA needs to be ruled out. One needs to go for an ABG, urinary ketones, and serum electrolytes. In airways, stiff joint syndrome needs to be ruled out. And if the prayer sign or palm print test are positive, one can order an X-ray cervical spine, AP and lateral to confirm it. How do we give the preoperative orders in these patients? These patients, they need to be placed first on the operating list. This reduces both the risk of hypoglycemia as well as starvation ketoacidosis. Since the gastric emptying in these patients is delayed because of autonomic neuropathy, there's an increased risk of regurgitation and aspiration. So prolonged fasting, preferably an overnight 12-hour fasting is recommended, along with gastric prokinetic agents and H2 blockers as pre-medicals. If the patient is on long-acting OHAs like sulfonylureas, they need to be stopped 24 hours before the surgery. Other OHAs or insulin, they can be continued till night prior to surgery. One has to omit the morning dose. And morning sample of sugar and electrolytes prior to surgery is needed. Now, the patients who are well controlled and well maintained on diet alone, there's no specific therapy which is required. During the procedure, the blood sugar should be checked hourly. If intraoperatively the blood sugar rises to more than 180 milligram per deciliter, then glucose insulin infusion should be started and should be continued post-op till they resume their meals. Following surgery, the blood sugars can be monitored for 4 to 6 hours till the patients are NPO. For patients on OHAs, one has to omit the OHA on the day of surgery. During the procedure, GI infusion has to be started if blood sugar is more than 180 milligram per deciliter, or if it's a major and prolonged and complicated surgery, or if the patient was being on more than 1 OHAs preoperatively for the treatment of his diabetes. OHAs have to be resumed once the patient resumes their normal meals. Sometimes post-operatively subcutaneous insulin may be required because of the hyperglycemia induced by the stress response of surgery and anesthesia. For the patients on insulin, maintain the usual insulin doses and diet the day before, and overnight fasting should be done. Omit the morning dose of insulin. Start GI infusion prior to induction of anesthesia. These are the principles which need to be followed, whether you follow any perioperative regime. These are the general principles. Then measure blood sugar at least hourly intraoperatively, and post-operatively continue GI infusion till the patient is capable of resuming an adequate oral intake. Now, there are many perioperative regimes which are available. Now, they have some common goals. Which are those goals? The first and foremost is to mimic the normal metabolism as closely as possible. So the aim of all these regimes is to avoid both hypoglycemia or excessive hyperglycemia, lipolysis, ketogenesis, proteolysis, and electrolyte disturbances. The target blood sugar remains 120 to 180 milligram per deciliter in all these regimes. Now, we need to give the patient both glucose as well as insulin. Why do we need to give the glucose to the patient? To meet the increased requirement of surgical stress in addition to basic caloric requirements. And insulin is given so that glucose can be utilized by the patient and the catabolic response to surgery and anesthesia is counterbalanced. So for this, any simple or error-free regimen can be followed. These are the ones which have been commonly used: the Vellore regimen, which has been discussed, modified Alberti's regime, variable rate infusions. These are all non-tight control regimes. That is, the target blood sugar in all of them is 120 to 180 milligrams per deciliter. For the tight control regime, which is recommended in pregnancies, cardiopulmonary bypass, neurological surgeries, and ICU, the target is 70 to 110 milligrams per deciliter. This is the Vellore regimen. Dr. Vijay has already discussed about it. So coming on to the post-operative period, the GI infusions should be continued till the patients can resume an adequate diet for at least 24 hours post-op. Since the first meal is a usual liquid diet or it's not a full meal, so half dose of OHA to be started with the first meal, and then the full dose of OHA can be given from second meal onwards. Sometimes hyperglycemia is detected post-operatively in patients who are not diagnosed pre-operatively. So even these patients are managed in the same way as a known diabetic would be managed. Diabetic medications requirements may be increased post-operatively, as we have discussed. So frequent blood sugar monitoring is essential in all the cases. And lastly, there are certain special considerations as far as regional anesthesia is concerned. One, it's from medico-legal point of view, it's very important to record the presence and extent of peripheral neuropathy in these patients. Strict asepsis needs to be measured because they are prone to infections. Dose requirement is reduced by 1/3. The response to atropine and vasopressors can be unpredictable, especially in patients with autonomic neuropathy. The nerve injuries are more likely, therefore careful positioning and transport of the patient should be done. Epinephrine needs to be avoided to avoid any ischemic damage to the nerves. And lastly, hypothermia should be avoided since these patients are quite prone to it. Thank you.
I can see few questions in the chat box. So we have already answered. One was regarding use of ringer lactate. Vijay, would you like to answer that? Whether ringer lactate should be used or not, and why?
Ma'am, actually, there is no absolute contraindication for using ringer lactate. We can use ringer lactate also, but there is chances that it will get converted into glucose. Lactate will get converted into glucose.
So it is better not to use. You should use normal saline as a fluid of choice, isn't it?
Yes.
And there's another one for elective surgery. What should be the cutoff of fasting blood sugar and postprandial blood sugar?
Ma'am, fasting blood sugar should be less than 120 milligram per deciliter, and postprandial is less than 140 milligram per deciliter.
I think Dr. Neha, would you like to add anything to it?
Ma'am, yes, an excellent control is a fasting blood sugar of less than 110 milligrams per deciliter and a postprandial of 140. An HbA1c of less than 6.5%. That's an excellent control.
6.5%. Yeah. I think I don't see any other question.
There's a question, ma'am. Do we need to do breast examination in this patient because of the surgery? I guess.
I mean, if it is a post-operative case and the dressing is there, then of course the case will be given to you in the pre-operative state only. Then yes, you need to examine. You have to do the local examination along with the other systemic examination.
I think that's it, ma'am.
Thank you, Vijay. Very well presented. And thank you, Dr. Neha, for that excellent summarizing of the entire topic. Thank you.
Thank you. Thank you, Vijay. Bye.
Thank you, ma'am. Thank you.
Thank you, ma'am. Thank you, ma'am, for giving your valuable time and such wonderful discussion on this topic. Diabetes is something that we deal every day, and I'm sure we'll be much more confident, not only for exam, but for their future when they'll be managing these patients. So before we move on to our next session, let's quickly have the answers of the first quiz. Which of the following statement is false about the new drug Remimazolam? So the answer is C. And for question number 2, an NVA exchange catheter is used for all except, the answer is C, elective intubation. So the result I'll be declaring in the end of all the quiz together. Okay, can we have the next quiz, please? The post pre-lunch quiz. Yeah. So we have the question here. Question 1. Vitamin K antagonists have A, slower onset and offset of action. B, fast onset and offset of action. C, slow onset and fast offset of action. Or D, fast onset and slow offset of action. Question number 2. Incorrect statement regarding neuraxial blockade is A, dermatome level of anesthesia achieved with a spinal anesthetic is often more predictable than following an epidural blockade. B, spinal anesthesia can more rapidly and consistently produce denser motor blockade than epidural anesthesia. C, local anesthetics administered during epidural anesthesia are typically more volume dependent and during spinal anesthesia are more concentration dependent. Or D, thoracic epidural anesthesia has an increased risk of urinary retention compared to lumbar epidural anesthesia when the same volume of local anesthetic is administered. So we have one announcement to be made. So the delegates can download their participation certificate. Now that it's already post-lunch, they can download it from the website, that is from the platform through which they logged into EPEC 2022, that is www.epec2022mnm.com. And for the faculty, they can download their participation certificate also from the website. And the passcode to the faculty has already been sent on their WhatsApp group, the respective groups. So you can look at the password and you can get your faculty certificate downloaded. So without wasting any further time, let's move on to our last session. And for that, I would like to invite the chairperson of the session, Dr. Umesh Kumar Badani, sir. Sir is Dean and Professor and Head of the Department at AIIMS Patna. Sir's area of interest are pain and palliative care, regional anesthesia, and medical education. To enumerate some of his numerous achievements, he has been a medical teacher for undergraduate and postgraduate students, a PG examiner, has been trainer of basic and advanced life support, reviewer in many national and international journals, and has several publications to his credit. We welcome you, sir. And I would request sir to kindly proceed with the session.
Thank you, Dr. Nitin. Am I audible? Is it okay?
Yes, sir, you're audible, sir.
Yeah. So now let us welcome Dr. Amit Kohli, who is Associate Professor of Anesthesia in Maulana Azad Medical College, New Delhi. He has got about 60 publications, of which index are 42. And he has got review articles and 5 and 3 chapters in the textbooks. He is a GC member of ISA Delhi and Delhi coordinator for ISA National Task Force of COVID. He has edited a book, Essential for COVID for Anesthesiologists, and awarded with the President's Appreciation Award and Proficiency Award 2021 by ISA National. His area of interest are critical care medicines and difficult airway management, and he is going to speak on pheochromocytoma, evaluation and management. Welcome, Dr. Amit Kohli. Please go ahead with your presentation.
Thank you, sir.
A very good evening, all of you. Though this is the last lecture of APEC, but it is a very, very important topic. To begin with, I would really like to congratulate and thanks Team APEC 2022, especially MD Kaur Madam, Dr. Neerja, and Dr. Akhilesh for giving me an opportunity this evening to interact with my students across the nation. Without taking much time, the topic allotted to me for today is important from theory exam point of view. That is the anesthetic considerations for pheochromocytoma. That is an important topic, my dear friends. And we'll be discussing many things that how to attempt this particular question, what are the considerations which you have to take care of, and what are the troubleshoots. This all we'll be discussing in coming time. To make it a little more interesting, I really want to add on a case scenario, and then we'll be taking it from there. There is a 36-year-old male who came to our operation theater
Firstly, he presented to the surgeon with a history of left lumbar pain, vomiting, sweating, and palpitations, along with hypertension. There was no history of seizure and loss of consciousness. Examination was essentially normal, except for high blood pressure. The BP was 170 by 100. The jugular venous pressure was not raised. There was no murmur. A diagnosis of pheochromocytoma was already made when the patient came to you in a PSC clinic, as he was planned for excision of the adrenal mass and therefore referred to the anesthetist for evaluation for the surgery. So the positive findings I have already highlighted with a different color. Now, why pheochromocytoma is important for anesthesiologists? I am directly quoting a statement from the Bible of Anesthesiology, that is Miller's textbook, 9th edition. These tumors are clearly important, and as previously, 25 to 50% of the hospital deaths in patients with pheochromocytoma occurred during induction of anesthesia or during operative procedures for other causes. So such a high mortality is there if it went unnoticed, means undiagnosed pheochromocytoma patient presenting for some accidental other surgery, or maybe unplanned thing if we are going ahead with the pheochromocytoma, but our planning is not important. But with the improvement in the anesthetic management in the current era, this high mortality has been grossly reduced. And that is the purpose of this talk. Wherever I take classes for PG Assembly, it's my routine to scan my university's last 10 years question papers, that why this topic is important for exam going students. Almost every third year, the question has been coming in theory exam about pheochromocytoma, specifically either in paper 3 or paper 4 of university. The question reads like, describe the anesthetic management of a 50-year-old female scheduled for excision of pheochromocytoma. Another year, again, they have asked about perioperative management of a female with pheochromocytoma under general anesthesia. Another question says that you have to enumerate the anesthetic goals and preoperative preparation of an adult patient scheduled for excision of pheochromocytoma, and all these questions are of 10 marks. Now, how does this pheochromocytoma word came into existence? Pheo means dark, chromo is color, cyte means cells, and toma means tumor. So it's a dark color cell tumor to begin with. 85% they originate within the adrenal glands, whereas 15% has extra-adrenal origin, anywhere from the base of the skull to the pelvis. And the most common site, as we have been knowing it since our MBBS days for extra-adrenal, is organ of Zuckerland, which has a very high incidence of malignancy. This is a very famous rule of 10 for pheochromocytoma. Many of your examiners, they can be asking about the rule of 10 of pheochromocytoma, and you have to mention it in your theory examination also. Now, what is that rule of 10? It has 10% extraadrenal involvement, 10% bilateral involvement, 10% may be malignant, 10% recurrent, mostly in adults, but 10% in children, and 10% it can be familial. So this is a rule of 10 of pheochromocytoma. Pheochromocytoma may be classically associated with some syndromes. These are exam-going PGs should be knowing of, that it is associated with either MEN2A or 2B, von Hippel-Lindau syndrome, and neurofibromatosis type 1. So these are the syndromes associated with pheochromocytoma. Pheochromocytoma case, the focus will be on catecholamine production, the effect of catecholamines on the body systems, the testings, the clinical presentations, and perioperative optimization and the management. So that is all important things we'll be discussing in the talk ahead. I'm not going into the details of biosynthesis and metabolism of catecholamines. From our biochemistry days, we are sure about how norepinephrine and epinephrine is produced. So this cycle, our exam-going PGs should be knowing. Now, what are the effects of catecholamines? This is from our pharmacology days. We are knowing that there are two receptors, alpha and beta receptors, which are involved. Alpha 1, we know it's responsible for vasoconstriction, whereas alpha 2 is for arterial vasodilatation and coronary vasoconstriction. Whereas our beta receptors, beta 1 is mainly to increase the heart rate and contractility, whereas beta 2 is for vasodilatation as well as bronchodilation. Epinephrine is more potent than norepinephrine in producing hyperglycemia. So with this particular line, what I'm hinting is that these patients may be into hyperglycemia. They have higher affinity for beta-2 receptors. That is important. And insulin resistance, which may reduce peripheral glucose utilization, that may lead to insulin resistance. This is something important, that not only the peripheral system or the vascular system is involved into cases of pheochromocytoma, but a prolonged history of pheochromocytoma case the patient may have an incidence of cardiomyopathies. There is a very frequent association of cardiomyopathy with pheochromocytoma. So all my residents who are listening to me today should suspect cardiomyopathy even in the absence of symptoms of catecholamine excess. Primarily, there may be symptoms of catecholamine excess, but if at all catecholamine excess is not there, then also your patient may present with cardiomyopathies. This we should be remembering. Now, what are the predominant symptoms of pheochromocytomas? That is seen in 20 to 40% cases. There are 5 Ps. What are those famous 5 Ps? Number 1, there may be increased pressure response. That is, hypertension. 90%, there's a very high incidence. Your patients may be having hypertension. 80% cases, the patient may present with headaches. That is the pain. There may be higher incidences of perspiration, palpitations, and even the pallor. The 6th P, which is there, is paroxysms. So there may be these famous 5 or 6 Ps in this, and primarily, either the hypertension or the headache is importantly there in most of the cases who present to us in a pheochromocytoma. Now, what are the signs after the symptoms? Epinephrine secreting pheochromocytomas, there is of course there is an hypertension, that too a systolic blood pressure is high. There may be tachycardias, and there may be at times decrease in diastolic pressures. Whereas if it is a norepinephrine secreting tumor, hypertension with narrow pulse pressure and even the reflex bradycardias, there may be pathognomic signs. There may be an associated orthostatic hypotension in these cases because of intravascular volume contractions and release of adrenomedullin. The patients may present with flushing and tachypneas other than these symptoms of cardiovascular symptoms. Now, how to clinch the diagnosis? Firstly, the history. History may lead you to getting a further biochemical or radiological and nuclear imagings. Biochemical investigations will be more focusing on that what all are the hormonal assays and stimulation or suppression testing which we have to do. We'll be discussing in a while. Now, as I was talking about biochemical tests done in a patient who is either a clinically diagnosed case of pheochromocytoma or suspicious case of pheochromocytoma, there are variety or battery of tests with the different sensitivities and specificities, which includes urinary catecholamines, total metanephrines, combination of urinary catecholamines and metanephrines, urinary VMA levels, whereas the plasma levels can also be done, catecholamines as well as metanephrines. As far as the sensitivity is concerned, we should be knowing that plasma metanephrines has a sensitivity of around 99%, whereas combination of urinary catecholamines and metanephrines are more specific or highest specificity of around 98% is there. This is important for all of my postgraduates. I repeat once again, the highest sensitivity is with plasma metanephrines, whereas the highest specificity is with urinary catecholamines and metanephrines combo. Now, what all stimulation or suppression testing needs to be done before taking up a case of pheochromocytoma? The important ones are clonidine suppression tests and glucagon stimulation tests. In a clonidine suppression test, it may precipitate, you have to remember it, we'll be very, very cautious while doing this test because it may precipitate hypotensive shock. Now, what finding we get in clonidine suppression testing? The important finding which we get in clonidine suppression testing is that there is no suppression of plasma norepinephrine levels with clonidine. If it is happening that there is no suppression of plasma norepinephrine levels, the diagnosis of pheochromocytoma is certain. But if it is suspicious or if it is like that, the norepinephrine levels are suppressed, it means you have to think of some other diagnosis. Similarly, glucagon stimulation tests, you have to keep it in mind, it may precipitate hypertensive crisis. And there is 3 times increase or even more than that increase in plasma norepinephrine with the glucagon in cases of pheochromocytoma. Now, what are the preoperative preparations? You have to attempt your answers also like that. After anesthetic considerations, the preoperative preparations. The objectives of preoperative care includes, this is very, very important slide, that they include arterial pressure control. This we all know, that case of pheochromocytoma, the blood pressures will be swingingly high. So you have to have the drugs available in operation theaters for arterial pressure control. Even in the preoperative settings, you have to control the BP first. And we'll be discussing how, which drugs first, which drugs later on in our coming slides. Then there is a reversal of chronic circulating volume depletion. The third is heart rate and arrhythmia controls needs to be done. Fourthly, assessment and optimization of myocardial functions. And lastly, reversal of glucose and electrolyte disturbances. If you attempt your question under these 5 headings in a preoperative care, you're likely to score good marks. Now, what are the keys to successful management? Of course, a multidisciplinary approach, which not only includes anesthesiologist, but also the surgeon, the cardiologist, and endocrinologist. Now, the first limb, that is arterial pressure control preoperatively. Preoperatively, alpha blocking is standard practice as it aims to preoperative arterial blood pressure control, and subsequent restoration of blood volumes also is achieved. That may be titrated using serial hematocrit levels. Now the question arises, this is a very favorite question of most of the examiners, that why alpha blockade first? Mostly when we are discussing about control of hypertension in other cases, there may be calcium channel blockers, there may be angiotensin 2 blockers, ARBs, or beta blockers per se. But specifically in cases of pheochromocytoma, firstly we want to control the blood pressure by alpha blockade. I would like to ask the students sitting here that why alpha blockade first? I would really appreciate if the students listening to me today can reply to this question in a chat box, that why specifically in pheochromocytoma we want to give alpha blockers first before giving, beta blockers. Most of few of you have responded in the chat box, right? That is there, and correctly said that if you use beta blockers, right, before achieving a good alpha blockade, it will mainly be leading to alpha stimulation, which will precipitate the hypertensive crisis, and this hypertensive crisis sometimes becomes unmanageable. That is there, and you may lose the patient, right? That is there. So you don't want an unopposed alpha stimulation, right, if you use beta blockers in the first place. Alpha blockers, I still emphasize, used in hypertensive patients. Very few subset of pheochromo patients can be normotensive also, but rarely. And those patients, yes, you can give calcium channel blockers as you give in other cases. Now, first line of management, I re-emphasize, is alpha blockers. That may be the non-selective ones or the selective ones, which may include, phenoxybenzamine as a non-selective alpha blocker. And then the selective or the reversible ones are prazosin, tirazosin, and doxazosin. Some of them are available in our country, but most of them are not available in our country, right? That is there. The non-competitive both alpha-1 and alpha-2 blocker is phenoxybenzamine. It is a long-acting agent. Non-competitive nature allows it to maintain its alpha blockade during a catecholamine surge. It has a long half-life that makes it easy for the patients to be more compliant because of the dosage schedules. But yes, an adequate blood pressure control ideally has to be done at least 1 to 2 weeks before you're planning to take up your patient for surgery or excision of the tumor. However, it should be stopped 24 to 48 hours before surgery due to its long half-life, right? Otherwise, at the induction of anesthesia, you may face a precipitous fall in the blood pressure. So it should be stopped 24 hours before surgery, but yes, it provides a very good control of blood pressure preoperatively. We all should be knowing the dose of phenoxybenzamine, that's 10 milligrams 2 times a day per orally, which may be increased to 10 milligrams per day, right, until the normalization of blood pressure and orthostatic hypotension occurs. But to balance both the things. Hence, it requires daily blood pressure monitoring in supine as well as standing position. So if you are trying to control the blood pressure of your patients who are to be posted for pheochromocytoma preoperatively, what I want to emphasize one thing is, always admit your patient in the hospital. Never ever attempt to achieve normalization of the blood pressure in pheochromocytoma case on OPD basis. Admit your patient because you need to daily monitor the patient's blood pressure because there is a very high incidence of orthostatic hypotension with these drugs. So both in the standing and the supine position, you have to take the blood pressure of the patient at least once a day. And that can happen only in the hospital. As phenoxybenzamine is a non-selective alpha blocker, so alpha-2 blocker results in reflex tachycardias. Now there comes the role of your beta blocker, right, to control that reflex tachycardia, not for per se the blood pressure control. Per se the blood pressure control, yes, alpha blockers like phenoxybenzamine, but yes, the reflex tachycardia caused by the alpha blocker, this thing that can be controlled by the beta blocker. I re-emphasize, beta blocker should be started only and only once you have blocked the alpha system. Otherwise, there will be catastrophes. Now, what are the specific alpha blockers? So specific alpha-1 blockers include prazosin, doxazosin, and terazosin. Prazosin is available at most of the places. The advantages are that short duration of action, yes, we all know, and there is some degree of avoidance of reflex tachycardia. Hence, there is no need of preoperatively beta blocker if you're starting this selective or the specific alpha-1 blocker agent as compared to phenoxybenzamine. But disadvantages, it has a shorter half-life, so more frequent dosaging is required, and that is there, and patient compliance may be a concern. As I already told you, calcium channel blockers are given specifically in patients who are already normotensive, can be used as a monotherapy in normotensive patients, can also be used along with the alpha blockers if the blood pressure is not controlled. So calcium channel blockers versus alpha blockers, which one? Yes, calcium channel blockers has an advantage that there is no orthostatic hypotension, lessens the severity of catecholamine-induced vasospasms, so useful in catecholamine-induced myocarditis cases. Perioperative hypotension may still respond to the pressor agents if you're using calcium channel blockers. So it's one of the choices these days of many of the physicians or endocrinologists. Reversal of the chronic circulating volume depletion was a second limb of controlling, this is there. That's why I emphasized that there is a serial hematocrits give a guide of effectiveness of volume expansion. Usually a 5 to 10% fall in the hematocrit is seen in a well-prepared patients. If a patient is well-prepared with the use of an alpha blockers, right, then you may expect almost 10% fall in the hematocrit in pre-operative period. Hence, residents who are listening to me today should see serial hematocrits and PAC for effective alpha blockade effect, right? That is there. That may be a guide whether your alpha blockade effect is effective or not. Third limb was heart rate and arrhythmia control. As I already told you, there may be tachyarrhythmias, which may be there, maybe due to epinephrine releasing tumors or maybe secondary to your alpha blockers. And this is specifically those non-selective ones. So selective beta blockers are preferred, as we already discussed that, and doses are to be titrated with a heart rate goal of 60 to 80 per minute. But beta blockers may be dangerous in a patient with catecholamine-related cardiomyopathies, hence can lead to hypotension, bradycardia, and even arrest. So you have to rule out the cardiomyopathy part before starting with a beta blocker. The fourth component was assessment and optimization of myocardial functions, right? So ECG can be done, and even echocardiography is must in these patients because you have to notify the degree of diastolic dysfunctions. Left ventricular systolic dysfunctions can also occur in 10% of cases. Various forms of cardiomyopathies can be there, specifically the HOCM can be seen in chronic hypertension cases. So you have to do an echocardiography to evaluate in presence of degree of cardiomyopathy, and may also be useful for determining improvement after antihypertensive therapies has been titrated. So in preoperative echocardiograph is must. Residents must ask for ECG and 2D echo in PAC whenever they are doing the PAC of a pheochromocytoma case. Last component was reversal of glucose and electrolyte disbalances. As I already mentioned in the beginning, the patient may have hyperglycemias that may be due to various reasons, and there may be electrolyte disturbances can also occur. Hypercalcemias can occur as part of neuroendocrine tumor, and that may be there as a part of a syndrome. So you have to measure the things and control the things appropriately preoperatively. Hence, hyperglycemia needs to be treated preoperatively. Now, my dear students, we have optimized our patients as per the 5 headings we have discussed. Now, is still something needs to be done? Our patient is well prepared for the surgery. Can we relax now? No, it's just the half battle won. Adequate preparation in the operation theater when you are taking up a case of pheochromocytoma, understanding what can happen during induction, during the maintenance, and during various steps of the surgery is very, very important, and you have to be very well pre-prepared before that. Now, there are various ways of assessing the adequate optimization. The famous Roizen criteria is there. You can all read from your textbooks what is the Roizen criteria for adequacy of alpha blockage. Not going into the detail. Now, what should be your preoperative orders in such cases? Right, that is there. Patient should be accepted for anesthesia under a high-risk consent. You should always ask for arrangement of a bed ventilator in post-operative period. Arrange blood and blood products adequately. Your patients may likely to bleed humongously during surgery. Short-acting selective alpha-1 blockers should be administered on the morning of surgery. If your patient was on phenoxybenzamine, I already told you it should be stopped 24 hours before surgery. You can continue with the beta blockers if your patient is on beta blockers. Long-acting benzodiazepines like diazepam can be given to allay the anxiety. H2 receptor blocker antagonists like ranitidine can be given, but you have to avoid metoclopramide as it may precipitate hypertensive crisis. Ensure the patient, counsel them to relieve their apprehensions, because any amount of anxiety in the patients, that any amount of anxiety in the patients may add on to more release of catecholamines and more hypertensive surge. So you have to counsel the patients preoperatively. Fresh CBC and serum electrolytes on morning of surgery is needed. And then shift the patient in OT on trolley to minimize any alterations in the hemodynamics. Never let the patient walk into the operation theaters. Now, you have come on an important day, that is the day of surgery. The battle for residents starts here. You need to have a careful planning, meticulous technique, and close communication with the surgeons. It is very important, because surgeons may be dealing with the tumor. There may be certain hemodynamic alterations, minute-to-minute changes, occur. That is particularly there. Now, what are intraoperative management? What are the risk factors, for intraoperative hemodynamic instability in such cases? Right, that is there. There may be high pre-induction plasma norepinephrine levels, large tumor size, pre-induction MAP more than 100. In these patients are much have to have a stormy intraoperative period. These are the risk factors. Just chosen anesthetic techniques should avoid drug-induced catecholamine release. Avoid catecholamine release induced by anesthetic and surgical maneuvers, minimize hemodynamic responses to tumor handling, and treat episodes of hypotension also, particularly after the tumor devascularization. So, which one, open versus lap? This is always a point of debate for all surgeries for anesthesiologists. That open surgery certainly leads to high catecholamine release because there is a large handling of the tumor by the surgeons, whereas laparoscopic surgery is a gold standard, less pain, early ambulation, but another problem with that particularly is the positioning and the gas insufflation, which may, lead to hypertensive crisis. So you have to weigh the risk versus benefit and discuss it with your surgeon. As I already told you, pre-induction, shift the patient on trolley, ASS standard 2 monitors, large bore IV cannulas, start with ringolactate. Arterial line has to be there in situ under LA before induction, right? That is the part of the planning, that before induction, you have to secure an IV line because at the time of induction and intubation, you may have hemodynamic perturbations. All infusions lines are ready to fire. They should be, well labeled. That is there. Check the consent, written informed consent, and it is always good if you place a thoracic epidural before induction, right? If your patient's coagulation profile is normal. General anesthesia, with or without epidural, is the technique of choice, right? That is particularly there. There are various advantages. We all know of epidural putting in this particular case, right? Anesthesia induction is a very critical time for anesthetist, right? We use IV midazolam, opioids in a larger doses. Induction can be done with etomidate. Etomidate is a preferred agent, right, in these scenarios, or maybe titrated doses of propofol, because etomidate provides a good cardiovascular stability, right, that is there. Agents which leads to histamine release like morphine should be avoided in these cases. So all residents, fentanyl should be preferred over, morphine. Regarding the induction agent, ketamine should be avoided because of its sympathomimetic effects. Muscle relaxation, yes, vecuronium is a very cardiostable, you should be using that. But at the same time, you should be avoiding succinylcholine because increased fasciculation lead to high catecholamine levels. Also, atracurium needs to be avoided because of its histamine releasing properties. Prefer video laryngoscope over a direct laryngoscope. That causes less of stimulus while doing laryngoscopy. Then important is to attenuation of the pressure response to laryngoscopy. That is there. You can use fentanyl, IV lignocaine, esmolol infusions can be started, infusion of nitroglycerine can be started, and prefer video laryngoscope that I already told you. Regarding inhalational agents, sevoflurane provides a very good hemodynamic stability. That is the preferred inhalation these days in cases of pseudocytoma, whereas you should avoid halodane because we all know it has an arrhythmogenic and sensitization properties, whereas desflurane should also be avoided because it causes sympathetic stimulation leading to tachycardias. Intubation versus LMA. Yes, intubation is a definitive airway. Longer period is there. Surgery period is longer. Your patient may needs to be shifted to, ICUs. So most of the anesthesiologists still they prefer putting the patient on endotracheal tube and mechanical ventilation. As a part of ASA2 monitoring, we all know that it has to be put apart from that. Intra-arterial monitoring, beat-to-beat monitoring is important. If you have access to cardiac output monitor, use cardiac output monitors like Vigilio. CVC insertion has a limited role, but yes, you can be giving certain drugs through CVC. Swan-Ganz catheter is not really recommended these days, right? That is particularly there. You should avoid it. And if at all you have to use the invasive thing, the TEE is the answer. There is no evidence base to support the use of cardiac output monitoring in pheochromocytoma surgery. But yes, with the clinical experience, yet if you have an access to the monitor, you can be using it, right? That is there. In cases of cardiomyopathy, if certainly diagnosed preoperatively, this cardiac output monitoring has no value. In cases of this thing, this is there. Intraoperatively, glucose monitoring is very, very important. Right, that is there. This is a intraoperative chart made by my anesthesiology resident in one of the pheochromocytoma cases, which we were getting it done. Right, as you can very well see in this particularly that there is a sudden increase in the systolic blood pressure of the patient, along with sudden increase in the heart rate, which is going in the range of 200. Right, that is particularly there with a heart rate of somewhere around 120, 130. What will you do now? Right, so yes, intraoperative hypertension is very common, right? That is there, and you have to manage it very, very rapidly or spontaneously. It is managed with analgesia and adequate anesthetic depth. Tumor manipulation, if it is being done, so hypertensive crisis can be precipitated because of increased catecholamines. You have to start the infusions of NTG and sodium nitroprusside. You may have to counter it with the beta blocker infusions of esmolol or levetolol, right? That is there. Calcium channel blockers can be started, and in addition to that, these days most of the anesthesiologists are very happy starting magnesium sulfate infusions also to inhibit catecholamine release in addition to your NTG or SNP. That is there. As we all know, magnesium sulfate is a wonderful drug, right? That is there. It's a direct vasodilator and can lead to decrease in the blood pressure of the patient. We should be knowing the loading dose is 40 to 60 mg per kg, followed by 1 to 2 grams per hour of the important dose. SNP and nitroglycerin are important drugs. You should be knowing, all residents should be knowing by heart what are the doses and how to use them. Beta blockers, both esmolol and levetolol can be used, right? If you want an immediate onset, then esmolol is preferred over levetolol. That is there, right? Calcium channel blockers and antiarrhythmics can also be used, right? That is there. Another important, wonderful drug is dexmedetomidine, which is a centrally acting selective alpha-2 blocker. We all know that. In addition to its sedative and analgesic properties, its central sympatholytic effects can result in substantial reduction in norepinephrine levels. Hence, it is a very promising and attractive agent in pheochromocytoma surgery. So, two of my favorite drugs in a present era, dexmedetomidine and magnesium sulfate. Now, once your surgeon is through with the tumor resection, this kind of chart your resident may show you that there is a sudden fall in systolic blood pressure. Now, what needs to be done now? Yes, there's a hypotension happening, right? That's refractory hypotension following ligation of the venous drainage of the tumor can occur. There's a sudden drop in the catecholamine levels, right? That is there, and that's maybe a precipitating factor for this particular event. How will you treat it? A preventive measure is volume loading before tumor vein ligation. When you're suggesting that's the importance of communication with the surgeon, that tumor vein ligation, when the surgeon is doing, you tell your surgeon to inform you at least 15 to 20 minutes before, and you do good volume preloading. That is there. If volume loading is ineffective, norepinephrine can be started. Your infusion of noradrenaline should be in place, right? Since beginning. Vasopressin is also effective in refractory cases. Intraoperatively, TEE has a role for assessing ventricular filling. And if your patient is not responding to that, in cases specifically in bilateral adrenalectomy cases, starting a steroid infusion can be taken care of. Pain management is a very important component, specifically if your patient is subjected to open tumor resections, multimodal analgesia. I re-emphasize the role of epidural blocks, right? USG guided TAP blocks and erector spinae blocks or the quadratus lumborum type 2 blocks can take a place if your epidural you can't be putting for some reasons. However, further studies are needed for the last 2 blocks. Immediate post-operative management, persistent hemodynamic instability can be there. Your patient mostly goes into ICU for post-operative ventilation. If there is a persistent hypotension, you can suspect a surgical intraoperative bleeding or a post-operative continuous bleeding. Inadequate fluid resuscitation can be done, can be thought of, and residual anesthetic-induced vasodilatation. These are the differentials. If your patient is drowsy or not responsive, you can suspect hyponatremia and hypoglycemia. So check for sodium and sugar levels in a post-operative period. If your patient is having a persistent hypertension in post-operative period, then fluid overload may be a reason. Return of autonomic reflexes can be reason. Residual tumor recurrence can also be one of the reasons. Right? There are specific concerns. If your pregnant patient comes with pheochromocytoma, it has a grave prognosis. Mortality of around 50% can be there. Diagnosis with 24-hour urine collections and MRI has to be done. Phenoxybenzamine plus beta blockers preoperatively 2 to 3 weeks prior to then, and prefer to do laparoscopic resections in second trimester. It may happen, as I discussed in the beginning, that the pheochromocytoma patients coming for a non-pheochromocytoma surgeries, elective surgery should be postponed and elective resection of pheochromocytoma should be planned before any non-pheo elective surgeries. However, in cases of emergency surgeries, it should be tried to be optimized as far as possible as the time permits. Coming to the last part of my talk, what are the take-homes from my talk? Yes, pheochromocytoma presents significant challenge to anesthesiologists. Significant risk for major, adverse cardiac complications in perioperative period can occur. But yes, a proper preoperative stabilization, optimization can reduce large risk of cardiac complications in intraoperative and postoperative period. Key to success is close communication with your surgeon, cardiologist, and endocrinologist. Don't hesitate to talk to them. Successful management requires meticulous preoperative assessment, optimization, and further assessment of optimization, right? I reread the sentence, meticulous preoperative assessment and optimization. This is we do in most of the cases, but yes, further assessment of your optimization. That is in addition in the pheochromocytoma cases. With this, I really wish to say my students, don't panic in your exams. You know more than anybody else. Hold on your nerves. In theory exam, structure your MCQ or your answers before you start writing your answers. In practical examinations, structure your answer in your mind before you utter your word in front of your examination. Take your time, buy your time. You will really, really pass through flying colors. I sincerely wish to thank my younger colleagues, Dr. Deepak, Arshi, and Dr. Abhijit, who has given me inputs for this presentation. That is there. Any questions are mostly welcomed. Thank you.
Thank you, Dr. Kohli, for your nice presentation. And really, it is one of these surgery where anesthetists are more important than basically surgeons. For surgeons, it is just removal of a tumor like any other tumor. But for anesthesiologist, it's like walking on a sword. One side, this is a hypertension, one side, and in about 3 of my cases out of 6 here, we have got hypoglycemia in post-operative period, which was almost persistent for more than 3-4 days. So we have to always watch for hypoglycemia in post-operative period. As you already told, that in pre-operative period, there is a tendency of hyperglycemia. And once the tumor is removed, since body is exposed to a high level of things, and the other things which is anti to the insulin is removed, and so there are it takes some time for the glycemia to come a normal level, and there are episodes of hypoglycememia. This only want to add, and when we make 3 teams. One is the main anesthesiologist in the center of the patient, and one team left side, one team right side. In one hand the hypotensive drugs, in another hand the hypertensive drugs, and with coordination with the surgeons, we can have this coordination of going ahead with this surgery. Thank you, the organizer, for giving me the opportunity, and we must congratulate, because this was the last lecture of the whole organization which I was done, and all are very much subjects for congratulation from the all faculties, chairpersons, and I am sure that our students are much benefited from this endeavor of the organizers, sir. Now over to you, Dr. Nitin Chaudhary. Thank you very much.
Thank you, sir. Thank you, sir. Do you have something to add? Okay.
Yeah, thank you very much, Madani sir, for your inputs. That one infusion, category of infusion on the right, other category on the left. There are various ways the people are doing it. Yes, and there should be very proper labeling of the infusions. That is very important. Accidentally, you can't afford to put your foot on the accelerator if you have to put it on the brakes. You know, so that has to be very well taken care of. Here I take an opportunity to thank all the organizing team of APEC. Madam, once again, it was a grand, successful event under leadership, along with Dr. Akhilesh. Dr. Nitin is in front of screen. A promising future as a faculty in specialty of anesthesiology. So I really, really want to thank you all once again and say my best wishes to all my students who are listening to me this evening. Thank you.
Thank you, sir. Thank you, sir. Thank you for your wonderful lecture, very enlightening, and so many clinical pearls for the students. Thank you so much.
Thank you. Thank you, Dr. Nitin.
So, yeah. So we'll first have the answers to our second MCQ. The first was vitamin K antagonists have. The answer is A, slow onset and offset of action. And question 2 was incorrect statement regarding urexil blockade. The answer is D. Thoracic epidural anesthesia has an increased risk of urinary retention compared to lumbar epidural anesthesia when the same volume of local anesthetic is administered. And we have the winners of both the quiz 1 and quiz 2. In quiz 1, I would like to congratulate Shravan Sri Kumar from Madan Mohan Malviya Hospital. And in quiz 2, we have Achita from RML Hospital, Dr. Achita from RML Hospital. Congratulations to both the winners. Before we move on to the last pop-up, this is announcement that the last quiz is open now. You will be getting the link very soon. So we want you to quickly fill up the answers so that the winner can be declared towards the end of the pop-up. Thank you so much. Let's have the next pop-up. Yeah. So for this, I would like to invite Dr. Ruchi Ori. She's a senior resident in ABPIMS and Dr. RML Hospital with us areas of special interest as difficult airway, obstetric and pediatric anesthesia. We welcome you.
Good evening, everyone. First of all, I would like to convey my sincere gratitude and thanks to the HOD Dr. MD Kaur ma'am and APEC team to giving me the opportunity to deliver a talk in APEC 22. Today I am going to talk about Bromage scale, which is a very important topic for exam point of view. So we start with the definition. Bromage scale is the tool for the measurement of the intensity of motor blockade. The intensity of motor block is assessed by the patient's ability to move their lower extremities. Why it is important to assess motor block? To determine the amount of motor function, to ensure the patient is safe to ambulate, and to detect the onset of complications like epidural hematoma or abscess formation. Bromage scale was originally developed by Philip Reques Bromage in 1965 to assess the recovery and regression of motor block with sensory block to S5 following administration of local anesthetic. In his score, he gave 4 points, in which grade 1 means complete paralysis, means patient is unable to move feet or knees. In grade 2, there is almost a complete block, means patient is able to move feet only. In grade 3, patient is just able to move knees. And in grade 4, patient experiences no motor blockade, means there is a full flexion of knees and feet. Several modifications of Bromage scale have been done. Modified Bromage scale was described by Logan and Wildsmith for the onset and assessment of motor block. Modified Bromage scale was categorized in 0, 1, 2 and 3 grades. In grade 0, patient experienced no motor block. means patient is able to do free movement of legs and feet. In grade 1, there is a partial block, means patient is just able to flex knees with free movement of feet. In grade 2, there is almost a complete block, means patient is unable to flex knees but free movement of feet. And in grade 3, there is a complete paralysis, means patient is not able to move legs or feet. Now, how to assess motor block? First of all, explain the procedure and purpose to patient. Ask the patient to flex their knees and ankles. The degree of motor block on both the left and right legs should be assessed separately. For children and disabled persons who are unable to follow the commands, try to elicit movements by tickling toes, gentle knee or hip flexion. For better understanding of modified Bromage scale, we made a video in which Dr. Siddharth and Dr. Dheeraj will demonstrate how to assess motor block in a stepwise manner.
Here we are demonstrating the modified Bromage scale in this patient. In grade 0, there is no motor blockade. Patient is able to raise extended leg, move his knee and move his feet. In grade 1, there is inability to raise extended leg, but the patient is able to move his knee and the patient is able to move his feet. In grade 2, there is inability to raise extended leg and patient is not able to move his knee, but patient is able to move his feet. In grade 3, there is complete motor blockage. Patient is not able to raise extended leg, patient is not able to move his knee, and patient is not able to move his feet.
Thank you, Dr. Siddharth and Dr. Dheeraj. Now coming to the next slide, which shows limitations of Bromage and modified Bromage scale in case of labor analgesia. Because it was designed to measure surgical block, while in labor analgesia, we give local anesthetic in dilute form and we need to achieve sensory blockade only. So, to overcome the limitations, Breen et al. Used a 6-point scale for the assessment of motor block in an ambulatory patients who received epidural analgesia for labor, in which 2 categories were added to modified Bromage scale. The 2 new categories were detectable weakness of hip flexion while supine and able to perform partial knee bend while standing. Now Dr. Priyanka and Dr. Dheeraj will demonstrate 6-point motor assessment scale given by Breen et al.
Demonstrating modified Bromage scale as described by Breen et al. It has 6 scores. Score 6 is patient is able to perform partial knee bend. Score 5, no detectable weakness at hip flexion while supine. Score 4, there is detectable weakness at the hip flexion. We can see that patient is not able to move his leg. Score 3rd, it is almost complete block. The patient is able to move his knees and feet. Score 2 is patient is able to move his feet. And score 1 is complete block. The patient is not able to move even his feet.
Now coming to the last slide of questions and answers which may be asked by the examiner in Viva session. Question number 1 is, what is the sequence of nerve block? The block occurs in a stepwise sequence with autonomic impulses blocked first, then sensory in which temperature, cold before heat, then pain, then touch, after that deep pressure and in last proprioception, and finally motor impulses will be blocked. Question number 2 is factors affecting epidural block height. There are variety of factors which are related to epidural block height, in which first is drug-related factors are volume and dose of local anesthetic are the most important drug-related factors. 1 to 2 ml of solution should be injected per segment to be blocked. Additives such as bicarbonate and opioids influence onset, quality and duration of analgesia and anesthesia, but these do not affect spread. Patient-related factors are age and pregnancy. Elderly patients require less volume of drug to achieve block height due to decreased compliance of epidural space and increased sensitivity of nerves in elderly. And in pregnant women, there is engorgement of epidural veins due to increased abdominal pressure. Procedure-related factor is level of injection. Question number 3 is, what does a doctor or resident assess when a patient is having epidural? Position of epidural catheter, sensory block and motor block should be assessed by a doctor or resident intermittently. Question number 4 is, how many hours does local anesthetic drug affect wear off and how? Drug spread and removed via diffusion, vascular transport and by leakage, and duration will be depend upon the local anesthetic which we use. Like in lignocaine, drug effect lasts up to 90 minutes and for bupivacaine it is up to 2 to 3 hours. Thank you all for your patient listening.
So this comes to the end of EPIC. It was a 7-day program and it won't be possible without the support of Dr. and Dr. Nidya ma'am. So I want to bring Dr. M.D. Kaur to please speak.
Once again, when we conclude EPIC 2022, I'm here in front of you to thank and introduce my EPIC 22 core team to all of you, so that the applause that all is coming towards us is because of the entire team. First of all, I introduce my right hand, Dr. Neerja Banerjee, who has done exemplary role. You know, she has got an exemplary role in designing the curriculum and in checking each and every, the presentation and the drug vivas and equipment slides, whatever contribution from Dr. RML Hospital is there, she has left no stone unturned to make it the better and then the best and the very best. Let me introduce Dr. Neerja. Please kindly for a few words from Dr. Neerja.
Thank you so much, ma'am. Thank you for your kind words, ma'am. It has been a really enriching experience, a wonderful journey to be here. We started it last year. Last year was the first time, and this time it's been like a real pleasure to be associated with the postgraduates. Thanks a lot to all the faculty who have contributed to making this a success. Without your participation, without your expert inputs, we wouldn't have been where we are. And the delegates and the postgraduates, you are the ones who have made this program possible. Thanks to all, thanks to the whole team. It's a teamwork. We have all worked together. Ma'am has been like really kind in praising a lot. Thanks a lot, ma'am. And
you deserve all the praise. Leadership, a leader is always incomplete without the team. And we have the rest of the team. I'll be introducing to them also, though they are also very well known to you all. And my only thing is, let's encourage. When we are working so hard, I would request that the entire faculties from outside to kindly encourage the postgraduate students to attend this program next time also, because we will be doing it in, EPIC 2023 also. Dates and all will be announcing later on, and probably we'll be doing it in the early February 2023. And by the grace of God, if all goes, everything goes all right, we'll be bringing around EPIC 2023 also. And then again, another pivotal person for the planning and execution of the program, Dr. Akhilesh Gupta. He is our professor here in RML. Dr. Akhilesh, kindly say a few words to all the people who are listening to you.
Thank you, ma'am, and definitely it would be possible without your leadership, and we could conceptualize the whole program only because of you. And the participants, the delegates, the postgraduates, all have very enthusiastic approach towards it. Our postgraduates and all the postgraduates who attended this program. So all the best to all the postgraduates. Thanks.
Dr. Devang and Dr. Nitin, I must say that, at every level you need support for the technical assistance, for carrying out the things, for doing the fine tuning with everyone. We had Dr. Devang and Dr. Nitin with us all these days. So Dr. Devang, kindly say a few words.
Thank you, ma'am. Thank you for giving us this opportunity.
I hope I didn't screw you much.
No, ma'am, not at all. No, ma'am, not at all. It was a pleasure, ma'am. And it was a great learning experience for all of us. It was a great opportunity. Thank you, ma'am.
Dr. Nitin.
Thank you, ma'am. Thank you, ma'am. Thank you for giving us this opportunity. It helps us to grow and learn further. And I hope we continue to be part of this EPIC. Thank you so much, ma'am.
Right. Thank you, Dr. Nitin. And now the two ladies, Dr. Jyoti Singh and Dr. Namita Saraswat. Both are associate professors in the department, anesthesia department of RML, AVVIMS and Dr. RML Hospital. I have no words to appreciate and tell you that these are the two ladies behind the success of this program. They have worked day in and day out, and I have all my praise, and words fail me when I have to tell something about them. Kindly say a few words, Dr. Jyoti.
Thank you, ma'am. Thank you so much for giving this opportunity, ma'am. And I really love working with the EPIC team. Thank you so much, ma'am.
Right.
And it was a great experience, ma'am.
Thank you, ma'am. And because of your guidance also, we are able to execute this with so efficiently. And I would like to take all the gratitude to you so that you have made such an extensive, comprehensive curriculum for the countries. Those they can get benefit all over India because of this curriculum. And I'm sure they might also be in all praise and ready for the exam with this curriculum. Thank you so much.
Thank you so much. Being a leader, I thank you all. And at the same time, I tell everybody that, there is nothing 100% perfect, I know my shortcomings. I have found out certain shortcomings which we could have covered up. And so the next program would be still better. That is what I feel. With these words, I thank everyone and Jai Hind, and we conclude this EPIC 2022 and all the best to and the entire PGs and those also who didn't attend. They will be seeing the proceedings of the program here and they are definitely through somebody. I wish the best of luck to them also, and goodbye. Thank you so much.
Thank you. Thank you, everybody. Thank you, Dr. Umesh.
Thank you so much.
Thank you for being here, sir. Thank you.
Right.
Bye.
And thanks to the meetings and more people.
Yes.
Because without whom, the program would not have been that successful. Such a good, show of the events and everything, being presented so meticulously. Thank you, team meets and more. Thank you,
ma'am. It was flawless. Yeah. Your arrangement was very good. Thank you so much. Gurmeet and Shalu, the backbone of this program.
Thanks a lot.
Thank you.
We would like to wrap up now. We'll meet next year. Till next year, bye from EPIC 22 team.
Bye-bye.
you.